March 25, 2021, and we are getting started with our plenary session, the MSR oration. To get started, I invite the chairpersons, Dr. Harshit Parasnas, POGS President. Thank you so much for joining in early morning. We've also got Dr. Sunita Tandulwarkar, who is the MSR chairperson and a very well-known gynecologist right over there. We've also got Dr. Amit Patki, who is the medical director at Fertility Associates Mumbai. Thank you so much for joining in all the way from Mumbai. And we've also got Dr. Ashwini Kale, who is the POGS secretary. Over to the chairpersons.
Nirav, can you change the slides? Yeah. Can you change the slides, Nirav? No, Dr. Tandulwarkar's slides.
No.
A very good morning to everyone, and also good evening to Anuja Dokras, who is in United States, in New York. We start today's proceedings with the prestigious MSR oration. Yesterday we had a day full of academic activities and a very well attended conference yesterday. We crossed more than 2,000 logins yesterday, and believe me, we were a bit late, and even late at night, at nearly at 7 o'clock, we had 1,000 people who were still logged in. So that speaks volumes about the content of our scientific program. So let's start today's session on of MSR oration. It gives me great pleasure to introduce to you my dear friend and colleague, Dr. Anuja Dokras. She hails from United States. I'm just going to be telling you about a few things about her and introducing you to her. Dr. Anuja Dokras has earned her medical degree at the University of Bombay, India, with 2 prestigious scholarships, that is the Dorabji Tata Scholarship and the NCRT for her medical education. She received a gold medal in both biochemistry and obstetrics and gynecology. She then studied at the University of Oxford, UK as a Rhodes Scholar, where she received her PhD degree. Her thesis focused on development of techniques for pre-implantation genetic diagnosis, which is now offered as a treatment in conjunction with IVF. She subsequently went to United States and completed a residency in obstetrics and
Thank you.
and fellowship training in reproductive endocrinology and infertility at Yale University, and is now certified of obstetrics and gynecology and reproductive endocrinology. Dr. Anuja is currently a professor of obstetrics and gynecology, medical director of the reproductive surgical facility, and the director of the pre-implantation genetic diagnosis program, and the chair of the gynecology team of the Women's Health Service line at the University of Pennsylvania, Philadelphia, United States of America. She's also the director of the Penn PCOS Center, a multidisciplinary center providing care to adolescents and women at all ages with PCOS. She has published extensively with over 100 peer-reviewed publications with a focus on long-term cardiovascular risk and mood disorders in PCOS. Her research has been recognized and received awards at the national meetings, including an Early Career New Investigator Award at the American Society of Reproductive Medicine. She is the past president of the AEPCOS Society, an international society focused on supporting education and research related to all the aspects of androgen excess disorder. She is currently the Associate Executive Director of the Androgen Excess PCOS Society. She is the former Associate Editor for the prestigious Journal of Clinical Endocrinology and Metabolism and current Associate Editor of Endocrine Reviews. She has been selected to the best doctors in America for several consecutive years. She has mentored several trainees with 2 winning Best with winning 2 Best Paper Award at the ASRM Annual Conference. Her research has been funded by the National Institute of Health, American Society of Reproductive Medicine, and the Reproductive Scientist Development Program. So it gives me great pleasure to introduce, present before you Dr. Anuja Dokras to speak on the nexus of cardiometabolic and mental health. But before she starts her presentation, I would also request Dr. Sunita Tanduvarkar, the chairperson of MSR, to speak a few words about MSR.
Hello. Thank you. Thank you, Harshad. Before I speak about MSR, I would first like to give huge congratulations to Harshad, Ashwini, Chaitanya, and entire POGS team. The way they perform in entire year, rocking. They just did not bother Corona coming or going. Their academic program for the entire year were so amazing that thousands of gynecologists across the globe has always been there in each and every program. And as Harshad said yesterday, more than 1,000, even at 7:30 p.m., talks a large volume about the scientific content about them. Can we have that music off? Someone is running the music. Yeah. Secondly, Dr. Anuja, thank you so much. So COVID has given this opportunity to have, even for 20 minutes, flying from New York. I don't know, from your busy schedule, you would have accepted. So it became a feather in a cap of a series of POGS MSR orations to have Anuja as one of the orator. I just want to know all the people who have logged in. Probably they are not from Pune, from all across the globe. What is MSR? Is a Maharashtra state chapter of ISAR, which always have won the best state chapter awards. Dr. Amit Patki, our dynamic secretary, is with us. And me and Amit, Rishikesh Pai, Reshma, Nandita, the way we worked for MSR, it's not only academically ahead of all, but also from all-round personality, contains lot of enthusiastic, what shall I say, ART consultants, and also proud to say, most of ISAR presidents belong to MSR. Dr. Ashwini Kale herself is a treasurer, and 2 years, the way she worked with the finances is amazing. So those who are not MSR member, but are from Maharashtra, I humbly request them to become ISAR member and then the MSR member. Thank you, Harsha, for taking this MSR POGS oration in your this prestigious annual conference. I won't take much time, and I request Anuja to proceed with her oration. Everyone is eagerly waiting for.
Anuja, best of luck. So proud and wishing you all the best. And I know you are going to be one of the ASRM presidents in the next few years. Harshad has spoken a lot on Anuja, and Anuja is married to a very dear friend of mine, Dinesh. And best of luck, Anuja. I'm so proud to see where you are today.
Thank you. Thank you, everybody. Thank you, Harshad, Sunita, and Amit for that fabulous introduction. And I feel honored after hearing everything about MSR to have been invited today to give this talk. So let me start with, I'll just share the screen and let's make sure you can see my slides. Is that looking okay?
Yes, good.
All right. So what I decided to talk today was to tell you all a little bit about my journey, how I left India to become a reproductive endocrinologist and an infertility specialist. And as you heard, while I was directing an IVF program and setting up a pre-implantation diagnosis center, I became interested in polycystic ovary syndrome, wearing my second hat as a reproductive endocrinologist. And I'm going to sort of go down my journey of how we developed the story for both cardiometabolic risk and mental health in this syndrome. And I'm hoping that will be an inspiration to some of the younger members of your audience, as well as of your society, to emulate bringing together your own clinical works as well as research. Because as I look back at my own career, nothing would have been more satisfying than having taken this path. So when I started and got interested in PCOS, as most of you know, we knew very little about it in terms of counseling our patients about irregular periods, endometrial hyperplasia, and cancer. We spoke to them about hair growth as well as acne. And then, of course, as infertility specialists, we helped them get pregnant. But at that time, very little was known about mood disorders, pregnancy complications like preeclampsia or gestational diabetes, and even less about dyslipidemias and cardiovascular risk. And I was really interested in this syndrome because it's a fascinating enigma. We knew that there were androgen production from the ovaries, a little bit from the adrenal gland, and we knew that these androgens predisposed to increased obesity and in the visceral region, in the middle of the abdomen. What we now have a better understanding of is that these fat cells themselves are capable of converting androgens that come from an adrenal source and then contributing to what's called 11 keto androgens, so another alternate path of androgen production. We also know that these fatty cells are not normal in PCOS. They don't store fat in the same way and actually give rise to higher levels of free fatty acids as well as higher levels of markers of inflammation, and that's referred to as lipotoxicity. All of that increases the risk of insulin resistance, and the hyperinsulinemia then drives excess androgens again from the ovaries. So it is no wonder then that this population would be at a higher risk for what we call metabolic syndrome driven by insulin resistance. And metabolic syndrome is a condition which sort of picks up the very early stages. So early prediabetes, some dyslipidemia, some prehypertension, and then the obesity, which really is an increase in the waist circumference rather than standing on the scale. And so trying to identify metabolic syndrome becomes important because these women are the ones who are going to be at a higher risk for diabetes as they get older or cardiovascular disease risk. So we began this journey way back in 2005. This was one of the first slides that my resident presented at an ASRM meeting in 2005. And I think we were pretty bold to say our title was All Women with PCOS Should Be Screened for Metabolic Syndrome. And now, about 15 years later, this has been incorporated into the guidelines from the international PCOS guidelines that were published a couple of years ago. So as we look back, what did we say at that time? We presented data that said that women with PCOS are about at a 20-fold higher risk of metabolic syndrome. That was quite a dramatic observation. And so to try to understand better, we looked at the different age groups. So on this slide on the right, you can see the different age groups. And even in women under the age of 30, we found about 1 in 4 of them had metabolic syndrome, compared to just 0% amongst the controls. So very high risk of metabolic syndrome in a young population with PCOS. The next question we said was, is everybody with PCOS affected with this, or are certain phenotypes affected? And as you might know, there are 4 phenotypes amongst women with PCOS. Phenotype A is when they have all 3 criteria, the irregular periods, high androgens, and the PCO appearing ovaries. Phenotype B has the old NICHD criteria, so high androgens and irregular periods. And phenotype C is again the high androgens and PCO looking ovaries. So what we found was in the phenotypes A, B, and C, the risk of metabolic syndrome was increased, whereas in the non-hyperandrogenic phenotype, it wasn't as high. And again, that has come to bear over the years now, where we understand that the hyperandrogenic phenotypes are the ones at the highest risk for diabetes, cholesterol problems, and all the other metabolic issues associated with PCOS. And then we started looking at how early does this risk start? Does it start right in the adolescent time period? And again, I would always say be careful about making a diagnosis of PCOS in young teenagers. Make sure they at least meet the two primary criteria, which is irregular menses and high androgens, and wait for at least 2 to 3 years after menarche. When we followed those rules, we still found that the risk of metabolic syndrome was significantly higher in these young girls. And just to make a note that as I'm showing you all of these studies, the pictures on the sides are most often there are trainees. So they're either my fellows or residents who have been first authors for a number of these papers. And this was an interesting study that we then did looking at the risk of metabolic syndrome across 5 different countries. And so we used the US population in the first 2 columns. We had data from Dr. Sujata Kaur's patients in Bhubaneswar, and from Brazil, Finland, as well as Norway. And the risk of metabolic syndrome really remains pretty high in all patients with PCOS worldwide. And we've seen that as a consistent pattern. What was surprisingly different, though, is the components of PCOS, of metabolic syndrome. So for example, in the Black population, look at these pink squares. They're quite different than the pink squares for India, which means what drives metabolic syndrome in the US is obesity and high blood pressure. What drives metabolic syndrome in India is high triglycerides and high fasting levels. And this becomes relevant because you're counseling your patients differently compared to the way I'm counseling the patients that live in the US. The other interesting finding from this study was when we adjusted the risk based on both BMI and age, the findings were quite different, such that the Indian population was at the highest risk for metabolic syndrome, even compared to the US, and then followed by the Norwegian. And this becomes important because just the BMI isn't as relevant as the waist circumference. And I think that's where, with the central adiposity, even though the cutoffs for BMI may be different in India, it's that central adiposity that puts the PCOS patient at an increased risk for metabolic syndrome. And then the question becomes, so is your patient who is 20 years old and has metabolic syndrome, is she going to be at risk for the rest of her life, for the next 10 years, for the next 15 years? Or does it change with time? And we knew very little till recently, so we just completed a longitudinal study. I have been at Penn now for about 15 years, so I have this large cohort of patients that we have been following over time. And what you see here is 0 month all the way going up to 90 months. So over about a 7 to 9 year time period, we have looked at the trend in metabolic syndrome. And the patient who develops metabolic syndrome at a young age remains a high risk throughout that time period, and hence becomes an important target where intervention would help, and early intervention and aggressive intervention will help. So you might ask, what is the risk factor besides having PCOS? What is it about PCOS that puts these women at risk for metabolic syndrome and later will put them in risk for diabetes as well as for heart disease? So of course, one of the most obvious answers is BMI. And as the BMI goes up, you can see that the risk of metabolic syndrome goes up. What's even more important, though, is the testosterone levels. So as the free testosterone levels increase, those are the women with the highest risk for metabolic syndrome. And again, given the variability in assays, it held true much more for free testosterone rather than the total testosterone levels. And hence the corollary becomes that if we are able to drop weight or drop testosterone levels, will our patients do much better? And I'm going to come to that in a second when I talk about treatments. Let me just go a little further, though, to talk about, so what if they have all these risk factors? Do they really develop heart disease? And a number of groups now, and here we have 6 groups. The first paper here is from our group, have shown that women with PCOS and young women, as well as perimenopausal, have increased evidence of calcium deposition within their coronary arteries. And that really puts them at a higher risk for cardiovascular disease. So this was our study showing an increased prevalence of coronary artery calcium in women with PCOS compared to controls. And for those who may not have seen some of these scans, so these are CT scans looking at the heart, and the bright white resembles the calcium depositions within the coronary arteries. And in a young person, and most of our patients are under the age of 40, any evidence of calcium, so a score that's greater than 0 is still in the 90th percentile, putting them at high risk. So this becomes really relevant when you pick up calcium at such a young age. We were also interested, as you can all imagine, in what happens through pregnancy, because we're helping these patients become pregnant. And what is their risk through pregnancy if they have PCOS? We recently published this paper, and this was one of the prize papers in ASRM in 2019, primarily because we looked at a huge population, 42,000 women with PCOS, and then about 800,000 without. And this came from a large insurance data set. It's called Optum. And when we looked at women with PCOS, as expected, before they're pregnant, we've already gone over this data, that they tend to be more obese, they have cholesterol issues, high blood pressure, diabetes, and I'll come to depression in a second. But over these last 2 decades, we have more information now that during pregnancy, women with PCOS are at a higher risk for gestational hypertension, diabetes, preeclampsia, preterm delivery, which has been an interesting but repeatedly found finding, and then a higher risk, of course, for multiple gestation, a little bit because of the ovulation induction that we help this population with. What was totally new in this study was what happens in the postpartum period. So we do know that preeclampsia predisposes women with or without PCOS to cardiovascular disease when they get older. Gestational diabetes gives a woman a 50% lifetime risk of diabetes. But what happens with postpartum cardiovascular complications? So in this study, we found that postpartum preeclampsia, postpartum eclampsia are increased in the PCOS population. Similarly, DVTs and PEs are increased in this population. And what was quite amazing was peripartum cardiomyopathy. And there's just such little data about peripartum cardiomyopathy, but it looks like the PCOS population is at a high risk for this as well. And so these are important data for us to share with our patients as we help them get pregnant and make sure that they are in their best cardiometabolic health before pregnancy. So to summarize this part of the talk, women with PCOS have obesity. Unfortunately, it's an epidemic. And with the high androgens and insulin resistance, we know that they are at a high risk for a number of cardiovascular factors, premature atherosclerosis, and increasing data that they have the higher risk of type 2 diabetes, coronary heart disease, as well as stroke. So let's shift a little bit to what about the treatments for PCOS? When we treat our patients, are any of these treatments affecting their cardiometabolic risk? And by this, I'm referring to birth control pills, which are first-line treatment. And as you know, birth control pills will suppress LH and hence decrease androgens. They'll increase sex hormone binding globulin and hence decrease androgens. And so one would think that they should have a beneficial effect as far as metabolic risk is concerned. But what do they do in terms of our cholesterol levels? So cholesterol is broken up into the not so good cholesterol and the good cholesterol. So the not so good is the LDL cholesterol and the VLDL, whereas the good cholesterol being the HDL. And we did some studies looking at the function of cholesterol. And so cholesterol normally lives within the blood vessels, and too much cholesterol within the arterial wall is not good. It's HDL, which is going to move this cholesterol out of the arterial wall and excrete it in bile. And if one is able to move this cholesterol out well, which is known as its efflux capacity, then the risk of cardiovascular disease is lower. So we did some of these studies in young women with PCOS where we did their lipid panel. And as you can see, really no difference in HDL cholesterol, not a striking difference in LDL cholesterol, but when we look at the function of HDL cholesterol, we find that the function is reduced, and that's really key to trying to understand their long-term risk. Similarly, for the LDL cholesterol, I showed you that there wasn't much of a difference when we did a simple lipid panel. But when you look by NMR spectroscopy and you look at lipoprotein levels, then the VLDL numbers are much higher in PCOS. The small LDL molecules are much higher, and these are the ones that cause atherosclerosis. So the question then becomes is if women with PCOS have dyslipidemia, what is going to happen when we treat them with our first-line treatments? And we had completed a study known as the OWL PCOS study, which was OCPs was the O and the weight loss is the OWL PCOS. And it was an intervention with overweight, obese women where we either engaged in lifestyle modifications, in continuous birth control pills, or the combination for a period of 4 months. And the final outcome was live birth and fertility. But when you look at this 4-month time period and ask the question, what happens to the metabolic risk in these women? Let's focus just on this very bottom here where it says metabolic syndrome. And the group that got birth control pills, their risk of metabolic syndrome went up. And it was driven primarily by cholesterol. As you see here, the triglyceride levels went up. Whereas in the other two groups, either with just lifestyle modification or the combination, there wasn't much of a change. So what is happening to these cholesterol levels when you give birth control pills to PCOS patients? The bad cholesterol, the LDL goes up, but the good news is that the good cholesterol also goes up, and that's because of the estrogenic effect through the liver. So a little bit of a paradoxical effect that is seen in this young population, and hence overall we might find that it might nullify between these two effects, and as long as they engage in lifestyle modification, the patient may be in a good place and not be harmed, especially if you do a low dose birth control pill. We also found that the efflux capacity, which is a function of HDL, actually improves with birth control pills, and it also improves with metformin. So in conclusion for this part, we know that women with PCOS have a number of cardiometabolic risk factors. They have evidence of atherosclerosis, and now there's emerging data for type 2 diabetes as well as heart disease. Why did I introduce mental health into this? And there is data to say that patients who suffer from heart disease have a higher risk of depression and vice versa. Those who have a high risk of depression also have an increased risk of heart disease. But the role of mental health in PCOS really comes when young girls suffer from depressive symptoms. They are unable to then engage in lifestyle modifications. They are unable to follow through with treatments for PCOS. And we're not able to help them get better because we are really not addressing their mental health. And that's how we got interested, pretty much a parallel story and a parallel journey. While we were doing our studies for cardiometabolic disease, early in 2007, we began to investigate the risk of depression in women with PCOS. And this was one of our very first papers. Dr. Hollenrich here in the picture also won a first prize for her presentation way back then at ASRM. And she showed that women with PCOS have a much higher risk of depression, an odds ratio of between 4 and 5 compared to the control population. And then the question was, do they get better after we make a diagnosis, after we counsel and treat them, maybe after they get pregnant? Maybe that's what was leading to the depression. But the longitudinal studies that we did also showed that persistent prevalence of depression, as well as a high conversion rate. And a number of groups over the last decade have shown similar results, such that we conducted a meta-analysis putting the worldwide data together. And overall, it looks like about 1 in 4 women will have depressive symptoms, and about 40% will have anxiety symptoms. And our meta-analysis was the one that then informed the position statement from the Androgen Excess and PCOS Society. And now the recommendations are that you should really screen all your patients with PCOS, at least at the time of diagnosis, for depression. So then again, the same question, why do women with PCOS have a higher risk of mental health disorders? And it's quite interesting that the same drivers and risk factors play a role here as well, such that BMI and testosterone turned out to be similar risk factors like we saw for metabolic syndrome. What was different though was even an FG score, just having a high FG score or the weight being higher was enough to give a higher risk for depressive symptoms. And hence we asked the question, is it something about their body image that then mediates the depressive symptoms? And we looked at body image distress in women with PCOS and really found that it played a significant role in mediating the scores for depression and mediating the scores for anxiety, which is good news because if we are able to improve body image in this population, perhaps we would be able to improve the underlying depression and anxiety. And so again, we went back to some of our data from the OWL PCOS study. To remind you, it had the 3 groups with lifestyle modification, birth control pill, and the combination. And we asked the question that in the population that was on the birth control pill, what happened to their depression scores over time? And over the 4-month period, they did much better with the drop in the male hormones, much better with the weight loss, and then the same for the anxiety symptoms. And this was very reassuring data. However, when you have a large proportion of patients who just don't feel good, it's hard for them to then follow through and to follow a nutrition plan and a diet and engage in exercise. And so we conducted a study where we did a combination of cognitive behavioral therapy to help with their depression symptoms along with lifestyle modification. So that was one group. And then the other group was lifestyle modification alone. And over a 4-month period, looked at the effect on weight loss. And this lower line, which is the blue line, is showing an increase in weight loss. So they lost more weight when we did the combination therapy with cognitive behavioral therapy plus lifestyle modification compared to just lifestyle modifications alone. And of course, as you would expect, because of that, there was an improvement in both depression as well as anxiety scores. Again, suggesting that if we screen our patients for depression, then we will be able to diagnose it. And if we diagnose it, then we can recommend the right kind of strategies, even for lifestyle modification, rather than just recommending a diet or exercise plan, really trying to understand how can we improve their depressive symptoms and thereby improve their cardiometabolic risk. What was surprising is that this group of patients have other mental health issues as well. So high risk of eating disorders, and the prevalence was about 12% compared to just a 2 or 3% background rate. And this is not anorexia nervosa, right? So what they are at a higher risk for is bulimia, binge eating disorders, which all again ties into the weight management and the weight gain issues, which are such a challenge in this population. And then, of course, we looked at depression during pregnancy. So again, going back to the large Optum study where we had the 42,000 women with PCOS and then the control population, we found that the risk of perinatal depression as well as postpartum depression was very high in this population. So we've spent some time trying to understand what do our patients with PCOS really want in a syndrome that's so wide, right? We have reproductive health issues, we have metabolic health issues, we have skin and dermatologic health issues, and now mental health issues. And what are the patients seeking? And our surveys of patients who live both in the US and Europe showed that they were very unhappy with the care that they were receiving for PCOS, unhappy about their diagnosis experience. We surveyed physicians, both in US and in Europe, both OBGYNs and medical endocrinologists. A lot of them had confusion about the diagnosis of PCOS and what criteria to use. And then here is the last study is surveying trainees and our residents. And we found that they too were confused about the diagnostic criteria. So more specifically, when we asked our patients as to the information that they receive about PCOS, very dissatisfied about very dissatisfied about the information that is being provided to them. And that's why I think this is a great topic for a conference like today, because most OBGYNs, and even if you're fertility doctors, you're the ones who are making the diagnosis of PCOS. And it's really important that as you make the diagnosis of PCOS, you then talk to these patients about their long-term risk, about their risk in pregnancy, about their risk after pregnancy and through to menopause as well. Patients tell us that less than half the physicians give them information about long-term risk. Very few talk about mental health. And so in response to all of this, we brought together 70 specialists from across the world to develop what were called the International PCOS Guidelines. So these were evidence-based guidelines that were put together in 2018 so that all across the world, one can use very uniform guidelines, and everywhere there are some exceptions made based on race and ethnicity so that you can adapt it to different populations, as well as in terms of the workup. There are exceptions that are made or suggestions that are made in areas where there are limited resources and one doesn't want to do the entire workup. What is the minimum workup that one can get away with? So these guidelines, given their importance, were published simultaneously in 3 journals that you can see here. And what I do want to leave this group with is really, as you see these patients, because again, I think OBGYNs and gynacs are the group that are going to make the diagnosis of PCOS, that are going to help these patients through their fertility journey. But as you do that, make sure that you're assessing their weight at every visit. You're recommending at least a baseline glucose screening. And I think given the high risk of the Indian population, it may be more frequent than every 3 years that you need to screen this population. If they're going to be pregnant, maybe the screening instead of 28 weeks needs to be a little earlier at 24 weeks so that we can pick up gestational diabetes quicker. A regular check in terms of blood pressure. I would recommend a lipid screen even when they come in for fertility treatment and at the first level, and for sure a screen for depression as well as anxiety. And the beauty of it is our journey, we sort of went on this in parallel, looking at cardiometabolic risk as well as depression, but it has all come together now on a more genetic level. So there are 3 genetic genome-wide association studies that have been done for PCOS, 1 large one with the Chinese population, and then 2 with Caucasian populations in Europe and the US. And what they show us, and as you can see in this top graph, that there are about 14 variants that have been identified to be linked with PCOS. And these are the ones above the green line here. Next, what was done was an LD regression score to look at these different phenotypes and their association with PCOS. And these are the ones that show a very high correlation. And of course, as expected, BMI, insulin, diabetes, cholesterol, all of it seems to be associated on a genetic level with PCOS. What was even more amazing was that the genes for depression seem to be associated with PCOS, indicating that there's some shared genetic architecture and biology between these phenotypes and PCOS. So it's no wonder that what we have found and others have reported, the link between cardiometabolic risk and PCOS and depression exists in PCOS. So let me just end by acknowledging all the people who have helped me through this journey with respect to developing a clinical as well as a research PCOS program. And what you see here are my colleagues in the US at Penn, a number of our medical students, residents, fellows who have always been part of our studies, and we work very closely with the Department of Psychiatry as well as Cardiology. Our collaborators, both at the NIH and at Hershey Medical Center for our clinical trials. And here are a number of our international collaborators, and we have done a number of research studies, both with Dr. Sujata Kar as well as Durusha. But it would be remiss if I don't acknowledge my roots. So as you heard in the introduction, I did both my medical training at GS Medical College and KEM. And it was at the time when we were there that the first IVF baby was born in India, right? So that was a collaboration that occurred through IRR as well as KEM. And really that was inspirational for me. And when I went to Oxford, my PhD thesis was on trying to develop techniques where we could biopsy the trophectoderm and amplify for single gene diseases. And of course, we've come a very long way since then with the Human Genome Project and so many monogenic diseases now that we are aware of, that we really can prevent transmission of these conditions to the next generation. So when I then moved to the US, I hadn't done my residency in India. So I did my residency in OBGYN and my fellowship in reproductive endocrinology and infertility. And now at Penn, I sort of wear both hats. So I used to direct the IVF program for the longest time. I still direct the pre-implantation genetic diagnosis program. But then I wear my second hat as a reproductive endocrinologist and run the PCOS Center as well as its research program. So thank you again so much, Dr. Harshad, for giving me this opportunity to share my journey with your audience. I hope they're as inspired as I have been just fortunate to have these experiences across some amazing universities, amazing departments. I have had great mentors in my life, and I have tried to be a mentor to a number of young mentees so that they can pursue their careers in a field where, you know, we give so much joy to our patients with the beginning of life. So it's truly inspirational. Thank you so much again for this opportunity.
Thank you. Thank you, Anuja. I think your talk was excellent. All the clinical scenarios and a lot of questions come up on your mind. I think all of them were answered. A very interwoven situation that we are having when we have PCOS. So I think we need to thank you for actually clarifying and actually giving a clear idea about the disease. So thank you. And the second point which you rightly said is not only is what you have just talked of about your education and the way I think your career graph, that the way you went from institute, from a country to to Oxford, then to Yale, and now that you're in Penn, I think this itself is inspirational to a lot of our postgraduates and our doctors out here, that yes, you what you must pursue what for excellence. Pursuit of excellence, as you have actually shown here, is exemplary. I think this is going to be a benchmark, and also for all our viewers here, all our delegates here, you are going to be a role model for all my junior colleagues. And I'm sure you're going to be poured with a lot of requests for mentorship in the days to come. I will now ask Ashwini to give remarks before we give you the award of appreciation. Can we have the award of appreciation? Anuja, it is unfortunate that we are not able to give it to you in person, but it reads that Pune Obstetrics and Gynaecological Society at the 29th Annual POGS Conference, we are presenting this plaque to Dr. Anuja Dokras in appreciation of delivering the MSR oration, PCOS, the nexus of cardio, metabolic, and mental health. It's a very well-deserved award. Anuja, please accept this on our behalf. And next time that you are in India, we will in person hand it over to you.
Yes.
I think that should not be long.
That's right. Thank you so much, Harshad. And I accept this. And yes, we will do it in person rather than mailing it. I think that'll be special.
Thank you so much.
Harshad, can I say only one word? Anuja, you made a history, and this oration, which we have every year, but 2020 oration will remember for a long in the history of MSR. Thank you.
Thank you.
Thank you, Dr. Anuja. Once again, it was a very lucid and a simplified talk. It shows your years of hard work It's very easy to listen from here, but it really shows how much you've put it into it. And congratulations for the guidelines as well. Thank you once again.
All right. Congratulations on a very successful meeting and good luck for today.
Thank you so much. With that, I would like to thank the chairperson and the speaker for finishing this session right on time. Moving ahead, we have a panel discussion, and we have our moderators, Dr. Ashwini Kalaman, who is the POGS secretary. We've also got Dr. Rohan Palshetkar, who's also recently been awarded as the Asia Oceania Young Gynecologist Award in Manila, Philippines as well. We all know him very well, and he's joining with us as well. I request Dr. Rohan to please unmute himself. We've also got our esteemed panelists, starting with, we've got Dr. Anand Shinde, who's a senior IVF consultant and director of radiology at IVF Pune, Dinanath Mangeshkar Hospital, Pune. We've also got Dr. Reshma Rajbhog. She is the ICOG Fellow in Reproductive Medicine, Consultant Satara at Yash IVF LLP. We've also got Shrikant Yatmale, who is from Pune and is a senior consulting radiologist with more than 25 years of experience. I request Dr. Ashwini ma'am to take the proceedings further.
I think we have a few more panelists as well in the program. I think they've been missed out. Let me just quickly introduce them. I think we've introduced so far Dr. Anand. We have Dr. Rahul Veer and Dr. Ketki Patil Maske as well in the panel. I think till Dr. Ashwini just comes and starts sharing the screen, I would like to welcome everyone. And this panel is going to be a very clinical panel. What we would like to know is what you are practicing more on a practical thing in your day-to-day practice, rather than it being more about the research, because we all know that yes, research is important and it has translated eventually into our practice, but each one of us picks up a few points from the research topics and applies it in our practice to see what suits our patients the best, because we do believe in individualizing our concepts regarding the treatment, and therefore we'd really like to know from your personal experience what you are managing in your day-to-day practice. I think Dr. Ashwini is just putting up the slides in just about a minute.
Good morning to all the panelists and welcome to our POGS annual conference. It's really good to see you all online. And thank you for joining. Just give me a minute. Start with the screen sharing.
Do the panelists want to just check their mic once before we start off if their voice is being heard? Dr. Rahul, could you just...
Yes, yes. Good morning, all of you.
Good morning, sir.
Very good morning, all of you.
Good morning, Reshma ma'am.
Yeah.
Morning, everyone. Thank you, Rohan, for the introduction.
No. Anand Shinde sir was here. I just saw him. So your voice is muted. Can you unmute the mic? No, sir, we still can't hear you. I think on Zoom you need to unmute.
Hello.
Yes, sir, we can hear you now. Good morning, sir.
Good morning.
I think Shrikant Yatmale sir is yet to log in.
Kungalia madam is outdoor, sir.
Sorry, sir?
Dr. Kungalia, her picture shows her to be outdoor.
Yeah. So I think we're just getting logged in. I think there is a little bit of an echo.
So much data loaded in my laptop.
Oh,
I think that's but I just want to know, we've had a wonderful talk on PCO just now by Dr. Dorcas, Anuja Dorcas ma'am, and I think a lot of us must be getting PCO patients in our day-to-day practice as well, I'm sure. And I think till Ashwini ma'am comes, we can just discuss a little bit maybe on PCO itself, that how many of you are actually considering using adjuvants in your day-to-day practice, especially thinking of metformin or inositols in that manner? Kethi ma'am, can we start with you?
Okay. Yeah. Thank you so much. Yeah, so we do prefer metformin in patients with PCOS, especially patients with a little obese PCO with high AMH levels, and they respond very well with metformin. With myoinositol, I don't have as much experience, but then it is one thing which is we are considering to be adding to our practice. But yeah, we will. But metformin is definitely, which it's by rule now. We do go in.
Dr. Anand Shinde, any dosage you prefer particularly for metformin?
Any?
Dosage where you go up to
Dr. Rohan, hello.
How to start it?
Dr. Rohan, can you, the echo is coming from your end.
My end. I'm logged in only from one device.
Hello. Dr. Rohan, we prefer a sustained release, 1000 milligram twice a day. If the lady is little underweight, we reduce the dose.
That's right. Anybody else have a different opinion on regarding how to use myoinositols or anything, or the combination which has started now of metformin and myoinositols? Do you prefer using that, Dr. Rahul or Dr. Reshma? Would you like to?
I would like to use metformin and mannostol both, because both decreases the insulin sensitivity. And as sir said, 1000 milligram sustained release BD or 500 milligram TID. But we like to taper the dose. Like first we start with a low dose, and then after 3 to 4 days we increase big dose, so that the side effects if patient has, then she can take over.
Dr. Rahul, I wanted to just ask you that now you get drugs which are there with metformin and myoinositols in one tablet itself. Do you have any experience of using that?
I I think rather than using combination, it is always better to use metformin alone. And we start with low dose, that is 500 SR. If the patient tolerate well, then we continue, we increase the dose. And we see what is the BMI of the patient. And at least we have to continue at least for 3 months. The duration can extend up to 6 months, or when the patient becomes pregnant, but we have to continue it. That is my opinion. And we do not use combination drugs like metformin and other drugs. It is always better to use a single dose.
All right.
Single drug at present, rather than using combinations.
Absolutely. Thank you so much. I think Dr. Ashwini is ready with her slides.
Yeah.
Dr. Ashwini, ma'am, please.
Yes. So it's always a pleasure to moderate with you, Rohan. So as we all know that IUI is a first line treatment which is highly desirable for the couples and still easily accessible and practiced worldwide. It is accepted because of the simplicity, and still it's a good option in our countries. And in the absence of evidence, NICE recommended IVF over IUI 2 years after 2 years of unprotected sexual intercourse. High quality recent data in a well constructed study still suggests that biases against IUI procedure and in favor of IVF are invalid. So we directly move on to the first case, and I would really like to know what your clinical experiences are. This is a 29-year-old female who's been married for 2 years with primary infertility. There's no other male factor. She's been stimulated twice with increasing doses of CC, that is 50 milligram, 100, and then 150. But still there's no ovulation. So I would like to know from any of my panelists that what are you suspecting in this patient? Ketki, you would like to take it?
So if we say CC resistance, I would first go ahead with an AMH level for her, and first investigate her properly for an AMH before I start planning an IUI, and then I would go see if her tubes are patent or not. And sorry.
All right. So I want to know from Dr. Anand Shinde, sir, how would we classify CC resistance and CC failure?
Here to ovulate would be resistance if you go up to 100. Here to conceive would be CC failure.
Your voice is not clearly audible.
voice, sir.
Yes, it's better now.
Can you hear me?
Yes.
Yes, sir.
Can rise up to 150 cc. And if she still doesn't ovulate, it would be resistance. If she ovulates and doesn't conceive, it would be
Dr. Anand, sorry to interrupt. There is an echo coming from your.
can be done for that. Can be done for people.
Yes, sir.
Can you switch on to other faculty? It will be.
Yes, sir.
Would you want to take it? I mean, for all our delegates of logged in, I would want to know how do you differentiate between CC resistance and CC failure?
Patient who is not ovulating at all with a clomiphene citrate, it's CC resistance, and the patient is ovulating but not having conception, is a CC failure. So in this patient, I would like to go with a AMH, and we can shift to aromatase inhibitor or gonadotropin. As if she's a PCOS, I would like to go with a letrose, like aromatase inhibitor, and if not, we can go ahead with the gonadotropins, low dose gonadotropins.
PCOS and obesity in this patient, and maybe when you stimulate her next time, it would be an aromatase inhibitor. So now once you've shifted to an aromatase inhibitor, I would like to know from Dr. Rahul, what would your dose be?
2.5 milligram BD or 5 milligram for starting from second or third day for 5 days. That will be the dose. Okay. I will start with 5 mg.
Simplified form, what are the protocols for letrozole?
What are the?
Step-up protocol or the prolonged protocols with letrozole?
You can use it for 7 days or 8 days, but we preferably use for 5 days initially.
May I add
May I?
Yes, Dr. Resh.
Few studies have done in that they have used long-term letrozole for around 10 days, or a shift protocol like that. Okay, 5 days you use the letrozole 5 milligram OD, and then do scan. If less than 10 millimeter follicle, again you add for 5 days, and then again you can reassess with the follicular monitoring.
Right. But the dose there would be 2.5 mg BD. I would like to know, panelist, would we go ahead with drilling in this patient since we have diagnosed her as PCOS?
I want to go.
Does it still have a role?
No.
Before that, we can think of low dose gonadotropins.
Ma'am, can I just, Ashwini, can I just add one thing? In fact, with letrozole in 2019, there was one paper which had come up with a multi-dose letrozole trial where it was called the step-up letrozole, in the sense where you just increase the dose daily, and it had shown to have a good multifollicular genesis as well with a good pregnancy rate. So that's something which can also be tried in certain PCO patients as well.
Right, wherein you give 1 tablet on second day, 2 tablets on the third day. So it works really well, right? So now I'd like to know which gonadotropins would you be using? What is the type, the dose, or would you just start it randomly?
For IUI, basically any gonadotropin is with the same pregnancy rate, like menopausal or recombinant. So we can use anything depending upon the paying capacity. So no difference in the pregnancy rate.
We can start with low dose HMG, or if the patient is PCO, even with you have multi-dose option. You have vial of recombinant FHS, you can start from 37.5 and then daily, or you can start it from 6 to 7 days, and you can give the injections and see what is the response. Accordingly, you can adjust the dose.
So will you give it in conjunction with letrozole, or would it be only gonadotropins? And
no, in conjunction with letrozole.
Who give it on alternate days, or they call the patient every third day. So how would your protocol be?
It can be given on the conjunction with letrozole. I prefer small dose daily. If the patient is staying nearby, or she can take on her own.
Ma'am, we can do letrozole plus gonadotropins, low dose gonadotropins together.
Starting from the second day.
So starting from the second day.
Okay. And would you go in for a step down protocol when you are using gonadotropins for IUI, or would you directly start the patient on gonadotropins?
I would directly start her. If she's a PCOS, I would start her with gonadotropins and antagonist.
Okay. Right. So the take home message here would be start with the lowest possible dose of gonadotropins. Using any kind of gonadotropins would not make a difference in the live pregnancy rate, but HMG definitely works better in patients of PCOS because they already have high LH. And secondly, you have to give it daily, monitor the patient daily. That is important. You call all your patients daily for ultrasound and you do your own ultrasounds.
Yes, so I would do my own ultrasounds, but not daily. I would start on day 7 first. Okay, am I audible?
Yeah.
Yes.
So I would start with day 7 and then day 10 and 12. That's when I would scan those patients.
Absolutely.
Okay, but you would give them gonadotropins daily, right? And how do
yes.
you decide to increase the dose? Maybe Anand sir, you are audible now. I think we
Yes.
can hear you now.
Yes,
Okay.
doctor.
So, do you find any difference when you give gonadotropin daily or
Anand,
Still cannot hear you.
Anand sir, maybe you can remove your headset and see if it's working without the headset.
hello? Am I audible?
Yes, yes, now you
Yes,
are.
sir, much better.
Is there any difference between daily gonadotropin and alternate day gonadotropin?
So
I want to
Success
know
rate.
how do you increase the dose for gonadotropins? I mean, what is your deciding factor?
No, you can skip it if and continue with the discussion if I am not audible. I'm enjoying it.
no, ma'am, can I take that question? What Anand sir was asking was, would you prefer giving daily gonadotropins or alternate day gonadotropins?
Daily.
I would
Daily.
Yeah, in fact, the research
Daily is
also has
preferable.
shown, the research has also shown that when you're giving daily gonadotropins, your IUI success rates are definitely better than
Definitely better.
your alternate regimen.
alternate day.
Yes.
Yes.
Basically, it doesn't make sense where you just give random gonadotropins. You give it
Yes.
some on day 3 or day 5. It should always be daily. Start with 75 or any low dose, always give it daily. And the thing that you have to remember is that you have to monitor your patient with the sonography.
We have to monitor the patient. That is most important.
Yes.
Across.
I want to know that you have given your patient gonadotropins till day 10 of a cycle. Still, you do not see any dominant follicle. So, do you leave the cycle or you still have hope and you start increasing your doses or you change the gonadotropin? What do you do? And when you call it a day, I mean, when do you decide to stop it now?
Day 10, we would stop after day 10. I wouldn't go in pumping more and more and just waste of injections going in there. But so I would, that's why we scan at day 7 itself to see if are we going anywhere.
By 10, day 10 will be if there is no dominant follicle by day 10, then we should stop.
We should stop and
we should reconsider the
Is
treatment.
economic concerns are working here or are academic concerns working here? Stopping at day 10.
No, if there is no dominant follicle by day 10, it is no point in continuing the treatment. We might have to recheck the patient's clinical criteria and what are the hormone profile. Then we can start again with the second cycle.
And how do you counsel this patient wherein you have given her daily gonadotropin, so much of money has already gone, and on day 10 or day 11, you suddenly declare that now nothing is
No,
happening?
at the time of beginning itself, we have to counsel the patient that we are beginning with the gonadotropins. If she is case of PCOS and we are going for IUI, we have to counsel the patient initially itself that we are trying with the small dose. Sometimes small dose might not work. That we have to counsel in the beginning itself.
All right. And then when do you begin the next cycle? Is it the immediate next cycle or you would want to downregulate?
Downregulate her before the next cycle.
All right. And then again start with gonadotropins, right?
Yes.
So now coming down to the trigger, now that we finally got a dominant follicle, say on day 14. So I would want to know what is the size that you look at when you give her the trigger? Or is it just the size or you do your Dopplers also?
Yeah, ultrasonographic monitoring is very important for the trigger. Like if you are using CC, we can give a trigger at around 20-22. And if you are using gonadotropins, the size of 18 to 20 millimeter is okay. But and the perifollicular blood flow more than 3/4 of the follicle should be there. Even the RI should be around 0.42 to 0.48, and PSV more than 10. Usually suggests the follicular maturity, and at that time we should give a trigger. While and at that time we should also look for the endometrium, that is triple line, grade A endometrium with good flow, grade 3 to grade 4.
That is why it's very important to do our own scans, wherein you
Yes.
not only get the size of the follicle, but also for the blood flow, because that is how you would get a good mature follicle. So what trigger do you use in your practice? Is it 2500 recombinant HCG 10,000 or 2 injections of 5,000 to make it 10,000, or a
So
single?
we use an HCG.
Many studies have shown that there is no difference if we give urinary or recombinant, and 5,000 international unit is
5,000 is
sufficient to have a ovulation.
5,000 is sufficient.
So,
And in case if I have like 3-4 follicles, then do I use 2 injections or would one be enough?
One.
Okay, because there are many practitioners which feel that if there are many follicles, let's use 2 doses.
No.
So we have to remember your...
That time we are keep making the more prone for OHSs, I feel. More
We have
HCG we are.
counsel the patient before giving trigger if there are many follicles. That is most important.
Looking at monofollicular development, and that
Yes,
is why
because we should look at for the monofollicular development at present. That should be our aim first.
Exactly. So it doesn't make any difference whether what trigger you use. The thing is you could use any of the trigger. And in case if you find that the follicle has not ruptured when you do an ultrasound, say after 48 hours, then do you repeat the trigger? Is there any point in repeating the trigger?
No
No,
need.
no need.
We are not. We should not repeat
The
it.
cycle is anyways. So now if on that day of the trigger, the endometrium is still 5 mm, you do not see any Doppler flow. So what do we do on that
Ashwini
day?
ma'am, your voice is not very clear actually.
very soft, Ashwini ma'am.
It's no, it's cracking also.
Is it better now?
Yeah, better. Yes.
Okay. So I would like to ask, Ketki, maybe you can take this. If on the day of trigger, that is maybe your day 14, the endometrium is still 5 millimeters, there's no Doppler flow. Do you want to add any adjuvants at this stage? And what would you take as a cutoff for a thin endometrium?
I would say anything less than 6 would be my cutoff for a thin endometrium. And adjuvants, we do GCSF. We do inject it in.
You use GCSF in a patient of IUI on the day of your trigger?
Yes, we do, if it is that thin. But I wouldn't say, see, it is not that I would say at 5 mm, she won't conceive at all. But if the patient is affording and willing for an adjuvant, we do GCSF. Even sildenafil does the job for it in the next 2 days.
Ashwini ma'am,
Trigger.
Ashwini ma'am, can I just add one thing to this?
Yes.
Yeah. Your voice is echoing, I think. Yeah. So Ashwini ma'am, there's also one more trial which has just recently come out in fertile sterility in Jan 21. It's called the Amigos trial, where basically they saw that the gonadotropins, clomiphene citrate, as well as letrozole. Obviously, gonadotropins had the highest endometrial thickness, then came letrozole, and then came clomiphene citrate. But they also saw that even with a 5 mm endometrial thickness, they had live birth rate. So what they are saying is that just because of a thin endometrium, don't cancel a cycle. But I do understand in practicality, it becomes very difficult to explain to a patient that, oh, because they always come back to you, doctor, why didn't I conceive? What was the problem? And if you say, yes, it was thin endometrium, they're like, why would you do the IUI? So I think considering the research as well as the practicality, we need to find a fine balance. But I do believe that there's no reason to.
And
I would like to
add in like a triple layer endometrium. So even with
I would like to
you see a triple layer and there you go, you can just continue with that cycle. You don't need to cancel it at that stage.
Right. So basically, there's still no consensus on how thin is a thin
Yes.
endometrium. So if you still see good flow, maybe you can go ahead instead of going for a cycle cancellation. And as Rohan rightly pointed out, that there's no consensus yet.
And you should think that is it an end organ defect or is it due to the low quality of the oocyte? And then you can just go ahead with that.
So there is the association between endometrial thickness and pregnancy outcome in gonadotropin stimulated IUI cycles. This was a very large study, and the lack of significant difference in the peak ET between positive and negative outcome cycles may be due to non-linear relationship. And the objective was to determine if endometrial thickness can predict pregnancy outcome. So basically, in these cases, we rule out causes of thin endometrium, as you rightly pointed out, maybe your stimulation protocols, previous surgeries, endometrial injuries, or any endometrial pathology like a septum, myomectomy done, polypectomies, age. At times, you get an end organ damage where there's absent flow. So these are the various drugs for thin endometrium. So I would like to know if any of you use these in IUIs. I'm speaking specifically for IUI and not IVF.
No, we are not using.
I've used sildenafil, yes, for 2 days just before. So after trigger, if I see the endometrium is thinner, we've used sildenafil.
Okay, so maybe we can still use sildenafil. It still doesn't make any difference whether you're using oral gel or patches. Maybe it is the patient comfort and the cost that makes a difference. So I would like to know from any of you, do you do HSG routinely before you start an IUI, or would it be a hysterolaparoscopy?
It will be depending upon the patient's age, duration of the infertility, and referral status, how many cycles she has done before.
Yes.
It should be in cases who go for
we do our own sonosalpingos also. So that is one thing whenever so it's much more easier than sending out the patient to a HSG because it's done by a technician and you're not there. Here you do a live sonosalpingo and you know the tubal status yourself. So it's you're the best judge at that stage. So we do our sonosalpingos regularly before an IUI instead of subjecting her to a laparoscopy.
Very radical procedure, and the entire experience just takes back the patient. So it should be a tailor-made thing wherein you feel that only HSG would suffice. You can go ahead and do an HSG also. So Rohan, over to you for this second case.
Thank you, ma'am. So let's just jump straight into the case. We've got a 36-year-old female who's come to you with previous 3 failed IUIs at other centers. The semen analysis has showed a normal count and motility. How are you going to proceed? Anand sir, can we start with you?
Models tell us that age of the woman more than 35 is a very negative factor. So if the other center is good, you would counsel for moving ahead with other technologies rather than persisting with IUI. But you are within your scientific limits by continuing at your better center, while your center is a better center. 3 more cycles with a better protocol, called as HMG or FSC protocol.
Okay.
And maybe changing the way you treat semen, this way or that.
So I think, sir, as you're saying, it's very important to find out what is the previous history of the different protocols that are used in the previous cycle, and based on that, you want to decide. Also, now another thing is, as you can see, she's already 36 years of age, and you can see the study which is showing that as your age increases, your chances for clinical pregnancy rate and live birth rate are also reducing. Could I have the next slide, please, ma'am? So, what is your opinion, Dr. Rahul? Would you do another IUI, and what would you like to add on, if you would like to add on anything in this particular case? Let's take, for example, she's taken only oral ovulogens and gone with the cycle. So what would you like to do in this?
As the patient is 36-year-old, if the AMH has been not done, I will go for AMH first. If and she has still ovarian good reserve is there, and is, as you said, that she has only used the oral medication. Recombinant FHS or any HMG can do. Low dose HMG can be started, and it has definitely proven. And the study also say that with the gonadotropins, the results with IUI are better rather than the oral dose.
Yeah. Dr. Reshma ma'am, do you think there's a role of a diagnostic histolaparoscopy if the patient is willing for an IUI?
If previous reports show, is there any end organ problem like
unexplained infertility, as you can see,
or endometriosis or any end organ defect like adhesions or any infection, endometrial factor?
Ma'am, she has done an IUI at a regular center. They've not really taken a look at all these factors.
Then we should go ahead with the diagnostic
Histolaparoscopy should be the choice. If
extroverted fixed uterus indicates that she has a problem.
Exactly. So a clinical examination, I think, is also very important, and that's really going to make a difference as well. Ashwini ma'am, can I have the next slide, please? Yeah. So you've decided to finally go ahead with a fourth IUI. Dr. Ketki, as Dr. Rahul also has said that he's going to use gonadotropins, and since we all are going to be on the same page, before I ask you about a single or double IUI, I want to ask you, are you going to add an antagonist when using gonadotropins in this case specifically?
So it all depends on her AMH and if she is a PCO or
unexplained infertility.
Unexplained.
So
No,
her AMH is normal.
at that stage. I would just do a CC plus HMG, and that would be straightforward enough for that.
Okay, even though this is a fourth IUI, you want to do a combined regimen?
Again, as sir said, as Dr. Anand said, that previously it has been, you don't know what has been done previously, and if she's only on oral.
I'm telling you, previously there's no gonadotropins used. She's just been given oral ovulogen.
You're telling me to say antagonist.
No, I'm not. I'm actually trying to bring up this controversy of whether an antagonist should be used or should not be used.
If she has done with everything, then that's all we are left with. So then go ahead with an antagonist.
It should not be used.
If she is unexplained infertility, and if we are using all ultrasonographic guidance, then if we don't use antagonist, it is fine.
Okay,
because it is not going to increase the pregnancy success rate.
I'm just adding a little bit of fuel to the fire now. Let me just make this even more controversial. Now, it's known that 25% of all cases have premature LH surges irrespective. So you're talking about 1 in every 4 cases having premature luteinization. Now, this lady is 36 years old, undergoing a 4th IUI cycle. Again, I'm going to ask you your own opinion. Yes, studies say that antagonists may or may not help. There's no real improvement in the pregnancy rates. But now I'm talking about this specific patient, 36 years old, 4th IUI.
I would go, 1 in 4. So this is the 4th one, and that's where we will try to come back the LH surge then.
So the IUI is falling on Sunday. Antagonist has no role.
Thank you, Anand sir. Thank you. That was another thing where we always look at posting sometimes so that we don't have to get to the clinic on Sundays. But as a if you're practicing, please try to avoid coasting because that can affect the quality of the oocyte as well. Okay, I'm going to move on.
You're very true. It's very true in the fact that the cycle is in your control. When you have the antagonist in your hand, yes, you are well in coordination with your time schedules and the patient and everything.
Absolutely. I think that makes a big difference. Okay, now to the questions. Anand sir, single IUI or double IUI in this particular case? 36-year-old, 4th IUI.
If I am owning the center, it is double IUI.
Okay, sir.
I am on the panel on the center, then it is single IUI.
Fair enough.
So double IUI doesn't give more rate of pregnancies.
Single IUI. I would say.
Single IUI is a better thing. Double has no role.
Absolutely. Okay, Dr. Rahul, just tell me, single or double?
Single IUI.
Dr. Reshma?
Single IUI.
Dr. Ketki?
I would say double. Now, seeing it's the 4th one, 4th one, that's the thing. I would go, if it's a normal sperm count, I would always do a single, but it's the 4th one now. So
as I said, yes, absolutely. As Anand sir also said that, yes, whether you do a single IUI or a double IUI, the result per se may not change. But yes, considering this is a 4th IUI I personally would also think of doing a double IUI in this particular case only. If it's a regular IUI cycle where you're doing, I absolutely promote single IUIs only. But I think if this is her last attempt at an IUI, maybe you can try everything possible under the sun. How many hours post the trigger would you do an IUI? Dr. Rahul, can we get your opinion on this?
From 24 to 40 hours, we can.
24 to 40 hours. Dr. Reshma, do you have a different?
36 to 40 hours.
Dr.
Recent guidelines, one paper, it had showed 42 hours, but routinely we do at 36 hours.
Dr. Kirti?
I would say 36 to 40, but there was 40 or maybe 42, but there was when I was in UK and when we did a few IUIs, the maximum pregnancy rates we got were at 30 hours, 30 to 32 hours. So it all depends on probably the institute and the protocols they follow, but the highest pregnancy rate, because we did it, we had a paper doing it for just after trigger, and then one at 30 to 32 hours, and then another at 40 to 42 hours. But the highest pregnancy rates achieved were between 30 to 32, which is nowhere these days. We don't follow that. We always follow between 36 to 42.
As an andrologist, I have a question.
Yes.
Do the processed sperm live shorter inside female genital tract than the natural coitus? Because all this discussion is regarding sperm surviving till the ovum arrives.
Yes.
That is, so is it shortened lifespan after processing for the sperms? Can you answer this? Anybody from the panel?
Yes.
So, yeah.
Maybe. Don't go ahead. Go ahead.
No, please, Katie, go ahead.
Okay. So shortened than the processed pumps, of course, they lose their capacitation after 2 to 3 hours. So I would say 180 minutes is the time when once the sample is processed, it should be into the female's uterus.
In fact,
has the egg arrived by the time?
So in fact, that is the entire point where it is a little bit of a controversy, because some people are saying that the range of capacitation time is from 45 minutes to 180 minutes.
Yes.
So the problem is now, that is the next question which I'm about to come to, is how are you going to confirm? Do you confirm the ovulation prior to the IUI? So, and now, as you said, Sir Anand, sir, in fact, you've added more fuel to the fire of single versus double. That if the egg has not arrived at the first time of the IUI and you're doing a second IUI, say maybe 24 hours later, have you possibly covered the window?
Yes, that was the logic when we started out for double IUIs. But in practice, it has not sustained the hypothesis. It increases the pregnancy rate. So there is a fundamental question. Do you believe in your trigger, batch to batch, cold chain, and all that? So our rates are dependent on our drug supply chain. And if you believe in your trigger, then 36 hours is a legitimate expectation for ovulation to occur. So you give the trigger in the night and post it in the morning, a day later.
Possibly. Okay. So I'm just going to quickly review this case that generally a single timed IUI is enough, 34 to 36 hours post trigger. But I still think that whenever, as you said, I always keep a window of say 32 to 40 hours, I think would be a consensus, what all the panelists may agree to on doing this. There's really no need to confirm ovulation, but if you do, there's absolutely no harm in it. And in a few cases of male subfertility, a double IUI can be done. Ashwini ma'am, can I have the next slide?
We'll just add one quick thing. Maybe an LH surge test, like an ovulation test, would also help in case that there is no ultrasound facility. That is also one quick test where you can say.
I think that's a very good.
LH adds more to the confusion rather than any consensus. So might as well do an ultrasound.
Ultrasound.
To confirm it.
Obviously, that's the best.
Okay. Let's say, will it be back-to-back IUI cycles or wash-off cycles? Like in the sense that, say one cycle fails, are you going to immediately start with a second IUI cycle?
Consecutive cycles.
There are some studies that have showed that there is some beneficial effect on pregnancy due to previous cycles of gonadotrophin effect. But more studies we really should do on this. And so right now we are doing consecutive, but it should be properly conducted study to confirm this.
There's no with CC. I would say if there is a wash-off cycle, would be better. And with Letros, you could go consecutive. That is what was.
I'm just going to get back to the practicality of it. How many of you all would actually try a wash-off cycle if you've already started with an IUI?
No wash-off.
Genuinely, just asking you on a more practical basis.
Yes.
Yes, the studies do say that, but I think most of the patients that are coming to you are very anxious to conceive.
Yeah, and
There's
so
a
we
reason
use
for that, and
consecutive
we want to try and reduce the time to pregnancy as far as possible.
Yes.
How much ever you may say that all these, in fact, there's a study which says that if you are doing an IVF stimulation, in fact, it was just released in 2021 itself, and you do an IUI maybe in the next cycle immediately, the pregnancy rates increase. That when you're doing a frozen embryo transfer and you've frozen the eggs and you just do an IUI in the middle, and then if it comes negative, you think, but they've seen that in the IUI, immediately post the pickup, there have been good pregnancy rates.
Yeah.
So in that way, maybe the drugs which you're giving could help, but in practicality, I don't think any of us are really using the wash-off cycles. We are actually ending up doing back-to-back. Okay, there's a day 2 cyst. How do you down-regulate? Or if there's a day 2 cyst and you still want to continue, how are you going to start?
A2 is below 50, is non-functional. You can proceed as usual.
You can do day 2, yes, as the sir said, day 2 E2 will be better. It can guide you how to proceed.
Dr. Reshma?
If the cyst is less than 2 centimeters, just we go ahead. And if it is more than that, I'll use low-dose OCPs.
Dr. Ketki?
If it is a luteal cyst, of course, now then I would go for an antagonist cycle where I would prevent the premature LH surge.
So we're getting back to the antagonist. Absolutely. Anyways, now case 3, I'm going to hand it over. I think the statements are very clear. I think it's an individual choice whether to go for back-to-back IUI cycles or to go for wash-off cycles. I think everyone on the panel has come to a consensus that they would go for back-to-back IUI cycles, especially if it's an advanced age like this where she's 36. I think it's important that we reduce the time to pregnancy. And in a washout cycle, if you give a patient break, as you all said, they can conceive spontaneously if you just give them enough time. But most of our patients do come with that anxiety of trying to conceive. So I do understand why there's a reason for a back-to-back cycles as well. For the next case, I hand it over back to Ashwini ma'am.
Thank you, Rohan. So now we have a 38-year-old male who's being referred to you for IUI. The trigger has already been given. The couple comes to the center, but the male is not able to produce the sample. So what next? I think Anand sir can take this.
You should design your center in a male-friendly way. The centers have all female staff. A lot of noise puts them off. You should be allowed to take their mobile phone with them inside the collection room. And you should have a proper scientific vibrator inside the room with proper instructions. Because the vibrators used in many centers are very crude. They are nothing more than massagers. So proper vibrate brand regulator will be helpful. And this retrofit ejaculation and all these things should be ruled out beforehand only, because it is too serious a matter to subject the couple for IUI with a case of retrofit ejaculation where you have to process the postcoital urine in an alkaline way. It needs some preparation. So all these things should have been ruled out beforehand, and no couple should be posted for IUI before the man has tested your IUI room, been successful in producing one sample for your pre-IUI semen analysis. It gives you an idea how is his sample, and does your room work for it.
So counseling definitely plays a very important role in this. So ejaculatory dysfunction could be at times stress related. There could be a lot of performance anxiety. So you can just counsel and calm the patient or try sildenafil or maybe a home collection with a proper consent would be a last resort. So I would like to know from any one of you, within what time of semen preparation should the IUI be done? And should the sample preferably be prepared in-house?
Yes, sample should be prepared preferably in-house, and around 40 to 80 minutes we should from the time of collection to the IUI procedure. 40 to 80 minutes.
Preferably be done within 60 minutes, exactly, because
Within an hour.
sperm quality starts hampering. And that is why we prefer preparation of the sample in-house rather than collecting at one place, preparing at the other, and doing the actual IUI somewhere else. So at the time of IUI, I would like to know quickly from Dr. Rahul, you're not able to negotiate the OS and the patient is too desperate to do the IUI. You cannot cancel it. So what do you do now?
Before doing IUI, as we all know that we should do transvaginal sonography that we are doing routinely. So you can see what is the uterus anteverted, retroverted, and by that you can do IUI. If you have the scan machine, you can shift it to IUI room and do under UAG guidance.
Right.
But you should not use dilator and thin anything.
May I add one more thing here, Ashwini ma'am?
Yes.
Another thing what you can do is you can fill the bladder as well.
You can
Pinch
fill the bladder.
the axis so that you can get a more straighter axis as well. Obviously, dilators and tenaculum, avoid dilators absolutely in an IUI. Maybe you can hold the sponge with a sponge holder, the cervix to straighten the axis.
The uterus cervix.
Yeah. You can always use a slightly hard catheter, more firm catheter
Rigid
to
catheter.
an IUI, rigid catheter. And in very difficult cases where nothing is working, maybe you can even think of doing an intracervical insemination, because there are studies which have showed that even a intracervical insemination can improve pregnancy rates if you do it. In fact, I have one patient who had just delivered a couple of days back where we had done an ICI because her cavity was difficult to negotiate.
Right. So always make a note whenever you do this. Maybe it is just the position of the uterus, or you can even think of doing a hysteroscopy before your next cycle, or by doing a mock on the day of the trigger. So quickly from any one of you, pain after IUI, reflux?
I'm sorry to interrupt, but
Yeah, just give me 2 minutes and we'll wind up with this case.
If there is a,
What if there's pain after IUI?
if there is a pain after IUI, then there might be a problem in the sample preparation, infection. Reflux, the procedure should be slow. You should count at least 30 seconds when you are injecting the semen sample. I think rest after IUI is not increases the chance of success rate, but it psychologically to the patient, it definitely benefits. Head glow is absolutely not needed, and we can resume the routine activity.
Right. I think due to lack of time, we'll have to stop here. Thank you so much, Rohan, for being my co-moderator, and thank you all my panelists for being here.
Thank you.
Thank you.
Thank you.
Thank the moderator also for finishing it right on time. Thank you so much.
Ma'am, thank you, and Harshat sir, thank you for the opportunity as well.
Thank
Yes,
you so
thank
much.
you.
Meanwhile, we've got the keynote address which is coming in.
We enjoyed it.
To invite
Rohan.
the persons to please unmute themselves and also switch on the camera. We've got Dr. Milind Dugar sir, who is the Vice President POGS. We've also got Dr. Pankaj Sarade, who is the upcoming Vice President POGS. We've got Dr. Prakash Kothale, who is the Treasurer POGS. I request Dr. Prakash Kothale sir to please join us as he is present with us along with Dr. Pankaj Sarade as well. We've got our first speaker, Dr. Sanjay Gupta sir. He's also with us. He is the ex-honorable associate professor at BJ Medical College, Pune, director, Gupta Hospital and Center for Research in Reproduction, and he is a gentleman with a charm. Welcoming Dr. Sanjay Gupta sir. As of now, we've got approximately 2,000 people who have logged in, approximately from 30 countries. That's the current update.
Very good morning to everybody. It's indeed pleasure to chair the session where stalwarts like Gupte sir, Shailesh Puntambikar sir, and Dr. Jatin Shah are going to present. It is my indeed proud privilege to call Dr. Sanjay Gupte, who needs no introduction to at least people in India who are practicing OBGYN. He has been president of Oxy and he has been mentor for many of us in Pune who are working now in POGS.
Hello, Nikhil, sorry to interrupt. Hello.
In terms of GDM in obstetric practice.
Hello.
Thank you, Milind.
Hello, Nikhil, can you hear me?
To all out there, it's a honor and privilege to present this presentation in front of all of you. And, the topic is very close to the heart of probably all obstetricians. And I'm very happy that Dr. Harshad, who is the president of POGS, has chosen this topic because all the obstetricians are going to be really wondering what this relevance is all about. So let's start with the talk itself. Well, for a long time, there were two questions which remained unanswered. Why to diagnose GDM, and is there any use of treating GDM? The hyperglycemia is always important in pregnancy, but the actual importance of this was proved with this large prospective observational study of around 25,000 women in 9 countries, the so-called HAPO study, which proved the association between the raised sugar levels and adverse pregnancy outcome in GDM. Whether treating GDM makes a difference. The Australian study, the so-called ACOI study, was a double-blind trial to determine whether treatment of GDM reduces risk of perinatal complications. And this study, along with the famous MFMUN study, proved the usefulness of treating GDM. Well, we all know that there are many adverse outcomes due to GDM: increased perinatal mortality, preterm birth, preeclampsia, postpartum hemorrhage, birth trauma, neonatal complications, and of course, subsequent development of type 2 DM later on in life. Well, if we look at the global scenario, what do we find in most parts of the low and low middle income countries, which, by the way, contribute to 85% of the annual global deliveries? The majority of women are either not screened or improperly screened for diabetes during pregnancy. These countries actually account for 80% of the global diabetes burden, as well as 90% of all cases of maternal and perinatal deaths and poor pregnancy outcomes. Well, there is a lot of confusion out there. Global healthcare organizations and professional bodies have advocated plenty of diverse algorithms for screening and diagnosis of GDM. Unfortunately, even the endocrine, diabetes, and obstetric association within particular countries often use diverse protocols and cutoff values for screening and diagnosis of GDM. They were developed based on 10 years data, expert opinions, and economic considerations. This created confusion and certainly uncertainty among the care providers. Even WHO, as late as 2018, was not very clear about the screening. And what the website said was WHO currently does not have a recommendation on whether or how to screen for GDM, and screening strategies for GDM are considered a priority area for research, particularly in LMICs. Even RCOG has its own recommendation, probably which suits their own country, and they say that 75-gram glucose, as per the criteria of IDPSG, that is International Association of Diabetes Pregnancy Study Group, and the screening is to be done between 24 and 28 weeks. So, somebody had to take the lead, and Dr. Sheshaya, who is the founder patron of DIPSI, the Diabetes in Pregnancy Study Group in India, did a pioneering work in diabetes in pregnancy in India and found that prevalence of diabetes in India was 16.55%, and even in rural India, it was as high as 9.9%. So through DIPSI, it was decided that we must take the lead and create our guidelines. So we started doing that in 2008, 2009, and 2010, we were ready with our recommendations. So the recommendations were all pregnant women in community should be tested. So there should be universal testing. The test should be as early as possible in the first trimester, and again in the second trimester between 24 and 28 weeks. The test that is to be used is a single step test, measuring plasma glucose 2 hours after 75 glucose dissolved in 300 ml of water, irrespective of last meal, whether fasting or not non-fasting. And this was important. And if the lab was not available, then standardized glucometer could be used. And the cutoff value was 140 milligrams or 7.8 millimoles for GDM. What were the advantages of this test? Pregnant women need not be fasting. It causes least disturbance in the pregnant woman's routine activities, and it serves both screening and diagnostic procedures. So this single step procedure is now approved by the government of India, WHO, and even FIGO. And how did it happen? And this is where the FOXY impact was. In 2010, we insisted on the government of India, and that was our first contact of this kind with the government, and they readily accepted the recommendations that we gave regarding the DIPSI test. And not only that, the FOXY at that time, in 2010, we came out with the guidelines for GDM and diabetes management in our country, and that was again readily accepted by the government of India. So the government of India guideline in 2014, which came out, now accepts practically all the issues that we put forward for through DIPSI and FOXY regarding the screening and treatment of gestational diabetes in pregnancy. And government, even for EMOC and various PSCs, this is to be followed, and these guidelines have gone far and wide to all corners of the country. So government of India is fully accepted and supporting the DIPSI FOXY recommendations. So nobody should have any hesitation now in accepting the one-step DIPSI test screening and diagnosis of GDM in our country. And this took a while because an endocrinologist, diabetologist took a while to accept this case for pregnancy, and that was a really good work done by DIPSI and FOXY. So FIGO also now in 2018, Dr. Hema Divakar is on NCD committee of FIGO, and with lot of efforts to DIPSI, and FIGO now has accepted, though they are still sticking to the IIDSP criteria for all the developed countries, but they have become now more pragmatic, and the pragmatic approach of FIGO says that universal screening should be there. All countries have an obligation to implement the best GDM testing and management practices they can. And that means, they allow the LMIC countries to follow the, DIPSI test. And FIGO acknowledges that global progress to be made, India, China, Nigeria, Pakistan, Indonesia, Bangladesh, Brazil, and Mexico must be key targets for focus GDM attention. So what is the relevance of all this, for our individual practice? And that is what, now I'm going to, come to. And this is where I'm going to tell you something about, our own statistics. Through FOXY and initially DIPSI, we advocated that there should be DIP clinic, diabetes in pregnancy clinics in all the obstetric hospitals, which have not only gynecologists, but diabetologists, nutritionists, physiotherapists, and counselors on board for that clinic. And these patients should attend these clinics regularly. So from 2012 to 2021, we have seen 21,134 patients. Out of them, 1,691 were known diabetic cases, and OGCTs were done in 1943. What are the findings? That in 75% patients, the OGCT came normal. Then in 14%, it came between 120 and 140, which we had started calling gestational glucose intolerance. Now, to accommodate and simplify, in national guidelines, we have not kept this GGI, and even FIGO guidelines, we have not kept this GGI as a separate entity. But I'll tell you, and as you see the statistics later, I still believe that GGI should be noted by the obstetricians in their practice because it matters. And I'll in a moment tell you how. So we had 10.59 patients who were above 140, and out of that 198 turned out to be an actual diabetic. So if you look at the GDM patients 2060, GGI to GDM conversion was 8.98, almost 9%, and that's where the importance of noting down the GGI also matters. Then GDM patients delivered at our hospital were 1706. GDM patients yet to deliver are 70. There are dropouts. Maybe they didn't like us or went out of town for delivery at the mother's place. So 13% were dropouts. Then out of the GDM patients, out of 2060. First trimester, raised OGCT was seen in 588, that is 28.54 patients. Second trimester, 53.35 patients, which is to be accepted and expected also. But important point is in third trimester also, 18.11% detection rate is there. And this is again very relevant to our everyday practice. So if you look at importance of screening in the first trimester, first of all, what do we find? That 91% will be detected in the first trimester, and out of that 49 or 8.33%, actually we found that they were already, their level was already about 200. That means they were probably diabetic, but not detected till then. And that's again the importance of actually screening them as early as possible with this particular test. Then if you look at the second trimester, of course, some come late and so they're booked late. So 309 were out of 1099 were such, and converted from GGI in the first trimester to GDM in the second trimester. As I said, the importance of noting GGI again is 128 patients, so 11%. And who were normal in first trimester and got converted to GDM were 60% or 662 patients. Then third trimester, and this is where I again would like to emphasize that third trimester is very, very important. There are, of course, patients who came late to us were 9.12%, so they were booked late, converted from GGI in the first trimester to GGI directly in the third trimester were 7.7%, converted from GGI in the second trimester to GDM in the third trimester were 7.5%. And most important, so those who were normal in the first and second trimester, but got converted in the third trimester were as 282 or 75.6%. So if you do not again test in the third trimester, then we are likely to miss these patients. And these are the patients who end up with sudden stillbirth. And we wonder, I had done OGCT and that OGCT was normal. And what happened, suddenly to the patient. So it's very important that we again check this patient, around 34 weeks with OGCT. Right. What is the other importance? Of this is the treatment given to the patient in our DIP clinic. And of course, 36 did not attend our DIP clinic out of 2024. They may be going to other clinics or they were doctors themselves, and that's why they treated themselves. But patients treated with oral hypoglycemics. As you can see, we use either metformin or acarbose or metformin plus acarbose, and you find that 31% can be treated only with metformin. Then the rest 20.8% needed metformin plus insulin, acarbose plus insulin, or acarbose, metformin, and insulin. So, if you treat with OHA, we find that actually you can reduce the use of insulin to a great extent, to a great extent. So it's important that we start using that. I will, if time permits, I'll discuss when to use actually acarbose and when to use metformin and what are the advantages and disadvantages of that. Again, finally, distribution characteristics of the GDM patients. We know that there are some risk factors, age, but if you look at the age, only 10% were above 35 years and more. If we worry about the, traditionally about the BMI, but in our country, the BMI is not always high when we talk about gestational diabetes. So we have to note that PCOS is significant. The history of PCOS, known PCOS, and there was many who had irregular menses, but we did not have adequate evidence to say that they were PCOS, and that's why we have put them into separate categories, but probably they were also PCOS. And GDM in previous pregnancy is important, but most important point in our country seems to be the parents, one of the parents with gestational diabetes, and history of IUD in previous pregnancy, intrauterine death, and of course, abortion in previous pregnancy also is important as a risk factor. And the final slide, look at the neonatal outcome. We always talk of, and give importance to macrosomia, and that is what we find in Western countries. In our country, FGR or PG, the FGR plus preterm, RDS, all these things are also very important. And LGA were, of course, significant, 139, large for gestational age. But, what we have to look at, and this is one sort of message I would like to give, that any patient who has GDM with, actually less birth weight is more of at risk as far as the baby is concerned than, one who is having macrosomia. Not only that, if in the third trimester you find that the requirement of insulin is reducing, this is the patient who is going to give you trouble. Don't be happy saying, okay, now I have to use less insulin and so on. So finally, what are the take-home messages, and so again, what is the relevance of this? Gestational diabetes is vital to our obstetrics practice. Universal and early screening is important. To screen as early as possible. DIPSI test is the simplest one anywhere that can be followed. The gestational glucose intolerance, especially that is GGI, is also to be noted and not missed out on. Third trimester testing should not be avoided, and precise blood sugar control will reduce complications. MNT and oral hypoglycemics helps us in reducing insulin use, which improves patient compliance. And traditional risk factors of GDM need second look. That means, as I said, BMI and age and all that. In our country, it's definitely different. And we worry about macrosomia, but if FGR is more trickerous. So look at all these points, and I think that will give you a different perspective of the GDM cases that we have in practice, and we'll be able to reduce mortality and morbidity. Thank you so much.
It was a wonderful presentation, giving crisp messages, very clear. You're a great academician, sir, and a wonderful teacher.
Thank you, sir. Now I will introduce Dr. Shailesh Tambekar, sir. The list of academic award for Dr. Shailesh Tambekar, sir. He has a patented technique of radical hysterectomy, that is Pune technique of laparoscopic radical hysterectomy. He conducted India's first successful laparoscopic assisted uterine transplant. The baby girl was born on 18th of October 18. He's the only Indian person who has board member in AAGL faculty as well as member of AAGL Oncology Committee. He has the largest series of laparoscopic endoscopic surgery and robotic surgery. He received the Golden Telescopy Award from AAGL, and the list is not ending. So lots of award he received. I request Dr. Pundamkar sir to talk on bowel injuries and endoscopic surgery.
May I request Dr. Sanjay Gupte sir to come on stage and accept this small token of appreciation?
Till the time presentation is ready,
Till the time presentation is ready,
Shailesh.
I can tell one thing about Shailesh.
Sanjay
Shailesh आपला संजय दृष्टीला एक मामा होता.
So all the other surgeons will first dissect and then they'll tell you that this is uterine artery, this is internal iliac. Sanjay will, Shailesh will first tell you in a minute I will show you uterine and then the uterine will come there. The stage is yours, Shailesh.
Good morning, everybody. At the outset, I should thank POGS, but especially Harshad, because it's after 1 year that I am wearing a suit and coming here. So thank you, Harshad, for allowing us to dress up and come because it's been a long time. And also thank you all the chairpersons for such kind introduction. And it is always a pleasure to follow Gupte sir because of a stalwart, being a stalwart in that particular field. So I'll try and make this presentation. This is about something which is bad work, which you go around and do it. But if you want to prevent bad work, what will you like to do? This is the incidence. It is just very less. And the incidence is quoted is very less. That is because majority of the times it is less reported. So finally, if you want to do anything good, it is most important, and I still believe that it is about anatomy. And you should have something what is as predictive anatomy rather than managing the complications. If you can prevent a complication, that would be a better alternative. So the first thing that we have always been teaching to people is fat belongs to the bladder, fat belongs to the rectum. And this is the principle with which the anatomy should be done. So you see, this is the fat. If you remain above the fat, you should always remember that anatomy doesn't change. It is your perception about anatomy that changes. So when you want to do a rectovaginal space dissection, which is where the bowel injuries take place, it is always better to remain above the fat. There are two layers of non-bilious fascia, and you should always try and go between the two layers. You can see very clearly. So fat belongs to the rectum was considered as bad English when we published it. So it is published in apostrophe, but this is the best way to describe how you should do the dissection. And now look at this similar picture, but now in such kind of picture with stage 4 endometriosis, don't believe that something is wrong. The anatomy is the same, and you don't have to use any big energy source. Just remember, fat belongs to the rectum, and just go above the fat. And as you go above the fat, you will start unraveling majority of the part. As you can see, this is the fat, and no use of energy source, but pure strict adherence to what we call as anatomical principles. You can see the rectum being pulled away, and there you can see the fat very, very closely taking adherent to the ovary. So again, you see this is the ovary. Fat belongs to the rectum. Just follow the principle. It is not about treating bowel injuries. It is about preventing bowel injuries. And these are the principles. If you follow, then you will find that without any energy source also, you should be able to prevent the bowel injury. So this is how I feel this is important. Similar case, completely large uterus, completely adherent large bowel, and you will see that as we go along the large bowel, you put a myoma screw. Again, don't use any energy source. Just follow the principle. Fat belongs to the rectum. And slowly and steadily, you will see that you will be able to do this very, very nicely. Similarly, you can see when you want to do the dissection of the small bowel, a lot of people use lot of energy source. I always teach my residents never to use the energy source. Now look at this small bowel completely adherent to the anterior abdominal wall, because whenever there is bleeding, you will immediately take care of that. But whenever there are later injuries, vascular injuries, because of the various avascular things that take place because of energy, then it takes a problem. So try and do everything without. Now look at this, completely adherent to the anterior abdominal wall. Look at the fat. Just remember, fat belongs to the bowel, and with this, you can keep on dissecting this. So you can see the small bowel very nicely going there. Don't enter into the extraperitoneal space. Just do the dissection very, very cleanly, nicely. No use of any kind of energy source. The best of the energy source also can cause lateral dissemination, and therefore prevent it just by using simple techniques like this. And these are the measures that you should be taking when you want to do or prevent any kind of dissection. So look at that. Traction, counter traction is the name of the game, and fat belongs to the rectum. Strict adherence to the anatomy. These are the measures that will prevent any kind of injuries. So you can see the small bowel slowly and steadily being separated from the anterior abdominal wall. Again, you see this is a very high risk patient where you can get a small bowel injury which will go unnoticed if you use a harmonic or bipolar current. So if you use just plain simple scissors, just cut it with the scissors. If there is a bleeding, you will take care of the bleeding. That is going to kill the patient. But a bowel injury which is going unnoticed may kill the patient at a later date. So don't use any kind of energy source. Just keep on going. Just keep on going, and you will see that slowly and steadily you can still go ahead and do a complete removal. So these are the principles with which you should try and avoid any kind of bowel injury. Never go in the extraperitoneal space, because that is again a mistake. Here the bladder and the bowel are very closely adherent to one another. So be careful. Just remain above the fat. There are no vessels above the fat. These principles you have to understand, that there are no vessels, and even if there are vessels, they are very small vessels. So just go there and do the dissection. These are simple measures for preventing this. But in spite of that, sometimes you can get this. Now, this is a patient, simple hysterectomy done by my resident. And just when we were about to take out the uterus from below, you can see a small amount of shit coming out of there. So immediately go ahead, do this. You let the uterus remain there. Just go ahead and find out where the hole is. And then it is very simple. Closure of the entire wound should be done in 2 layers. What are the principles? A lot of people ask me, when should I do a colostomy? The colostomy, very simple principle. If there is more than 5 centimeter damage to the large bowel, never rely on the best suturing that you have done. Go ahead and do the suture. Go ahead and do a ileostomy or colostomy. So this is what you can see. We have done a 2-layer closure, simple 2-layer closure. But after doing the 2-layer closure, it is very important to do this leak test. This is the leak test which you should always perform, no matter how well you have done the dissections. Fairly simple, easily done, no evidence of leak, just 2 centimeter, and we should go ahead and do this. After this, but then situations like this can happen. This is a patient of endometriosis that we had done, and the drain had gone and perforated the large bowel. So you see on the 5th day, the patient presented with peritonitis. And when we went inside, we saw a drain going and entering into the anterior wall of the rectum. It is not the drain which has caused the mistake. There was literally a serosal injury, which probably we missed. And through the mucosa, the drain went inside and then got this perforation. So this perforation, then once you detect the perforation, this is a second surgery. We close the perforation. But again, you see the perforation was just 2 centimeters, and therefore she did not require an ileostomy. But when you have this kind of rectal injury, now this is a rectal injury because of callous nature of our assistant, who at the end of the surgery kept on talking to each other, and the instrument remained inside, and they were discussing something about the next day, and the instrument tore the rectum completely on the anterior abdominal wall. So we have put a rectal probe from below. You can see that. Then we put the drain, because we don't know which is the anterior wall, which is the posterior wall. We put the drain, and then we sutured it. Now, when you want to suture this rectum, fairly simple. You can see we have sutured it in 2 layers. But these are the patients whom you will have to do an ileostomy. So a lot of things keep on, the gynecologists or surgeons also keep on asking me questions. See, the suturing looks good, everything looks good, but more than 5 centimeter, we covered this patient with ileostomy. So majority of the complications also occur during the entry of the abdomen. So I will show you a surgery which was done like a rectovaginal fistula following a vaginal hysterectomy. Now, this was a plain, simple vaginal hysterectomy done by a gynecologist from outside Pune, and then referred to us because the patient started passing stools through the vagina. We went in laparoscopically, and you can see a finger from there. That is the finger in the vagina, and that was a rectovaginal. Now, even after a vaginal hysterectomy, if you have a fistula and if you open these patients, the patients will sue you, because a minimal invasive surgery is now converted into maximal invasive surgery. But what you thought, that there is no chance of damage to the rectum after a vaginal hysterectomy. We have just published our series of 7 patients referred to us following vaginal hysterectomy. So again, a callous attitude when you are not able to really do the dissection, then of course it becomes easy. You identify the fistula, the patient is happy. Similar coloanal. Now this patient was operated in Nashik 3 years back. 2 times the rectovaginal fistula was opened and closed, and still it did not work. So what we had to do, the rectum was so big, the vagina was also continuously getting involved. So what we did was we replaced the entire anterior abdominal wall by taking the colon down. So the entire portion of the rectovaginal fistula was resected. This is the resection of the entire fistulous tract, because 2 times repair were done. Local repairs were not working. The patient used to come back with rectovaginal fistula repeatedly. Both these were done with open surgery, but we then did a coloanal replacement. So don't try to do something again what has been already done. We replaced the anterior abdominal wall. We resected that part of the rectum and did the stapler anastomosis, and the patient went home after about 7 days. This patient, of course, had ileostomy because this was done 3-4 times. So you can see very bad rectum over there. Don't try to reinvent the wheel. Don't try to do the same thing. And this is what we did. You can see the entire rectum being replaced now with the proximal rectum, and you can see the rectum, new rectum going there. So we replaced the entire rectum and sutured it to the anal canal, and that's how we could control the rectovaginal fistula. We won a Golden Telescopic Award for this video because this was and then you can see prevention is the best measure. This is what I keep on telling. Do not use any, just do not use any kind of, look at the rectum. There is a huge kind of temptation to use energy source. Don't use energy source. Tell your assistant to push the posterior wall of the rectum. Push the rectum. When people come and tell me that there is anatomy was distorted, I tell them anatomy is not distorted. Your mind is distorted. Anatomy remains the same. Just follow the anatomy, follow the principles, and you will be able to do this dissection very well. So you can see somebody pushing from the vagina, a simple measure of somebody pushing from the vagina, and you have a very good, nice method by which you can immediately do the dissection. What about trocar injuries? This is a case where, again, my own resident tried to put the trocar without understanding, without doing an inflation, and he actually did a colostomy by putting a trocar. So these kind of injuries are common. This was a peritonitis patient, and then of course closing it was easy. You could see the site of bowel injury which was there, but this could have been an avoidable procedure. In peritonitis, never put a direct trocar. Look at this. This injury was recognized 3 days later. The patient did not have, and this was a patient from our own institute. But, and therefore we always advocate, whenever there are adhesions, use VisiPort, and that would be very, very nice to do that. So entry-related injuries are something which you should avoid by using Visiport. Intra-abdominal pressure should be 14 millimeters of mercury, and diagnose the cases, because this is prevention and diagnosis is much better than later on regretting. So diagnosis of bowel injury should be intraoperative. Whenever there is suspicion, smell of gas, which is through the port. If you smell something, do not say it is because of something in the theater. And persistent problems which exist, if the patient is not having a good course, as an anticipated course, a radical hysterectomy TLH patient should go home after 24 hours. But if he complains of nausea, reluctance or inability to mobilize, be suspicious of everything that is not going correctly, and you will find that quick decisions will help you to do that. Do not refer the patient to the physician. It is always better to do a diagnostic laparoscopy. So prevention by using peg leg and all these measures of careful retraction, not using energy source. So anticipation and suspicion will save the patient and also save you. So complications should be avoided. Good surgical decisions come with experience, and unfortunately experience comes only with complication. So if somebody says that I have no complication, either he is god of laparoscopy or god of surgery, that who doesn't know what to do. So if you have not had complication, you are not doing enough surgery, doesn't mean you have to have a complication. But if I have had complication and I tell you how to prevent it, follow the experts, follow what they have committed the mistake, because you learn from the mistakes by communication, decision making, and do not be afraid. So everything you have wanted to do on the other side is the fear. The fear should prevent from doing this. Go through the anatomy, and anatomy is the only thing, because even as the best surgeons, the best scar, you will have accidents. Accidents are something part and parcel of the life. How to prevent them and diagnose them is in your hands. So thank you, ladies and gentlemen. Thank you very much for giving me this opportunity. Thank you so much.
Wonderful, lucid presentation, as always, Shailesh. May I request Prakash and Pankaj to kindly felicitate Shailesh.
I request Dr. Jatin sir to also please start his screen sharing in the meanwhile. With the permissions from the chairpersons, can Dr. Shah please get started? Yes. Yeah, we are ready. We can go.
Yeah, in the line of all stalwarts now, we have a presentation by another stalwart in the field of IVF, who is fondly known as IVF Commando because of his expertise of handling complicated IVF cases, Dr. Jatin Shah, presenting on management of poor and high responders simplified.
Thank you so much, respected chairpersons. It's always a pleasure to be a part of the POGS conference. I was actually very disappointed because, like Dr. Shailesh said, I was really looking forward to wearing a suit and driving down to my favorite hotel in Pune for this today morning, but I guess it was not destined to be. At the outset, I'd like to, of course, thank my dearest friend, Dr. Harshad Parasnis, Dr. Ashwini, and all the members of POGS for inviting me today. The topic we have today, of course, I'm sure all of you will agree that in an infertility practice, almost 70 to 80% of our patients would either fall in the category of low AMH and poor responders, or the PCOs with high AMH and high responders. So, of course, I've put in something for everybody, for those who do only IUI, and also for those who are practicing IVF. So if you look at the 10 commandments of IUI success, probably the most important is, of course, controlled ovarian stimulation, because successful IUI depends on doing a proper ovarian stimulation with a perfect timing of follicular rupture and ovulation. What is the aim of stimulation in IUI? We don't want 15 or 20 follicles. We just want 2 to 3 or 4 good quality oocytes with a proper endometrium. We wanted the protocol to be cost effective, safe, and give us the best possible pregnancy rate. It's very important before you start stimulation that you must categorize the patient into a poor, a normal, or a high responder, And for this, you take into account, of course, the age, the AMH, the AFC, the BMI, her previous response to treatment, and whether she has associated PCO or endometriosis. So let's begin with the high responder and the PCO, which is usually the dangerous category, especially when you start using gonadotropins for them. Of course, we know that letrozole is the best for all PCO patients and anovulatory patients. And Legro showed that way back in 2013 that you have a 44% increase in pregnancy rate as compared to the use of clomiphene citrate. Subsequently, this has been corroborated by several studies, as you can see in 2017, that letrozole gives a much higher pregnancy rate at 60% as compared to 40% with clomiphene citrate. A very interesting combination protocol, which I've started using recently, is to give both 2.5 milligrams letrozole along with 50 milligrams of clomiphene from cycles day 3 to 7. And the advantage here is that you will notice that they have a statistically higher ovulation rate than when you use letrozole alone. So you get the benefits of a better endometrium, and you also get better ovulatory rates. What about the sequential protocols? Again, for PCO patients, the Letros HMG does much better in terms of clinical pregnancy rates as compared to clomiphene HMG. And you can see here, especially, you have a lower incidence of LUF, you have a thicker and better endometrium, and you have higher pregnancy rates with letrozole sequential protocols as compared to clomiphene citrate. What about gonadotropins? The best way to do gonadotropins in IUI, especially if you are a beginner, is to do the chronic low dose step up. Just start with about 50 IU a day, wait for 14 days. If you see a dominant follicle, continue the same dose. If you don't see a response, increase by 50%. So instead of 50, you make it 75, wait for a week, and so on until you see the dominant follicle. Of course, the follicular phase will be very long, 25-30 days. The criticism is that it becomes expensive, too many injections, but it is the safest way to treat these patients. A good in-between compromise, especially for a high BMI PCO, is to start with 112.5. And a lot of you would think that this would cause hyperstimulation, but in fact, it doesn't. You have 40% of patients, despite this dose, just giving you a monofollicular cycle. Pregnancy rates are excellent at 30%, and you have just mild hyperstimulation in about 10% of patients. So this works very well for most of the PCO patients. But the most important slide, before you start a single gonadotropin injection for a PCO or a high responder, always counsel the patient that there is a possibility of cycle cancellation, which the patient will not appreciate in the presence of hyperstimulation. So the better thing to do is convert her to an IVF, because if you've started with the lowest dose, you know that you can't go lower than that, and yet she produces 10-15 follicles. It's best to just add the antagonist, speak to your friendly neighborhood IVF center, and convert her to an IVF cycle. And is this successful? A beautiful paper here showing that when you do rescue IVF in such high responders, you get excellent pregnancy rates as high as 45%, even better than the control group, because of course these are easier cases, they have fewer problems, and therefore the pregnancy rates are very good, and you are not compromising the outcome of the patient by such a last minute conversion. But it's very important that the patient should have been aware of this possibility before you started the first gonadotropin injection. So don't end up with cancellations, because the patient loses a lot of money and they are not in the happiest of moods whenever you cancel a cycle for hyperstimulation. For normal responders, it's best to use a nomogram to calculate the starting FSH dose. Simple plotting AFC versus the weight of the patient. And you can see here, for example, you have a patient weighing 65 kg with an AFC of 15. Your ideal starting dose should be 75. Now, if you started with 100 or 112.5 for this patient, you might end up with hyperstimulation. And as this beautiful paper shows from 2018, that in most cases, the FSH starting dose calculated by the nomogram is significantly lower than the one which was calculated by the clinician. So a lot of patients, almost 85% of patients, you are likely to go wrong with your starting dose and then end up with hyperstimulation. So please use a nomogram when you begin using gonadotropins in the early days of your practice. For poor responders, of course, I would like to give coenzyme Q, maybe DHEA or testosterone for 1 or 2 months prior to starting the IUI cycles. Hormonal pretreatment is important here. You can start with a high dose here. You don't have to worry about hyperstimulation. Even if an AMH is 0.8 and you're planning an IUI, you can easily give 150, even 225, and she's just going to produce maybe 2 or 3 follicles. You could also add the agonist or the antagonist. Coming to the antagonist, whenever you do IUI with gonadotropins, please, please, please add the antagonist. Remember, there will be a 25%, that means 1 in 4 patients with gonadotropins will have a premature LH surge, resulting in LUF, unruptured follicles, and a failed cycle. It's not fair when you spend so much money on the gonadotropin, then just for this minimal added cost to lose a pregnancy or to have a premature LH surge. A lot of papers now, and this is one of the most recent, 2019, clearly showing when you add the antagonist in an IUI cycle with gonadotropins, your premature luteinization is almost down to 0, and your clinical pregnancy rate is up from 15 to almost 25 to 30%. So very important to add the antagonist in every gonadotropin IUI cycle that you do. What about the trigger? Very easy. In clomiphene letrozole cycles, you can give anytime between 17 to 20 mm or even 21. In gonadotropin cycles, we like to give it at 18 or 19 millimeters. Remember that ovulation usually occurs around 38 to 40 hours post HCG. Most important point, not to get confused about when to do the IUI, before rupture, after rupture. Remember that once you have a washed sperm sample, these sperms can fertilize oocytes just for 2 to 3 hours from the preparation time. So if you do IUI a day before rupture, it is absolutely meaningless. Oocytes, on the other hand, are fertilizable for 12 to 16 hours post-release. Now, if you remember these two basic principles, it's very likely that you will not go wrong with the timing of your IUI, and therefore the best time appears to be at 40 to 46 hours post-HCG. So you can see here 42 hours gives the best pregnancy rate in these patients. A very recent advance is that you can also use the agonist trigger in IUI cycles if you don't want to give HCG for fear of hyperstimulation and still get a similar pregnancy rate. More importantly, when you see a asynchrony, many times in clomiphene cycles, you see that the follicle is 19 or 20 mm, but the endometrium is still just 7 mm, and you are wondering what to do. And it's a beautiful paper here that you just give the agonist trigger instead of the HCG trigger whenever you see such asynchrony, and you get excellent clinical pregnancy rates, much better live birth rates, and lower miscarriage rates in these patients. So food for thought and very interesting area for you to follow up on. Luteal phase support, of course, mandatory whenever you are giving gonadotropins. And therefore, in poor responders, you could do a starting dose of 150 to 225. Normal responders, 75 to 150. High responders, as I told you, chronic low dose step-up protocols so that you try to get a monofollicular growth and do not get hyperstimulation. What about IVF? Now here the scene completely changes because you want lots of follicles. You want 15, 20, 30 follicles. You want 20 to 25 oocytes, maybe 15, 20 top quality embryos, because we now have a shift from the original thought process that we had that 5 to 15 is the best. And after that, there is a drop in pregnancy rates because of the supraphysiologic estradiol levels. We now know that this is easily averted by doing a freeze-all, and the ideal number of oocytes has now shifted from 5 to 15 to almost 25 to 30, so that you do just one stimulation cycle and you are done with it. Freeze all the embryos, keep doing frozen transfers, and give her 1, 2, 3 offspring from the same one ovarian stimulation. So the selection of the initial dose is very important if you are to get this kind of a response and enough number of oocytes for these patients. So please avoid dosing with 100 or 150 when you're doing an IVF cycle. This paper clearly shows the best is 225, which should be a standard dose for all predicted normal responders, so that you do not get fewer oocytes and you do not create a Poseidon 1 or 2 poor responder with a suboptimal response. But coming back to our main discussion, and that is how do you manage the high responder in IVF? We know they have numerous problems. One is the propensity for ovarian hyperstimulation, difficulty in titrating gonadotropin doses, increased risk of cycle cancellation because of hyperstimulation, OHSS, increased incidence of premature progesterone rise, most significantly increased risk of spontaneous pregnancy loss. Most of this has been overcome now with the simple 3 musketeer approach. You need to use an antagonist protocol, never down-regulate a PCO patient. Use the agonist trigger whenever there are more than 15 follicles, which is almost the norm in a PCO, and do freeze-all and do not do a fresh embryo transfer. Add back HCG was recommended by some, but still gives a very high incidence of hyperstimulation. Progesterone rise, you can see if there are more than 18 oocytes, almost 17% of patients will have high progesterone on the day of HCG. And the more the number of oocytes, the more is this premature progesterone rise. And you can see here, this was our preliminary study way back 6 years ago. for PCO patients, all with the 3 musketeer approach. And as expected, the first frozen embryo transfer, 57% pregnancy rate. If you remove the pregnancy losses, you still have an ongoing pregnancy rate of close to 50%, which today remains the most successful approach for even severe resistant PCO patients. What else do you achieve with freeze-all? You have reduced risks of low birth weight, small for gestational age. Biochemical pregnancies are almost eliminated. Ectopic pregnancies are half the incidence of fresh transfers, and so are early pregnancy losses. Of course, there were occasional reports of acrita and macrosomic babies, but these are yet to be established. I've been doing freeze-all for the last 7 years now, and we've just had 2 cases of acrita, which were also in surrogate mothers with 2 previous cesarean sections. So maybe that is a high risk category which needs to be identified. But in the general infertility crowd, you do not see much of this problem. What about neonatal health? For some of you who might wonder, what about the side effects of vitrification on the babies? So far, we have this huge paper here of more than 1,000 patients, and you can see the malformation rate with fresh and frozen transfers is the same. So we don't really need to worry about that. Pre-treatment strategies are very important because I see a lot of clinics just putting all their patients on OC pills. Even donors are on OC pills. Please remember that OC pills in antagonist protocols, we know from 15 years ago that you will have slower growth, lower E2 levels, longer stimulation, higher consumption of gonadotropins. 2017, again, it was shown lower ongoing pregnancy, lower live birth rates, and 2018, higher miscarriage rates whenever you use OC pill pre-treatment. But leave all that aside. The most important practical point is all these high responders are going to need an agonist trigger. And the agonist trigger is based on the fundamental that you need a release of endogenous FSH and LH, unlike the HCG trigger. Now, if you have given too much of OC pill pre-treatment, you will have over suppression of LH at the start of stimulation. And the lower the LH at the start of stimulation, the higher is the percentage of a suboptimal response. So then you wonder, oh, I had 40 follicles, but I got only 20 oocytes. I had 20 oocytes, but I got only 5 M2s. This is what happens because the endogenous FSH-LH surge is not adequate if you have suppressed FSH-LH so much with prolonged OC pill pre-treatment. So don't give these patients ever OC pill pre-treatment, especially egg donors, because this is where many of you often find that, oh, my regular patients give me good eggs with the agonist trigger, but the egg donors don't give good eggs with the agonist trigger. And this is the culprit is the OC pill and not the gonadotropin which you have used. The best way to pre-treat is just give the antagonist on days 2, 3, and 4, and then begin stimulation on day 5 for all patients undergoing IVF. If you do this, you will really see a dramatic improvement in your outcomes. Which gonadotropin to use for high responders? Until now, we were told only REC FSH should be used because LH is not good for PCO patients. They already have high LH, but we now have the results of the Megaset trial for high responders comparing REC FSH with HPHMG, and you can clearly see you will get fewer oocytes. So you get 7 less oocytes with HMG as compared to REC FSH. So you would wonder, how is it better? But this converts to 5 less metaphase 2 oocytes, which converts to 4 less zygotes, which converts to 3 less blastocysts. So you are all now convinced that HPHMG cannot be as good, but it gives you the same number of top quality blastocysts. Now, this is the important point, that with 7 less eggs, you still get the same number of top quality blastocysts when you compare HPHMG and REC FSH. And somehow this translates into reduced miscarriage rates. And that is a very important point because in PCOS, we've managed to counter most of the problems except the high early pregnancy losses. And you can see HPHMG reduced early pregnancy losses, cumulative early pregnancy losses also lower, FET pregnancy rates higher than with REC FSH. And therefore, they concluded that HPHMG is non-inferior as far as ongoing pregnancy rates are concerned. Reduced early pregnancy loss rates, to my mind, is the best advantage that we have. So OC pills, not recommended. You must use the 3 musketeer approach. You don't need to give clomiphene letrozole, and mid-cycle adjustments of doses do not work. Routine use of adjuvant metformin is not required. Agonist trigger is recommended. Once you give the agonist trigger, you don't need to give any cabergolines or albumins or anything else. The patient's ovaries settle down within 24 hours of the egg retrieval. And finally, IVF for poor responders. Of course, remember there are 3 categories. The first, where there is a reduced number of follicles. So this is a patient who has a low AMH and a low FC to start with. You cannot flog a dead horse back to life. So if you go to 450 or 600 IU, you're not going to make her ovaries respond. Second, she had adequate follicles, but you gave her a lower dose. And most of the Poseidon 1 and 2 are in this category, that she needed 225 and you started with 150, which is why I showed the slide that please select the higher initial starting dose for all these patients. And the third category is that she has enough follicles, you gave her adequate FSH, but she has polymorphisms, which is why the follicles are insensitive to the exogenously administered gonadotropin. So you can see unexpected, that is Poseidon 1 and 2, is the most vexing category, because 50% of patients will fall in these two, where you expected, oh, she was 28, she had a beautiful AFC, normal AMH, and I got only 4 oocytes or 7 oocytes when you were expecting 20. And the commonest reasons here, before we go to that, remember that whatever I am going to talk from now may give just 1 or 2 extra oocytes, but does this make a difference to a poor responder? Yes, it does. You can see with every additional oocyte that you get, you have an increase in the live birth rate for these poor responders. So the commonest reason for Poseidon 1 and 2 is usually under treatment. As I told you, you just need to increase the FSH dose. A lot of these patients might have polymorphisms, almost 20% of them. So you better to add LH or start with HMG instead of giving FSH to these patients. Pre-treatment, very important, because a lot of these are because you did not do pre-treatment. You started on day 2, day 3. One follicle became dominant, the others were lagging behind, which you very commonly see in antagonist protocols. And therefore, although you have 10 follicles, you end up with just 2 or 3 top quality embryos. So of course, there are various ways to prevent asynchrony of follicles, but my favorite now is the use of the antagonist. It works like magic. Just give days 2, 3, and 4, and then begin stimulation from day 5, and you'll get a beautiful uniform cohort, just like you got with the agonist cycles. OC pills, if at all you have to use, remember, not more than 10 to 12 days. So all the previous information I gave you was if you use it for more than 15 days, if at all you have to give for some kind of scheduling or programming, just give it for 10 to 12 days from day 2. Agonist protocols we thought were obsolete and were not good for poor responders, but it's quite the contrary. You can see here significantly higher number of oocytes, embryos, and clinical pregnancy rates with the use of the agonist. And this was a beautiful study we did at our clinic, same patient. So the best way to control a study is to use the same patient, 1 cycle with the antagonist, 1 cycle with the agonist. And the agonist with HP-HMG showed 30% top quality embryos as compared to the antagonist. And you can see medium to poor quality embryos more with the antagonist as compared to the long agonist. So it's not the end of the road for the agonist. You must use it judiciously. It often gives better results in poor responders. What about groups 3 and 4? Of course, these don't have follicles to start with. You were prepared for these patients. And of course, most of you are aware about the treatment modalities. Again, agonist does much better. You can see Poseidon group 3, young patients with low AMH, AFC, agonist, almost double the pregnancy rate as the antagonist. Maximal ovarian doses, please don't overdose the patient. You can see here whether you give 300, 450, 600, you have the same outcome in Poseidons 3 and 4, who start with a diminished ovarian reserve. 150 is probably the best for these patients. But what I am really excited about before I conclude is something you all need to start practicing, and that is the duo stimulation, where we do 2 stimulations in the same cycle. Of course, we know there are multiple waves of follicular recruitment in the same menstrual cycle. Some women have 2 waves, 32% of patients have 3 waves. And this was initial Ubaldi's study on 51 patients, where he, of course, gave REC FSH, REC LH from day 2, then the antagonist at 14 mm, the agonist trigger, egg retrieval, wait for 4 days, again start stimulation, and again the same way do a second retrieval.
Apologies to interrupt, sir, but we are running short of time. If you could
Yeah,
sum it up in
sure.
30 seconds, please.
So you can see here the rate of obtaining a euploid blastocyst is much better with the contribution of luteal phase stimulation. So somehow the luteal phase gives you a much better outcome in these patients. LH supplementation, again, we have enough consensus now that it is useful to add LH in poor responders for a better outcome. And of course, finally, the dual trigger, that is a combination of HCG 6500 and 0.2 milligrams triptorelin, will give you better outcomes in all poor responders. So of course, the recommendations are long agonist is the first choice. Second choice was estradiol or antagonist pretreatment. Dual stim might soon be the first choice for all these patients. So ideal dose summaries: poor responders, Poseidons 1 and 2, 225 to 300, 3 and 4, 150 to 225. Normal responders never below 200. High responders 200 to 225 is safe. So key messages to end: always be ready for rescue IVF if you're doing an IUI gonadotropin cycle. Avoid OC pill pretreatment for all patients. Antagonist protocol, agonist trigger and freeze all for high responders. Antagonist pretreatment, fixed day antagonist and dual stimulation for poor responders. It's not the end of the road for the agonist. HPHMG can be useful for high responders to lower miscarriage rates, and of course freeze all for a lot of these patients. So thank you once again, dearest Harshad, Ashwini, all the organizers. Apologies for overshooting the time, but it was a huge topic to be covered in about 20 minutes. Thank you so much.
Thank you so much, sir. It was excellent, and you kept us glued to the screen for last half an hour. And on behalf of POGS, we would like to felicitate you by giving you a plaque.
Thank you.
Since you're physically not present over here, we would just be zooming in onto the plaque.
Yeah.
We are actually felicitating.
Yes, we are virtually felicitating you. Thank you so much.
Thank you, thank you, thank you, everybody. Thank you, chairpersons. Thank you so much.
Jatin, thank you very much.
Thank you, Arshad.
Yeah, thank you for being there. And yeah, we missed you. We would love to have you in person out here.
Yeah, now I feel I should have come.
Yeah, thank you.
Thank you so much. I would like to thank the chairpersons as well and the speakers for keeping in time. Moving ahead, we've got the plenary oration session, which is going to be getting started. I request the chairpersons to please join us on the stage, starting with Dr. Dilip Kamath, sir, who is the founder member of POGS and the pioneer of OBGYN practice in Pimpri-Chinchwadi area. I would also request Dr. Harshad Tarasna, sir, to please join us. He is the president, POGS. Dr. Ashwini Kale, ma'am, she is the secretary, POGS, and Dr. Chaitanya Ganpule, clinical secretary, Redify 2021. Thank you so much. I also request our orator, Dr. Amarnath Biresa, to please start his screen sharing, switch on his camera, and unmute himself. Over to the chairpersons. Kind request Dr. Amarnath Biresa to please unmute yourself as well. And over to the chairperson.
Yeah. Yeah. It gives me great pleasure to start this session. This session is on Dr. Anjanelu oration. Dr. Anjanelu oration is one of the most prestigious orations of our society, Pune Obstetrics and Gynaecological Society. We have more than 2,000 delegates who have logged in from over 30 countries. Till last year, we always used to have this oration in our society with a audience, small audience. But this is the first time this has now gone virtual, and it is actually an international audience. So I feel it is deemed right that Dr. Anjanelu, late Dr. Anjanelu, who was the teacher of teachers, should be introduced. We must know about him. So I request my senior gynecologist from Pune and past president of Pune Obstetrics Gynecology, who had the good fortune of working with him and has been his students. So I would request Dr. Dilip Kamath, sir, to kindly say a few words about Dr. Anjanelu before we start with the oration.
Good afternoon, everybody. First of all, I'm very much thankful to Harshad Tarasna and the team POGS to give me an opportunity to have some words from my great teacher. Dr. Anjanelu was basically a teacher. He never used to like somebody calling him Dr. Anjanelu. He used to be very pleased when somebody calls him Professor Anjanelu. On this platform, I can say that the Dr. Anjanelu is responsible for keeping this society alive from 1973 to 82. This period I'm talking because 73 I joined as a clinical secretary, and I continued till 76 till I passed my MD. After that, I was general secretary till 82. And that's the time the POJS has changed the entire things as far as the financial matters and things become totally different. Dr. Anjanelu not only kept this society alive, but the most important thing that he's the first person who gave a platform to postgraduate students to have his own weddings on the POJS platform. He made it compulsory for all PG students to present their cases in the monthly meeting. There is a monthly meeting in BJ Medical College, where POJS was not having his own office. The another thing which he has done, that he has broken the safety between the Armed Forces Medical College and BJ Medical College. You may not be knowing, but it was a tough time during our undergraduate and postgraduate career. But he is a person who convinced all the FMC people to join the mainstream of POJs, thereby BJMC and FMC become together. He invited all the FMC senior people, teachers to become the officials of POJs and to become the member of POJs. He also made FMC postgraduate students to present their own cases at annual meeting as well as the monthly meeting. The another thing which you can say that he was a great obstetrician. He is a man who is known for this forceps application. His skill and application, rotation and extraction was really delighted in most of the cases without any morbidity and mortality. That is most important. The another thing was that he is a person who brought Riverol, that is ethacrylate lactate, which was brought in market as Gynaecological in 1973 after the GEAT virtual thing for the second trimester MTP cases. And he gave it to me for the trial, and that has really changed the era of second trimester MTP, where we have done the pioneer study in India. He was a great philosopher, and he used to believe on God. The another thing is that he used to believe on Amavasya and Purnima, and his words Amma, Beta and Beti to his students and patients were really delighting. He was very kind-hearted person. He had all his students, whenever they had any difficulty, whether it's a financial, whether it's a family or anything like that. And then I can say that he was not my teacher, but he was my godfather, and he gave me name and fame at very early stage of my salute to my great teacher, Dr. Anjanelu.
Thank you. Thank you, Dr. Kamath, for saying those words. And I think it is time that we as doctors, we as even our juniors need role models in the society who can actually be followed. And I think he is one who would surely be the one where who we should actually be following. So it gives me great pleasure now to introduce Dr. Amarnath Bhide, who is going to be delivering our prestigious POGS Dr. Anjanelu oration. First and foremost, Amar, good morning, because I know it's very early in the morning at 6 o'clock in United Kingdom now. And I'm just going to be saying a few good words for you, for my audience. Dr. Amarnath Bhide is the alumni of, say, GS Medical College and KM Hospital, Mumbai. And after his post-graduation in gynecology and obstetrics, he went to UK, where he also did his PhD at the Tromsø, the University of Norway, Tromsø. And later on, now he has now settled in UK, where he is the consultant in obstetrics and fetal medicine at St. George's University Hospital, London, UK. And he is also an associate professor attached to the Department of Clinical Medicine and the Faculty of Health Sciences, University of Tromsø, Norway. He is an FRCOG, and he has international postgraduate students and research fellows, where he supervises their PhD at various universities. As I can see here, he is also supervising a PhD student from the University of Kuopio, Finland. And he has also 600 students who are registered with him at the University of London under him. He is actually been has got an excellent academic career. Not only that, he has been doing a lot of research where which has actually resulted in his being the scientific editor of British Journal of Obstetrics and Gynecology and International Journal of Obstetrics and Gynecology with an impact factor of 5.05 in the year from 2007 to 2017. And he has also been on the editorial board of the ultrasound in obstetrics journal, and also the editorial member of the Acta Obstetrica et Gynaecologica Scandinavia. At a personal level, he has actually had more than 164 publications in peer-reviewed journals. And what is important, his H factor is 33. H factor is the citation impact factor of the author, and it is 33. So I think we are fortunate enough to have a person with such great credentials as Dr. Amarnath Bhide, and he's also a good friend of us. He is also a good friend of a lot of our members of Pune Society. So I welcome Amar, and I would ask him to kindly please start with his oration. Amar, the stage is all yours.
Thank you very much for the kind introduction. Can I share my screen if it's okay? Can you see my slides at all?
Yes, yes.
Harshad, I don't know how the internet connection is going to be. So if you can't hear me properly, let me know. Also, please let me know when my time is up and I will shut up. So I bring you greetings from London. It's lovely weather outside. It's 6 o'clock early in the morning. Outside temperature is 1 degree here. Thank you very much for the kind invitation to deliver this oration in the memory of Professor Anjanelu. I don't know him as a doctor or as a person because I never worked in Pune. Just to say that I've got some personal connection with him because he is responsible for my nephews to be in this world, because he operated on my sister-in-law, and she was carrying twin sons, and now they are about 25. So I do have some personal connection with him. Now, the topic that I've chosen is what is new in prenatal diagnosis. In my career, I've seen many changes, and those changes I would classify into two categories. One are the advances in medicine. And as we know, we don't practice what we learned in medical school because medicine is changing all the time and there are advances happening all the time. But the second important advance I've seen in my career is this advance in information technology. At one time, information was the monopoly of doctors, but no longer the case. Anybody who has got access to internet and access to Google has got access to the same information that you and me have got. So that results into a lot of information. There is a lot of information out there. It's not enough to just have the information, but we should be able to sift it through our intellect in order to find out what information is relevant and how to make use of that information. The point I'm trying to make is that it is no longer sufficient for us just to know about things, but it is necessary. We need to know what is going on in the world, and that includes what is going on in the world in prenatal diagnosis as well. So what I will do is I will, in a short period of space of time, try to summarize what has happened during my career in the field of prenatal diagnosis. Now, many of you have seen this slide or something similar, prenatal diagnosis of common trisomies. So we started with maternal age as a screening test somewhere in 1960s. And at that time, anybody with the age of more than 35 was considered a high risk. But very soon we realized that if we restrict screening to older women, then we are missing the majority of fetuses with chromosomal abnormalities. Because although the individual woman is at a high risk, majority of fetuses with chromosomal abnormalities occur with women who are younger than 35. Then was the era of nuchal translucency and serum biochemistry. And currently, that is the standard. A combination of maternal age, serum biochemistry, and nuchal translucency in the UK is offered as a screening test for all pregnant women. With that, we can detect 95% of all chromosomal abnormalities with a false positive rate of about 2%. So there's been quite a lot of advance. Starting from 30% sensitivity, we have reached 95%, and from 5% false positive rate, we have reduced that to 2%. So what is the current state of affairs? In the UK, risk of first trimester screening, the risk of 1 in 150 or higher is considered high risk. Now, what does it mean in clinical practice? If a patient is labeled as a high risk, what are the chances of that person to have a baby with fetal abnormalities? So one would say, okay, risk is 1 in 150, the chance is 1 in 150. But if you're looking at a group of women with high risk, what is the chance that we will ultimately find a chromosomal abnormality? In other words, what we are talking about is, what we're asking is, what are the odds of affected given positive result? And that odds is not 1 in 150, it's about 1 in 7, 1 in 8. So in short, anybody or the group of women who are labeled as high risk, and if we perform either a CVS or an amniocentesis, the chance that we will find an abnormality is about 1 in 7 to 1 in 8. So every 7th or 8th procedure I do, there will be a chromosomal abnormality which will be found. So that is the implication of a positive or high risk first trimester screening. The second change that has happened is the way in which we do karyotype. I'm sure you all know what a karyotype is. Karyotype is looking at the chromosomes. And if you look at the chromosomes under the microscope, this is how they look, or I'm told they look. I've never looked at the chromosomes myself. And the chromosomes are identified by the banding pattern. So at one time, there used to be somebody looking down the microscope, looking at the chromosomes, trying to identify which chromosome it is. But that's all now changed into computer. So we have given the control over to the computer. The banding pattern is identified automatically by the computer, and the computer will tell us what the chromosome is and which chromosome it is, and whether there is an extra or missing chromosomes. So that is what has changed in karyotype. But that's not all. Chromosomes are something which are seen only when the cells are dividing. It's pretty much like putting seeds in the ground and waiting for the tree to grow. Now that takes time. It takes about 10 to 14 days for the chromosomes to start seeing. But we don't have that much time. Patients don't have time. If they have a test today, they want the results today. Of course, that's not possible, but the advantage, the advance that we have is development of what is called as fluorescent, quantitative fluorescent polymerase chain reaction of qFPCR. Now, this is a rapid test which can test for copies of the chromosome. So each chromosome is identified by some markers, and we try to identify how many markers there are. And here you see 2 markers, which includes, which tells us that there are 2 copies of the chromosome. But sometimes we see that 3 markers, and we know there are 3 copies of that chromosome. Or sometimes we see 1:2 ratio of the markers. Again, 1 plus 1 plus 1, there are 3 copies of the chromosome. Now, this is a rapid test. and the results are available within 5 working days in the NHS. There are some drawbacks or downsides. The downsides being that the test is available only for chromosomes 21, 18, and 13. So it can miss other chromosomal abnormalities. Having said that, trisomy of 21, 18, and 13 constitutes the vast majority of chromosomal problems in clinical practice, and the other chromosome abnormalities are relatively uncommon. So, we started off with conventional karyotype, and then we changed over to QFPCR. But that's now changed, and the next advance that we have is something called as microarray analysis. And microarray analysis came into clinical practice some few years ago, and now there is a further advance which is called as next generation sequencing. Now, next generation sequencing is actually sequencing the human genome, and there are advantages of doing or applying that technology, and there are advantages and there are also downsides. So let us see what microarray analysis is. So this is the resolution and scale with cytogenetics, conventional cytogenetics. We need a get a resolution of 5 to 10 megabases. 1 megabase is 1,000,000 base pairs. So when there is an addition or deletion of 5 to 10 megabases, we can see that under the microscope, or even the computer can detect that under microscope. But this resolution can be reduced to about 10 kilobases with microarray. So you see how much we can improve the resolution, even if there is a small deletion or addition that can be detected with microarray. But when we come to whole genome or exome sequencing, we can reduce that to 1 base pair. Now that's really sensational, and that actually is possible in real life. So before we see all that, we will look briefly as to what this microarray business is. A microarray it utilizes a technique called as comparative genomic hybridization, and I'll explain to you what that is in a minute. But basically, it compares a normal genome with a patient genome. It picks up extra or missing bits of the chromosomes. What it cannot pick up is a single gene mistake. It is a more detailed karyotype, but we must remember that a single gene disorder such as achondroplasia, if that is suspected, then a microarray analysis is not a good technique. It's not an appropriate technique. How does it work? So the microarray comes as a chip, and you see a chip over here. So a test or genomic DNA, that is patient's DNA, is snipped up into several small pieces. It is mixed with a reference genomic DNA. Now, reference genomic DNA is a normal DNA, and equal amounts of it are put onto a chip. Now, it uses makes use of the fact that DNA is a double-stranded helix, and it will hybridize with its complementary strand. So there are several complementary strands spanning the whole of human genome on this chip, and each of these will hybridize with whatever is present in the chip, with the result that the test or patient DNA is hybridized with a green dye, and a reference DNA is hybridized with a red dye. Now, if there are equal amounts of it, then the resultant color is yellow. If there is an excess patient DNA, then the resultant color will be green. And if there is a missing DNA, there will be excess of reference DNA, and the resultant color will be red. So what we're trying to do is trying to find out the ratio between the red and the green. And the ratio should be equal normally. If there is more green, there is DNA gain. If there is more red, there is DNA loss. And that's how array CGH works. Now, this is how a chip will look like. Most of the dots should be yellow. There will be some red dots and some green dots. Now, in this publication from 2012, there were two kinds of array probes used, 44,000 probes, and the other one array was 1,800,000 or 1.8 million probes were used. So there's several probes spanning the whole of human genome. They are hybridized onto this chip, and we can identify if there are missing or extra bits of DNA present. So that's actually revolutionized how prenatal diagnosis is made. Now you might ask me, what difference does it make? Does it give you any advantage over conventional karyotype? And yes, it does. So here is a meta-analysis showing you what is the excess detection rate by chromosomal microarray in cases with normal karyotype, where there is a structural fetal abnormality detected in the fetus. And here are the results. There are several series published, but what we are interested in knowing is what is the excess. And in about 7 to 8% of cases, the karyotype will be normal, conventional karyotype will be normal, but there will be some excess of missing pieces found when chromosomal microarray is used. And when we find this, this will be more than just the fetal abnormality. Very often, this will have pathogenic consequences. So the practice has changed. In 2018, the present practice was the risk of aneuploidy of 1 or in 150 or greater on combined screening. We would offer invasive testing with QF-PCR. And QF-PCR, we've already seen what it is, testing for trisomy 13, 18, 21. And we'll offer sex chromosome ratios if the nuchal translucency is more than 4 millimeters. And that we are trying to detect is Turner syndrome. And most of these fetuses will have increased nuchal translucency. If nuchal translucency was more than 3 millimeters, we would offer full karyotype, because there is a chance that there is another problem, not just commonly seen chromosome problems. On the other hand, if there are ultrasound abnormalities found, then we would offer full karyotype to this particular patient, and we would offer chromosomal microarray following discussion with genetics. So that was happening in 2018. Now that has changed, and we have come to what is called as exome sequences. Now, exome sequencing is an efficient strategy of selectively sequencing the coding regions of the genome. It's interesting that 1 to 2% of the entire genome contains about 85% of the mutations that are known to cause genetic disorders. It is a cheaper but effective alternative to whole genome sequencing. So we can actually theoretically sequence the whole genome of a patient. It takes a lot of time, a lot of money, but it is possible. However, it's not necessary. We can be more efficient and only sequence part of the genome, but detect 85% of the mutations. So this is some exciting finding, which is now available for clinical use. And this is a study which is relatively recent, published in 2019. It used targeted virtual gene panel for 1628 genes. And as you know, there are about 22,000 genes that we know of. Out of them, 1,600 genes which are commonly seen or relatively commonly seen, they were targeted. And pathological genetic variants were identified in 8 to 12%. What is important to know here is that it is not, it is selective. It depends on what we find. So here you see, if there is a multi-system fetal abnormalities, then we can see positive or abnormal exome sequencing in up to 15% of these fetuses. But if it's something like brain, then it is not so high at all. It's about 3-4%. So it is cysteine dependent. What is the result? Current practice in 2021, what we would do with the risk of aneuploidy of 1 in 150 or greater with combined screening, we would do invasive testing with qPCR. Is my time up?
Sir, you can continue.
Thank you. So we would do invasive testing with qPCR. If nuchal is more than 3, we would offer them chromosomal microarray. So the thing to note here is that we no longer do conventional karyotyping. We don't do it because a microarray is available and it's so cheap. If the woman does not want an invasive testing, we would offer them NIPT, and we'll see a little bit later as to what this NIPT business is. If there are ultrasound abnormalities found, then we would offer them qPCR and microarray. And in selective cases, depending on what the abnormality is, we'll offer them exome sequencing. But for that, we need vetting with genetics because the technology is new, it's expensive, and we can't offer it to each and every patient. And why not? We'll come to it in a little while. Now, this is something that I'm sure everybody in the audience knows, cell-free DNA in maternal blood. It all started with the realization that maternal blood has cell-free DNA with an average base pair length of about 150 base pairs. There are several segments of it lying around. This is a mixture of maternal and fetal DNA. Now, fetus and placenta are mitotically active, so the proportion of DNA in fetal origin is relatively large, about 10 to 20%. So even if the fetus is only 3 kilo at term and the mother is maybe weighing 50, 60 kilos, the relative proportion is high because the placenta and fetus are mitotically active. Now, it is possible to differentiate between maternal and fetal DNA, but it is not necessary. It's not what we need to do in order to find out what happens for non-invasive diagnosis. So here is a sample of maternal blood, and there are several small segments of free DNA there. Now, this is a mixture of maternal and fetal or placental DNA. So what is done here is each of these fragments is sequenced. And as the length of the sequence goes on increasing, it becomes more and more unique, and we can tag it, identify it as belonging to a particular chromosome. So we can identify that this sequence can be number 4, 13, 18, 21, X and Y. So we can identify which chromosome it belongs to. Now, if there is an excess chromosome 21 in the fetus, then we know that there is some extra chromosome 21 lying around here. So we know the relative proportions of each chromosomes, which we expect to find in the maternal blood. If there is excess here, then we can, with a reasonable certainty, with a good certainty, tell that there is an extra chromosome 21, and that same thing works for trisomy of 13, 18 as well. So this is how cell-free DNA in maternal blood works, or NIPT works. Now, here is a graph which tells you or shows you the reference range of nuchal translucency, and on this is plotted nuchal translucency values of fetuses with Down syndrome. And here you see there is a considerable overlap. A large proportion of nuchal translucencies are above the reference range. There's no doubt about it. But there is quite a lot of overlap. A fair number of fetuses with known trisomy 21, they're actually within the reference range. With the availability of NIPT, that's all changed. So here is the risk of trisomy 21. And please note that the y-axis is logarithmic. Here are the risks of fetuses which don't have trisomy 21. Here are the risks of fetuses with trisomy 21. So there is a clear separation here. There isn't a clear separation there. There's quite a lot of overlap. Here you will see there isn't any overlap. There's hardly any. And that's what makes NIPT so good, that there's more black and white than gray. Okay, so that brings us to future issues. So we have got access to all this technology. Is it good or is it bad? Now there are definite advantages, but it's not the end. And there are issues as well. One issue is genotype and phenotype. What I'm trying to say is that we may know that a genotype of the fetus may be different. For example, we can identify a fetus with a trisomy 21 or Down syndrome. What we cannot tell is what effect it will have on an individual. How much will that fetus be affected? And it's impossible to say at the present time. So even if we know the genotype, we don't know the phenotype. The second problem is about information. There is a lot of information out there. How much information should we give to the prospective parents? We don't want to overload them with information. At the same time, we should not hold back information from them. And this balance about how much information to give is not very easy to make. The third important problem is definition of normal. What is normal? And that's quite difficult to define if you think about it. It may be argued that a person is normal only as long as you don't investigate the person enough. If you have to make several investigations, eventually you will find an abnormality. So it is quite difficult to find out what is normal. Finally, there are very, very difficult ethical issues, rights of the unborn fetus. For example, when we do this, apply this next genome generation sequence or even chromosomal microarray, sometimes we pick up abnormalities or errors which don't lead to much apart from maybe increased risk of developing certain types of malignancies or cancers in future life. And what if the parents come back and say, we don't want this baby, we want a termination? How ethical is it? So application or availability of all these techniques brings us into very, very difficult ethical questions. Now, to give you a taste of what these ethical questions may be, you might have read this book entitled Never Let Me Go. In fact, there was a movie with the same title, and I don't know if you've watched that. If you haven't, I would strongly recommend you to watch it. Another book by the same author, Clara and the Sun, is very new, will be published this year. And I would strongly recommend you to read these books. And these are disturbing books, actually. They are thought-provoking. They make us think as to where are we going with this new technology. And that is bringing us very, very difficult ethical questions. As you know, as areas of knowledge grow, so too do the perimeters of ignorance. I thank you very much for your patient hearing. Thank you.
Thank you, Amar. Excellent talk. Actually, a lot of futuristic repercussions of what is presently being done and what actual research is going well around. I thank you for this talk, and I would now ask Nirav, can you just show us the plaque? This is the plaque that we would virtually give you at this moment, though it's ready. It says that Pune Obstetrics and Gynaecological Society 29th Annual POGS Conference, Ratified 2021, presented to Dr. Amarnath Bhide in appreciation of delivering Dr. Anjanelu oration, What is New in Prenatal Diagnosis. Please accept this on behalf of from Pune Obstetrics and Gynaecological Society.
Thank you very much, Harshad. Very kind. Thank you.
We will hand it over to you the next time when you visit India.
Certainly. Looking forward to it.
meanwhile, I would like to thank the chairperson and especially the speaker for finishing it bang on time. Thank you so much. And now I request the chairpersons for the next session to please join us. I request Dr. Harshad sir to please be seated because you are the chairperson for the next as well, along with Dr. Ashwini ma'am and also Dr. Chaitanya. Our chairpersons for the next sessions are Dr. Harshad Parasna sir, who is the president POGS. We have Dr. Ashwini Kale ma'am, who is the secretary POGS. We've got Dr. Chaitanya Gandhule sir, clinical secretary Redefy 2021. And I also request now Dr. Prakash Kotale sir to please join us. He's a treasurer POGS to be the chairperson. To save time, can I also request our speaker, Dr. Dilip Walke sir, to please join us on the stage?
Nikhil, I think we can do that job.
Sorry, just to save time.
It gives me great pleasure to chair this session of POG's past president's oration. Who better could we have than our past president, Dr. Dilip Walke, to present this oration. I know a lot of people who are actually waiting to hear him on that, but that has always been customary. I know Dilip doesn't need any introduction, and he has actually told me outside that, and he has taken a promise from me that I'm supposed to be speaking only good about him. So I am going to stick to that, and I'm going to be only talking about the positives and not leak out any of his secrets that I know of. As you all know, Dr. Dilip Walke is the president of Pune Obstetric and Gynaecological Society for the year 2019-2020. He was the Ethics and Medical Legal Committee chairperson of FOXI for the year 2008 and 2010. And he is presently the consultant at Medipoint Hospital and Jupiter Hospital. He has keen interest in telemedicine. And I think after he finished off with his presidentship, or rather during that phase, he was keenly involved into futuristic medicine. I think today is a day for future medicine that we are looking at after Amarnath Bide's lecture. So he was also in telemedicine. He has developed his own app, Dr. Prax, and I think Dilip, we're all very eager to hear you, especially when you have actually put in a title name Dilip Dilse. So the mic is all yours.
Hello. No, it's okay. It's okay. Am I audible? So thank you. First of all, before I begin, I must salute to the POGS flag, which we actually drafted last year. And before any presentation, I salute to the POGS flag. And I thank the team 2021 for giving me this opportunity to give my past president's oration. And I must tell Harshad, Sunita and Parag, please concentrate on what I am speaking today, because in the coming years, you also are going to give the past president's oration. And they say, we learn by mistakes made by others. So you can learn from my mistakes, and then you can see to it that your past president's orations are better than mine. I tried to decode this word redefy, and I went to the Google and I found out edify means to improve, especially in moral and religious knowledge. So I thought re-edify would be to rebuild the same after the destruction. So since I am not an expert on religious matter, so what I thought was, what if I open my heart today, Dil Se, and talk about when and why I felt morally humiliated in my career. My humble request to you all, because you all expect whenever I speak, you all expect me to have a little funny kind of a presentation, but my humble request to you all is, please hear me out. Don't be judgmental. We can always agree to disagree, but please allow me some space today to ventilate. Two questions at the outset. Why did I not talk about my humiliations before? Well, the reason was fear of rejection by all of you. And then why is it that I'm talking about it today? Because today is my best chance to be heard. Because past presidents' oration in the past have been non-academic, religiously philosophical, and even about personal achievements where people talked about I, me, and myself. Then I thought, why not my personal experience of humiliations? Because I owe it to some others who suffer like me, but don't speak up. So firstly, let me reveal this fact. I belong to a caste which some of you call as Dalits, low caste or backward caste, and our constitution has enlisted as scheduled caste. Now, when I say that, the immediate reaction would be, Dilip, what's wrong with you? Why all this today? Well, has anybody in Pune ever bothered to ask you your caste ever? Have a look at this, because fortunately, my surname is not typical enough to know about my caste. However, have a look at this experience of mine with a senior POJS member who said, Dilip, तुझी भाषा इतकी शुद्ध आहे आणि तुझे विचार इतके प्रगल्भ आहेत. वाळके म्हणजे तुम्ही कोण? देशस्थ का कोकणस्थ? And then when I told him my caste, he said, Dilip, tu scheduled caste bilkul वाटत नाहीस. Now, what should be my reaction to this compliment? Should I be happy that he considered me to be the so-called higher caste person, or should I be humiliated? Because if I were to be happy, it meant that I accepted two things. Number one, the purity of thoughts and language is a prerogative of only the so-called higher caste people. And the gouty language, the mediocre thinking, the simple lifestyle, and my so-called of my so-called grandparents and my ancestors is impure and below dignity. Such stereotyping of caste makes me feel humiliated. Again, you might say, Dilip, you are overreacting. Has anybody demeaned or demoralized you on personal basis of caste in Pune? The answer is no, never. Not in Bombay, never in Pune. All is well in my personal life. I've had an intercaste marriage with somebody who is supposed to be the so-called higher caste than me. I'm reasonably successful in practice. I was a managing director of a corporate hospital for several years. I was the chairman of a committee in Foxy. We all made me the president of POJS. I made such wonderful friends in Pune, and all I am today is because of this unconditional friendship with my Kandar Chokdi. But having said that, and having had a very happy and fulfilled life, while I am happy with this romance, I feel disturbed to learn about lynchings, rapes, and land seizing of the powerless by the powerful in the Indian village. And no need to tell you what is the caste structure of the powerless and powerful in our country, in the Indian villages especially. However, this disturbance in my mind is very temporary, because I soon get back to the romance of my life with you all, enjoying parties, enjoying banquets, chilling out, exchanging goodies on the social media. My own insensitivity towards such incidents makes me feel humiliated with myself. And when I talk about humiliation with myself, I cannot resist sharing this WhatsApp forward with you. A Dalit girl gets raped in Hathras, UP. Not new. Evidence are destroyed and the girl is cremated. Not new. Some WhatsApp post maligns the girl's character and blames the girl's family for murder. Again, not new given the kind of media we have produced in our country. This message are forwarded by some doctors. Again, I'll say not surprising. But what is surprising and utterly humiliating is that one gynecologist, and I know for sure that he also belongs to my caste, forwards this message, and when confronted, says, Dilip, it is just politics. Rape, just politics? I can't take that. While I dwell further on this topic, I must give you this disclaimer that I'm no expert to debate whether social justice of more than 4,000 years can be undone by reservation of some number of years or till some parameter for evaluating social justice is achieved. I'm not insensitive to this comment either from an open candidate who says, why should I suffer for the wrong, social wrong done by my forefathers? Because I know for the ever privileged, equality always equals to atrocity. The privilege will always consider reservation to be an atrocity. I know that. This talk is not a debate on reservation. It is merely my journey and my humiliations. So for that, a bit into my family background. My father's family, and this is not a story of our poverty. Mind you, I'm not telling this story to tell you how poor we were, because I need to tell you this as a background,
that my grandparents were laborers on the Solapur Barshi highway, and that's the reason why their house is nothing but a slum alongside the highway. And no need to tell you that we were at the mercy of the labor contractor there. My blood is boiling even if I narrate this story to you now. My father, a 12-year-old boy then, goes to the local police. He tries to make a complaint because that rascal labor contractor had physically molested his mother, that is my grandmother. FIR, not registered. My father and grandfather beaten up. My grandmother was called a whore, and she was threatened that she would be raped in public if she made a complaint. Dilip, casteism is not about poverty. It is about poverty and powerlessness. This is what my father told me. My grandparents were poor and powerless, not because they were lazy to work to get educated and escape poverty, but it was because of several thousand years of oppression and lack of entitlements to get educated and earn a respectable living. More than 90 years ago, my father had asked his parents, are we destined only to do laborer's job and clean the shit of the so-called higher caste? And my poor Aji had only this answer then. She said, because it is mentioned in the holy books, because cleaning the shit of the upper caste is our eternal karma. However, cutting the story short, things change over time. My father got out of the slum life, got educated, became a custom officer, and retired as an assistant collector customs, thanks to two people. One was my mama, my mother's brother, and my father's very close friend. And second was the speeches and writings of Dr. Babasaheb Ambedkar. My mother had a blessed family because her father was a school teacher, one of her brother was in IFS, the other was in Indian Administrative Service, and they were related to Dr. Babasaheb Ambedkar, albeit distantly. It is very obvious that he is a godlike figure for me. However, when it comes to the topic of Dr. Babasaheb Ambedkar, I do not behave like a typical bhakt. I do not insist on respect for him by all of you at all cost. I do not retaliate if someone has a divergent opinion about him. However, I feel humiliated when 6th of December and 14th of April are remembered as dates where there is traffic jam at Dadar, Mumbai, near Chaitya Bhumi because of dirty people who create shit all over. Because I believe that sanitation arrangements of 6th of December and 14th of April in Mumbai are as important as sanitation arrangements for Wari in Pune district. Every Indian who willingly participates or endorses public celebrations of his religion or political events cannot be intolerant to similar celebrations of others. I feel humiliated if they do. Just to clarify, personally, I am against any such disturbing public celebration. Sharing this incident, did not feel humiliated, but felt pity to listen to a jibe on Dr. Ambedkar. Again, a senior POJS member who was talking about a raid by a PCPNDT authority on a sonography center, where the appropriate authority had taken objection to the fact that there was Devi's photo on one wall and Deva's photo on another wall, and then comes this jibe which says देवाच्या फोटोच्या ठिकाणी आंबेडकरांचा फोटो लावला असता तर ऑब्जेक्शन घ्यायची हिम्मत झाली असती का? Now, very senseless and harmless job, but it shows the casteist mindset that we have in us. So let me take you several years back in Mumbai, where I felt humiliated because of my caste for the first time in my life during my admission in the medical college. A bit about my background. I did my schooling from the Indian Education Society of Dadar. I was a rank holder in SSC among the first 100. And I always studied with a closest friend of mine, and we discussed nothing else in life but my career in medicine. His father considered me like his own son. In fact, I called him Kaka. Cut to the day of counseling for medical college admission. Kaka treats us in a very posh restaurant before reaching the counseling center. I'm so excited and happy. However, things change soon after that, on that day of counseling. Me and my friend had exactly the same marks in PCB, that is physics, chemistry, and biology. I was ranked first in the schedule, and for the benefit of those who do not know, in those days we used to get admission in medical college on the kind of marks that we obtained in physics, chemistry, and biology in the 12th standard. I was ranked first in the scheduled caste list, and that's the reason why I was getting GS Medical College, which was the first choice then. And my friend with same marks was getting into Grant Medical College, which was the fourth choice then. तुम्हा लोकांचं बरं आहे बाबा, मेरिट नसताना ऍडमिशन मिळतं, हवं ते कॉलेज मिळतं. तुझे वडील तर कस्टम ऑफिसर आहेत ना, वरचा पैसा खूप मिळत असेल, तुला कशाला रे हवं रिझर्वेशन? My friend's father. Imagine a 17-year-old boy being intimidated because of his caste by someone he respected and called Kaka. I felt ashamed of my caste that day. So I went back to the counselor and I said, please do not consider my scheduled caste certificate and give me admission as per merit in Grant Medical College. हे बरं आहे, म्हणजे तू मेरिट मध्ये ऍडमिशन घेणार आणि आमच्यापैकी एका कॅन्डिडेटची जागा खाणार. The counselor told me. आमच्यापैकी आणि तुमच्यापैकी was very new to me. I take admission under reservation, I am wrong. I take admission under open category, am I still wrong? This is where I got the taste of caste-based humiliation for the first time in my life. If you think this does not happen these days, my daughter had a similar experience during her admission in Ferguson College. And that's the reason why Mayuri says, Papa, this is like a Virgin Mary conundrum. A woman conceives, she has sinned because she has copulated to conceive. And if the woman does not conceive, she has again sinned because it was her duty to conceive. It is only Virgin Mary who can conceive without sinning. Good performance or not, a reserved caste candidate will always be labeled as Khalcha Zatiche below merit candidate. Let us take a look at this particular video. If it plays, I hope it does. Yeah. And is there an audio there?
पैसे देता हूं, देश का एडमिशन ऐसे नहीं हुआ है. भाई साहब, वही हो ना जो केलकर मार्केट ट्रैफिक सिग्नल पे है, अंडरवेयर पहन के भीख मांगते हैं. अरे तू वही है ना, है? बिल्कुल भिखारी हो. अरे कितनी बार तेरे को पैसे दिए मैंने.
Were you angry with the cheating beggar? Were you? Basically, feeling cheated to know that the person you were helping regularly is enjoying life exactly like you is just human nature. Just like the feeling that you get when you see that the protesting farmers are eating pizzas or the scheduled caste person is overtaking you in life. We carry in our mind a stereotypical image for farmers, for beggars, and for reserved caste persons. And when such image of a reserved caste candidate is shattered, that is the time we have an immediate rhetoric of creamy layer concept or effect of reservation on meritocracy. Couple of years back, I heard someone say, त्याच्या आई बापाची धो-धो practice आहे, financially एकदम sound आहे, पक्का creamy layer candidate आहे, तरी साल्याने मुलाला reservation quota मध्ये admission घेतली. And I thought it was a fair comment until just last year, the same person takes admission for his son in a private medical college in a management quota. Now, is that not another form of reservation? How many times do we hear this? तो रिझर्वेशन कोटा कॅन्डिडेट आहे, फालतू डॉक्टर असणार, असल्या डॉक्टरांच्या हातात आपला जीव धोक्यात आहे. We hardly ever hear this. तो ना तो डोनेशन कोटा कॅन्डिडेट आहे, फालतू डॉक्टर असणार, असल्या डॉक्टरांच्या हातात आपला जीव धोक्यात आहे. It is humiliating that I have to explain that reservation is only for admission in medical colleges and not for passing exams. If indeed we are producing faltu doctors, then it reflects on our examination system. Meritocracy is not about caste, my dear friends, it is about opportunities. Raise a so-called high caste by birth child in a village in UP, in a Dalit family, put him in a government school in the village, let all the villagers ridicule him as a poor Dalit boy, give him no extra entitlements, and then make him compete for meritocracy. Can anyone deny this? The best way to uplift the underprivileged, to bring social justice, is to educate them. However, the challenge for them is so much of privatization of education that they cannot afford it. Government-run institutes are on the verge of closing, and even in government-run institute, we hear such comments that these underprivileged Dalit or poor students enjoy education and hostel facilities at subsidized fee on our tax-paid money. Firstly, I am no economist, but I understand by sheer numbers, the parents of these poor Dalit students collectively contribute much more to India by paying an indirect tax on any goods purchased. Secondly, do we have a moral right to complain when most of us studied in medical college at subsidized fee? Some of us stayed as parasites in hostels for exam studies. Thirdly, I feel hypocrites like us should not complain because on one hand, we complain about subsidy on our tax-paid money, and on another hand, in our conferences, we invite IT and labor law experts to teach us tips and tricks to smartly evade taxes and get away by underpaying our staff. While I go further, I wish to make a request. Please, don't get me wrong. I'm not here to play a blame game against some caste or play a victim card. There are several doctors from my caste who have entered under reservation quota in the medicine under reservation quota. They hide their caste understandably because the fear of rejection again. But when they are in a discussion on reservation policy, they pose as if they are open merit candidates and shamelessly talk against reservation policy. This indeed is a humiliating hypocrisy. I have seen several people of my own caste offer water to their house help in different glasses, make them eat in different plates, refuse marriage proposal of some specific match because they belong to caste lower than theirs, because you may not know that there is a high caste and low caste, subcaste, even amongst scheduled castes. It is ironic that, and indeed humiliating to know that the victims of caste system are also oppressors of the same crime in some situations. It only shows the casteist thinking that is deeply engraved in the DNA of each and every Indian. It reminds me of a joke. Parents of a homosexual boy comes to term with his decision to marry another boy after lots of efforts. However, having accepted this marriage, कम से कम लड़का अपनी जात का तो पसंद करता. This is what her mother tells that homosexual boy. All this has, ladies and gentlemen, affected me a lot. I have become a hardcore atheist. I no longer believe that every religion is good. I have started believing that every religion is irrational. I ignore WhatsApp posts on Hindu culture, Islamic culture, or Christian culture because I believe culture is geographical. There can be only Indian culture, and I'm proud of my Indian culture. I believe that the essence of Indian culture is our constitution. Coming almost to the end of my of what I have to say today, and I expect no ovations or not even simple claps for my oration because there were no messages, there was no philosophy, there were no tips for perfectionism. And I realize that henceforth, many are going to blame Harshad for allowing me to choose this topic. But let me tell you, Harshad did not know about this topic at all. It was my choosing. Some will be keen to argue with me. Others will avoid any discussion. Some will genuinely sympathize. Others will show that they do. And I also understand for sure that there are going to be behind my back gossips like मालूम था साला schedule caste है या लगता नहीं था साला schedule caste है या अरे यार मैंने किससे दोस्ती कर ली इतने दिन. I don't mind all that because I'm very happy that you all let me open my heart today and ventilate, because this is something that was there in my heart for a long time. You gave me this chance to open my heart to you. So I thank you very much for a patient listening.
you, Dilip, for the for venting your feelings, and felicitating you for as a past president. We have to
5 minutes before, lot of time. Huh. Actually, the panelists are not yet come in, so we cannot start early because it's at 1.
yesterday we were a bit late, and today we have actually seen to it that we are on time, and now we are not only just on time, we are before time. So we just have got around 5 minutes more, 5 to 10 minutes more, and we'll start exactly at 1 o'clock.
Or just 5 minutes before, so the panel discussion gets more time to discuss as well.
Panelists have come. You can.
Yeah, we are just calling the panelist and we shall inform. All right.
Yeah.
Yes, we shall take a. Yeah, so we're just taking a quick, short.
Take a short break.
Yes.
Yeah, and I thank
moderators to please take it forward. In the meanwhile, shall I just mention the panelist name or?
I will do that. Thank you, Nikhil. Thank you, Nikhil, for the kind introduction. And I welcome Dr. Rajesh Kokre, my co-moderator from Baramati. He has come all the way from Baramati to join me for this moderating the panel on ovulation induction. Let me introduce today's panelists, Dr. Kedar Ganla. Hi, Kedar. We can't hear you.
Hi, Chaitanya.
Yeah, hi. Dr. Anjali Patil from Satara. Good afternoon, madam, and welcome. If you can just say hello, it would be easier for me to know that your mic is working perfectly. Dr. Mugdha Parasnis from Pune, Dr. Asmita Podgar from Pune, Dr. Daya Borgaonkar, Dr. Manasi Naralkar, and Dr. Bharati More. Dr. Ashwini Margai was also a part of this panel, but for some reason she couldn't join today. She has conveyed her apologies for the same. Friends, India is witnessing a high burden of infertility. About estimated 22 to 23 million couple in the reproductive age group suffering from lifetime infertility. The female factor accounts for about 40 to 50% of infertility among infertile couples. Anovulatory infertility ranges from 3.7 to 22% amongst the female factor infertility. Now, this is just to update all the others. And ovulation induction and controlled ovarian hyperstimulation lie at the very heart of the treatment of anovulatory infertility. Ovulation induction in anovulatory is the most successful treatment for infertility. If you see the history, it dates back to 1960s, and since then, the science has progressed rapidly to be discussed at length from time to time, and that's the reason why we are here today again to discuss ovulation induction, in spite of it being discussed for quite a few times in the years. So I would like to start with Dr. Anjali Patil, madam. Madam, we would like to know from you, how is the natural ovulatory cycle? If you can tell us something about the HPO axis and something about the two-cell gonadotropin theory. I'm going to go a little bit in the basics because many of our delegates are non-fertility consultants. So therefore, for them, it would be good if we go to the basics.
Good afternoon, everybody. Can you hear me?
Yes, ma'am. Please go ahead.
Nice to see all of you over here. Nice to see Dr. Kedar Kand also, because we missed him in AMOX 2019 also. Namaste. Basically, what I want to tell is that the number of follicles are decided when the female is in the intrauterine period. That is, there are oocytes are there at 6 million at 20 weeks of gestation. Apoptosis starts, and at the birth there are only 1 million oocytes, and then only 4 lakh remain till the puberty, and out of that only 470 can ovulate. So basically what I think is that hypothalamus is the main master of the orchestra of the endocrine organs. So just before the menses, all the hormones come down, and then FSH starts increasing. At the same time, whichever follicle is going to dominate, that recruitment starts nearly 10 weeks prior. So there are 2 stages, that is gonadotropin independent stage and gonadotropin dependent stage. So in the last few days only, the gonadotropin dependent stage starts, that is from the pre-antral follicle, and therefore if the follicles are rescued, then they definitely can grow. So that is the basis in ovulation induction, that is that we have to see which period is of the FSH window, and then we can get good recruitment of follicles. So there are 2 cell gonadotropin stages, that is there are 2 cells that is theca cell as well as granulosa cells. So theca cells, they have LH receptors. So cholesterol is converted to androstenedione in the theca cell, and from there the androgens are converted to estrogens in the granulosa cell. So you have to know that there is aromatization occurs from androstenedione or androgens to estrogens, and there the aromatase enzyme acts. So I think so. This is the basic that we have to know when we give letrozole. So this helps us.
We have to know the reason why we have to know these basics is that whenever we are going to induce women with any kind of medications, we should know the basics because we should know the principle on which the drugs are acting, and therefore the drug which we should be choosing will be different based on what the issue with that particular patient is, and therefore a mature HPO axis is what is needed when it comes to proper ovulation, proper menstruation. Rajesh?
So next question is to Dr. Manasi Naralkar. What are the types of ovulatory disturbances we see? And how is the significance? Hello? Shall I repeat?
Am I audible?
Yes, yes.
Yeah. So as per the WHO classification, there are 3 groups of anovulatory disorders. One is the hypo group. One is hypogonadotropic, hypoestrogenic, which is mainly the central axis. The problem lies with the hypothalamus or pituitary. The group 2, which is the most common, in which we see PCOS, that is normogonadotropic, normoestrogenic, in which the FSH, LH, the gonadotropins are the levels of the gonadotropins are normal, but the estrogen is less. Is normal as well. So that includes PCOS as well as the non-PCOS group, in which we have the hypothalamo-pituitary axis dysfunction and the hormonal issues like hyperprolactinemia. And the group 3, which is the target organ dysfunction, that is primary ovarian failure. It includes hypergonadotropic, hypoestrogenic anovulation.
So for us to understand in which group of the classification the patient fits is important, because based on that we are going to choose the ovulation induction agent. If it's good in group 1, we are going to go for some different medications. In group 2, if you are going to go for different medications. Group 3, we are going to go for different treatment altogether. And that's the reason why we should be aware of what kind of group the patient is fitting into. So most of them fall in group 2, that is PCOS group, which is wherein we have a normal FSH, may have an increased FSH, LH or a normal LH and a normal estrogen. The second group, hypo incidence is much less, wherein we get low FSH, low LH and low estrogen. So that is important for us to understand the classification. Now, immediately after that, I would like to ask Dr. Bharati, what are the types of ovulation induction agents which we have? What are the types of ovulation inductions? Dr. Bharati?
Audio is not. Hello? Please turn on your audio.
Dr. Bharti, you need to unmute yourself.
Sorry. Good afternoon. Thanks at the outset. The different types of ovulation induction are that you can either use correction of the ovulatory disorders, that is you call dysovulation, or superovulation, which you use in IUI, or you can have controlled ovarian hyperstimulation, which you use in IVF and ICSI. The different agents which can be used is you have ovulogens, that is you can use either tablets, or you can use gonadotrophins, which could be the agonist or antagonist.
Okay, we can take it at a later point of time. I will request all other panelists also to put in their comments once the person who has asked the question finishes with her or his answer. Rest of all, Kedar, you can also put in your comments so that it becomes more interactive. So let's start with our first case. She's a 25 years young woman who came with the history of primary infertility since 3 years. Her menstrual history was she bleeds 2 to 3 days every 2 to 3 months. The investigations done revealed that the FSH was 5.4, the LH was 11.6, AMH was 4.8, the ultra TSH was 2.8, the prolactin was 9.5. My question is, do all of us, before going ahead, do all of us do all these tests in each and every woman who comes to us for the first time? We'll start with Kedar.
As soon as the patient will come, I think first thing we do is investigate is by doing an ultrasound. So on ultrasound, we will typically see the multicystic ovary. We will correlate with the history of irregular periods, high BMI. Okay, this will lead us to do certain investigations. Now in this, whatever investigations are written, these are perfect. Okay.
Yeah.
No, the only thing is now the Rotterdam doesn't consider FSH LH ratio as been something which is very important.
Correct.
I always add insulin resistance investigations in this so that it helps me to decide whether I'm going to start insulin sensitizers for all patients with evidence. Without evidence, I don't start. So these are investigations with the.
Which investigations do you do?
I do fasting glucose, fasting insulin. 2 hours later, again post glucose insulin and sugars. So if the fasting insulin, fasting sugar by fasting insulin ratio is less than 4.5, or the post glucose insulin is exaggeratedly increased, means this is a patient who has not been able to tolerate the glucose load. The likelihood that this patient will benefit from A, metformin, B, weight loss, and C, maybe I will continue metformin or insulin sensitizer in pregnancy to prevent occurrence of GDM.
Correct. So I was going to come to that. Kedar, you said that you will be doing insulin resistance. Would you be doing it in each and every woman, or will it be a group of women in whom you would specifically do insulin resistance?
It's actually based on obesity, but the definition of obesity itself is changing. Now we have to know that there is an intra-abdominal obesity and extra-abdominal obesity. And even in thin lean PCO, when the intra-abdominal obesity, which is high, also could give rise to this. And there is one more investigation, is serum testosterone we forgot. So serum testosterone also I would like to add in this list of investigations.
Testosterone, or you would like to see the free testosterone, or you would like to add even SHBG to it?
No, I generally do only serum testosterone if testosterone is high, and then my classification becomes much easier. Thin lean PCO with high testosterone and no glucose insulin resistance. Second part comes obese, insulin resistant, serum testosterone normal. So the classification of PCO becomes much easier for me to manage.
Bharati madam,
so her reports of the husband is semen analysis normal. No any past treatment have been taken. So what is the diagnosis? How do we proceed for this case?
As Dr. Kedar has rightly said, depending on the history of oligomenorrhea or irregular menses or maybe amenorrhea, obesity, and signs and symptoms of hirsutism, you are going to clean the diagnosis with a transvaginal sonography of the sonographic findings of your multiple cysts on both the sides. So with this and a history of infertility for 3 years, you're going to clean the diagnosis as actually PCOD. Now, with the semen analysis normal,
before moving ahead, I would just like to ask other panelists also, what are the criteria you use in your practice to diagnose PCOS? I want practical answers. What criteria you use in your practice, each one of you?
Can I speak?
Yes.
Yeah, so with the history of infertility 3 years, if she has a history of irregular menses with signs and symptoms of acne hirsutism, that is hyperandrogenism, and she is obese, you can see upper lip hair, or she has a chin, FG ratio, then with the investigations that Kedar has rightly said, I think, and the transvaginal sonography findings, I would decide that she's a case of PCOS.
Dr. Mansi?
I agree with Dr. Bharati. Clinical as well as biochemical and ultrasound features, they are the most important to diagnose.
Okay.
So can I add anything?
Yes, Kedar.
To look at the intra-abdominal fat, you use your trans-abdominal probe just above the umbilicus and look inside. The amount of subacute fat is the fat outside. And to know visceral fat, you go from the rectus sheath to anterior wall of aorta. This is where intra-abdominal fat, visceral fat is located. So even in thin lean PCO, this visceral fat may be high, and that's the reason she will be a polycystic ovary. So this one thing which we can start doing now.
Okay. Dr. Asmita, are you there? Yeah, I want your opinion also. What are the criteria you are using for polycystic ovaries? Diagnosis of polycystic ovaries. Can't hear you.
Unmute. Please unmute yourself.
Dr. Mugdha? Asmita, we can't still hear you. Just if you can re-log in. Dr. Mugdha? Mugdha nahi? Okay.
Next we'll take.
Okay, so how will you proceed in this case? Dr. Bharati?
So the first drug of choice.
I would of course confirm that her tubal patency is there, and after confirming that, I would first advise a lifestyle modification because her BMI is very high. Even if she achieves 5 to 10% of weight loss of her weight, 5 to 10% of her weight, and that would be really good for us, helping to improve the quality of the I would start, and if her insulin resistance shows me that she is highly insulin resistant, then I would start metformin also. And these patients are going to need induction of ovulation with either clomiphene citrate or letrozole. And you do the try and improve the ovulation and ask them for planned relations. Immediately, no couples are ready for IUI or IVF.
You madam said that you will be going for testing of the fallopian tubes. Now, if you go back in the history, she has not had any treatment in the past, and you know that she is now diagnosed as polycystic ovaries. Before starting with ovulation induction, you would like to confirm that her tubes are patent, or would you like to go for ovulation induction cycles, few cycles, and if she doesn't conceive, then go for a testing for the fallopian tubes? And if you go in the first cycle itself, what kind of
then see, when the patient has come to you, she's 25 years old and she's married for 3 years. Yeah, maybe first few to 3 months, we would ask them to go for planned relations. And then maybe if she doesn't conceive and consider the
still can't hear you.
Okay, Dr. Kedar. Kedar wants to add something.
Yeah, Kedar.
What my experience is, when you know, even if the patient loses 5% or 10%, the results what you showed are not always like this. But it's very simple thing happens that your ovulation inductions becomes a child play. And secondly, also the implantation rate and abortion rate is going to go down. That what is has to be understood, not only ovulation induction. See, many times patients have been given letrozole for 5 cycles, ovulation has happened, no weight loss has happened, patient has not conceived. They come to us, we make them lose weight, and next cycle they become pregnant. So keeping at this particular finer aspect is very important.
So the point which here we have to remember is that the weight loss is not only for improving our results of ovulation induction or pregnancy rates, but it's also for the continuation of pregnancy, the miscarriage rates and other complications which will be added on because of the obesity. Therefore, it's important for her to lose weight, even if she is having ovulation induction on ovulagens or whatever drug you are using. If she is ovulating, we should ask her to reduce weight so that her complications during pregnancy are on a lower side.
Yes.
Okay, going ahead.
Agreed.
So which are the different ovulation induction agents which are used? Dr. Daya. Oh, she's there. Yeah. Ashish, you can. Asmita, you can take up this question. Which are the different ovulation induction agents?
Okay, am I audible?
Yes, there you are.
Okay, thank you. So the first line are oral ovulation induction agents like clomiphene citrate, which is a non-selective estrogen receptor modulator, and aromatase inhibitors like letrozole and anastrozole. Then, of course, there are gonadotrophins, which include your HMGs, RFSH, and so on. So, primary ovulation induction agents, first line will be clomiphene citrate.
Now, the next question is also to you
Mechanism,
about
like,
clomiphene citrate. Can you just
so it is a
mechanism of action, the different
It is a
protocols you use?
It is a non-selective estrogen receptor modulator. It binds to the estrogen receptors, and hence the peripheral estrogen levels are perceived to be less than they are actually. So it's a central acting agent, and it also has a anti-estrogenic effect on the endometrium, which is its main disadvantage.
Can you just tell us something about the monofollicular development and the multifollicular development, which we see in cases with clomiphene citrate and letrozole?
So because clomiphene is a longer acting agent, the negative feedback of the estrogen is stopped, and therefore the multifollicular development is more common with clomiphene. While letrozole, because it's a peripheral agent and it is shorter acting, and there are the negative feedback of estrogen to the FSH is maintained in letrozole. So there is a monofollicular development in letrozole.
Perfect. So whenever the patient is going to be on CC, maybe we have to consider regarding the multiple pregnancies.
Ovarian, yes, multiple pregnancies.
Incidence of ovulation, multiple pregnancies with CC as compared to letrozole. Right? Okay. So
so what are the different protocols of clomiphene citrate we should use?
I would like
for related to
what you are using in your practice. You may say that I am not using clomiphene citrate at all.
So less use of clomiphene citrate these days, and preferred letrozole, definitely. But when letrozole was banned, I think clomiphene was used pretty regularly. And I was using starting dose of 100 milligrams. So the textbook says starting dose of 50 milligrams from day 2 or day 3 for 5 days.
Dr. Kedar, what's your choice of drug?
It's always been letrozole. See, the clomiphene as a drug has an anti-estrogenic effect. It has a good ovulation rates, but less pregnancy outcome because of anti-estrogenic effect. And second is the abortion rates are very high. And the anti-estrogenic effect of the clomiphene cannot be reversed by adding estrogen. So when the good drug is available, which is short acting, not receptor blocker, it's an enzyme blocker, which is much better than clomiphene. So I always use letrozole.
Okay. So now coming to your question, since you have brought out that topic, that many a time if we don't see a good endometrial development in women who we induce for ovulation. Okay, so when she comes back for on day 10 or day 12, you see a good nice follicle of 14 millimeters, 15 millimeters, but still the endometrium is thin. Do you add estrogens to these women? And what is the rationale behind you adding these, estrogen? Anyone? Asmita?
So I don't add estrogens to these women because I think if the clomiphene is causing, it is absolute. It's not dose dependent. So it's not like if we increase the clomiphene citrate dose, then only there will be anti-estrogenic effect. So it is person dependent. Some women will have estrogen, anti-estrogenic effect on endometrium, and adding estrogens will not really help them.
So this is true when we are using clomiphene. We know that it has got an anti-estrogenic effect. What about other agents wherein you don't see a good endometrial development? I'm not talking only about clomiphene citrate. I'm talking maybe she's on letrozole, but still she has got a poor endometrial development. Do you add estrogen to these women?
I don't, sir.
I don't.
You don't.
Yeah.
Yes, Kedar.
I don't think. One should do an E2 level. If your E2 level is above 250, then the adequate estrogen is present in the body for which the endometrium is bound to respond. Okay. If it is not responding for E2 of 250 and above, which means there is a target organ problem, which needs to be evaluated in the next step.
Perfect. My opinion on this is that, as you rightly said, you do an E2 level. If the E2 level is adequate, it's an end organ problem. But if the E2 level is inadequate, it's the follicle which is not producing that kind of estrogen. So even if you add estrogen to these women, you will see good endometrial development. But because of the poor quality of the follicle, probably pregnancy rates will remain the same. So I want to give a clear-cut message that should we be using estrogen in such women, or should we stop adding estrogen to these women?
There is one more point. There is one more point. If you add estrogen, say if the size of the follicle is 14 millimeter, if you find 87 millimeter, you add estrogen to the dose of TDS. This will cause a natural LS surge, and the follicle will, prematurely cause LS surge, and the whole cycle will go for toss. If at all you want to give estrogen, you can give post ovulation. That might help.
Perfect. So no estrogen for any of the women who are on ovulation induction agents. Am I right?
Yes.
Perfect. So coming to the protocol, we can start anything between 50 and 150 milligrams. Okay. How many of us are going above 150 or above 100? What is your cutoff for CC? See, I'm taking CC because many of us are still using clomiphene citrate. All of them have not shifted to letrozole completely, and therefore I would like to discuss this.
Yes, and when we'll be calling it as CC resistance. So like how many cycles we are going to give CC?
CC resistance is if you have already given her maximum 200 milligram per day and you've already given her for 6 months and she is not ovulating. That means it's a resistant case. So if further increase is not going to help. And as Dr. Kedar rightly said, PCO I always use letrozole and not CC.
Yes, Kedar.
150 milligram for 3 cycles, and if the patient has not produced follicle, you label that patient CC resistance. But in practice, 100 milligram and there is no response, I think it's time to quit the drug, give a 1 break cycle of OC pills, get the testosterone and LH down, and then start with letrozole. It will give you much better results.
Yes. There is a wonderful study which was published by Professor Roy Homburg, wherein he has compared all the various doses of clomiphene citrate, and he has seen that above 100, it's more or less the same. So there is no point in going above 100, even if the literature says that you can go up to 150. Dr. Manasi, you want to add something?
No, I agree. Usually, if there is no ovulation with 3 cycles of up to 150 mg, we call it quits. And otherwise, if she does not conceive even after ovulation, after 6 cycles, we label it as a clomiphene citrate failure.
6 cycles. And which day you would like to start? To day 2, 3, 4, 5?
Between day 2 to day 5.
Any day it is fine?
No, day 2 is,
any day is okay? Or you want to start on specific day? Day 2 or day 3 or day 4 or day 5 or day, what you would like to do? Manasi madam?
Between day 2 to day 5 is fine.
Anything is fine. Kedar?
If it's an ovulatory cycle, even if you start on day 2 or day 5, the hormonal conditions are going to be the constant. So it's not going to make any difference even if you start on day 2 or day 5. This should be no problem.
Correct. So we agree, all of us, we agree that we can start any day from day 2 to day 5. It's going to give us the same results. Now, there are some other protocols also which have been proposed in the literature, but we hardly use them. Extended protocol, when we give it for 10 days in a row, 100 milligrams, right? Then there is a stair-step protocol wherein we say that the CC is given for 5 days. Then on day 10, you do ultrasound. If the leading follicle is less than 10 millimeters, again give CC 100 milligrams for next 5 days. See the ultrasound. If it's less than 10 millimeters, then you say that probably she is not going to ovulate in this particular cycle. So we discussed about the CC resistance and failure to ovulate after 3 cycles of the maximum dose is CC resistance. It's 3 cycles and failure is 6 cycles. Resistance is 3 cycles and failure is 6 cycles. Yeah.
So So other factors, age, BMI,
What will you do if you encounter a CC resistance or CC failure?
Next step.
You're going to assess the patient for why you have had a failure. So you're going to see her BMI, you see her AMH, see her age, you see her previous response to ovulogens, and if required, you are going to see her thyroids, you're going to see her prolactin, and if required, testosterone, and then you're going to decide how to manage the case.
So if the AMH is less than 1.5, what will be the drug of choice, and the doses will vary? Suppose the patient is low AMH, less than 1.5. So in that case, doses would be the same, or will step up the dose?
No, so depending on whether he's a poor responder or a higher responder, or she's a normal responder, depending on that, depending on the AMH, you're going to decide the dose of the gonadotropins.
Based on the AMH, would you like to differ or change the dose of the starting dose of the drug? Instead of 50, you will directly jump to 100.
Yeah, that's what I wanted to say.
That's what you want to say? Any difference of opinion here?
Yes, Dr. Kela.
When the AMH is very high, okay, your choice is what are you want to achieve for monofollicular genesis, right?
Right.
So in an ovulatory cycle, monofollicular genesis, a low step-up protocol is the best. But if the AMH is on the lower side, or there is an unexplained infertility, then your starting dose has to be little higher, so as to go for 2 to 3 follicles. Aim is that way. So control ovarian hyperstimulation, and then achieve well, all that depends upon the age, BMI, previous response, antral follicle count, and affordability of the patient.
Yes.
Perfect. So that also needs to be looked into before we start with the dose of clomiphene citrate or letrozole. Madam, Anjali madam, how will you manage this CC resistance? Anjali madam. Okay, anyone else? Asmita, if you want to take this question, or Manasi madam.
So in CC resistant cases, sir, actually in practicality, I think I would want to change the drug. Letroz, like I said, is my preferred choice always. Lifestyle modification, I think we will start lifestyle modification even before starting CC. So we will tell the patient that you have to lose weight. But again, in practicality, if we tell the patient to lose weight, probably after 3 to 6 months, she will put on another 5 kgs and come. So we have to start side by side. When
you are saying that in obese women, we are going to, ask her to lose weight. Now she has come to you, you know that the BMI is high. You have already given CC. You are facing CC resistance. Will you?
So now I would like to start with gonadotropins.
Will you wait for her to lose weight for 3-4 months and then ask her to come back? And
in practicality, I don't think it helps.
Yes, Kedar.
The problem is, treating obesity is like wearing a different cap in the same consulting. I don't know of 100 grams of paneer, what are the calories? I better send it to a dietitian. I better send it to a physiotherapist. I add drugs like Orlistat. Okay. And I keep monitoring. There is a phone call happening to her as she lost weight. Then she understands the importance of weight loss. And I give them 1 or 2 months with therapy like metformin to act, and correspondingly, if the LH is also high, then maybe consider OC pills. And then after some weight loss, when they have already motivated, then you start the stimulation. The problem is, Asmita says correctly, patient, if is in a hurry, if I don't respond, my next door neighbor is going to respond or going to treat her. So better I only treat. That is my approach, but that's not my approach. I look at this way. Better to do a simple, case which is uncomplicated.
Okay. Now I have a practical question here. What you say is absolutely right. You should send her to the dietitian. You should send her to an exercise consultant or a physiotherapist who will explain her all the things. How many of our patients really go and consult dietitians or exercise consultants or whosoever it is when it comes to lose weight? Are they really going? What is your practical experience in your clinics?
Can I speak on that?
Yes.
Yeah. See, I'll tell you what we face is, these are working women. They leave the suburb at 7 o'clock in the morning and they reach home by maybe 8 o'clock. They're going to office from maybe one suburb of Bombay to BT station and Churchgate and all. So, they don't lose weight, as Asmita rightly said. In fact, they increase weight and come, and then they'll say, whatever I'm doing, doctor, I don't have time for exercises and I cannot do dieting. So even if after sending them to a dietitian or a physiotherapist, they are not able to lose weight 5 to 10% what we want. So in this case, what I would suggest is, if her BMI is very high and her LH is more than 10, she's obese, I think we should offer her PCO drilling. Of course, it should be minimum 4 in each ovary with 4 mm and all those precautions taken, so that she doesn't end up
We are going to come to that later on. Yes.
putting down her ovarian disease.
Yeah, we will deal with that laparoscopic ovarian drilling at a later.
Chaitanya, important point. Chaitanya.
Yes, Kedar.
See, it's very important. We are here to treat the pathology. The pathology is obesity. What you do, how you do, it's your job. You may do IVF for her and she will fall into implantation failure. She will develop gestational diabetes, PIH, twin pregnancy, early delivery. Where is going to end? At 30 weeks, she has 2 twins in her hand. Is it not correct? We need to put our foot down and say, I will not start ovulation induction. There is a very beautiful paper from Australian University. They say if you don't lose 10 kg weight, they will not be given gonadotropin. Then in that patients, they found 50% of the patient conceived. Abortion rate came down from 73% to 14%. Why can't we do that? Because we are worried the patient will go. If the patient is going, I feel sometimes very happy. You understand? I feel very happy. It's okay.
Message is that yes, she has to lose weight. She has to lose weight, and we have to tell her, hang on. That
conceiving is not the only thing.
Exactly. Conceiving is not the only thing. You should lose weight. Take time. Give some time to lose the weight.
So take home baby is important.
And then start with the treatment.
So the take home baby is important. So the next question is about the next drug, letrozole. So what are the different protocols, results, and drawbacks of this drug, and how do we go about it?
Dr. Manasi, you can take. Dr. Mugdha has joined?
No, I think not.
Dr. Manasi, you can take this then.
Yeah, so letrozole is an aromatase inhibitor. It does not act centrally. So basically the negative feedback mechanism is still intact, and it just prevents the conversion. It inhibits the aromatase enzyme, which is responsible for the conversion of androgen to estrogen. So peripherally, the level of estrogen falls. It is not a SERM. So unlike clomiphene, it does not have an anti-estrogenic effect on the endometrium or on the cervical mucus. So it is much better tolerated, and also it leads to monofollicular development because it has a shorter half-life compared to that of clomiphene, and which is that is why we have a lot of advantages of letrozole over the use of clomiphene citrate as the first line drug.
So most of the there are all the advantages which you want as compared to clomiphene citrate. So should letrozole be the drug of choice for each and every woman who comes to us and needs ovulation induction?
Not every woman, but in PCOS, yes, I would say yes.
Okay. So Bharati madam says for PCOS, she wants to use letrozole. For a non-PCOS woman, she says that she may go with CC or she may go with letrozole. Kedar?
All ovulation induction, letrozole or letrozole gonadotrophins or only gonadotrophins. Only 3 options.
Manasi madam?
I prefer letrozole. it's my first preference always.
And Dr. Asmita?
I agree with Dr. Kedar Gandhar. Either letrozole or letrozole plus gonadotropins.
Okay.
So
So most of us using letrozole as the first drug of choice in all women, may it be PCOS or non-PCOS. Is that right? And is that the message we want to give?
Yeah.
In non-PCOS women, both of them have shown to be of equal ovulation rates, are same, pregnancy rates are more or less the same, but still letrozole for other actions, because the washout time is less for letrozole as compared to CC also. So most of us are using letrozole as the first drug of choice. Okay.
So what are the different protocols for letrozole?
And I want, in addition to this, we will discuss the protocols, but I want what you actually use.
Yes, in practice.
Normally, we give that routine day to the tablet and give it for 5 days. Especially, you can start with 2.5 milligram OD or 2.5 milligram BD, or starting from day 2 or day 3, giving it for 5 days. Sometimes, there's a step-up protocol where you start with 1 tablet, in the second day you give 2, then you give 3, and then you give 4.
Milligram OD, or you said 2.5 milligram BD. Now, when I am going to give 5 milligrams, should it be given as a single dose daily, or should it be given in divided doses? Your opinion. And if you say divided doses, why divided doses?
See, if it is OD, then I would prefer to give it at the night. And
OD,
otherwise,
it is in divided doses.
OD is just once in the night.
Correct.
And
but
otherwise,
see, when you want to give 5 milligrams, what you usually do? Do you give 5 milligrams once a day at bedtime or whatever, any time, or whether you prefer to give 2.5 milligrams in the morning and 2.5 milligrams in the evening? Yes, Kedar.
Half-life of the drug is in hours.
Okay.
So it doesn't matter whether give OD or BD. It's going to be same. Give OD, much better, patient compliant, patient friendly.
Correct. And the levels which you achieve if you are giving as a single dose are much higher than when you are dividing the doses.
Thank you.
2.5 milligrams, you can increase it up to 7.5 milligrams any day from day 2 to day 5. That's the standard protocol.
Yes.
Then other protocols which are available or which are studied are
the extended protocols like
Extended protocol, 10 days.
For over a period of up to 10 days, and same for the follicular growth. Yes, Dr. Kedar.
See, what you do is give 5 milligram for first cycle for standard 5 days. Then you scan her on the 8th or 9th day. You will have 2 responses. A follicle selection has happened, or there is no change. Now, when there is no change, you continue monitoring her.
Yes.
Give her withdrawal, and then whichever technique you want to use, like extended, step-up protocol, whatever, or add gonadotropin, you should do in the next cycle, not in the same cycle.
Begin with, it should be the standard protocol which be used. And if she doesn't respond to the standard protocol, then shift to either extended protocol, as you said, or maybe a step-up protocol when you give 2.5 on day 2, then 5 and 7.5 and then 10. Correct?
Yeah.
Right. A single dose protocol in which you give 20 milligrams as a single dose on day 4 is also studied by Mitwali and Casper. Or stair-step protocol, as you said, 2.5 milligram to start up with, do ultrasound on day 10. If she is not responded, increase the dose to 5 milligram in the same cycle. Again, do the ultrasound on day 18 and keep on doing it till you reach 7.5 milligrams. That's the protocols which are available, but all of them should be used only if the standard protocol, the patient is not responding to the standard protocol. Dr. Asmita, Dr. Mansi, do you do the same way that Kedar and Bharati madam are doing, or you are doing a little differently? You start with 2.5, or as Kedar said, you go directly for 5?
5. I start with 5.
Okay. So all of you are starting with 5. No one is starting with 2.5 milligrams.
If the AMH is more than 5, so does the dose will vary? If the AMH more than 5 or 6, you can say. Will the
PCOS
yes,
or
Kedar?
non-PCOS? Would you
Yeah.
like to change the dose or would you like to keep the same dose?
No. The first cycle will be always 5 milligram for 5 days. You cannot change. If the BMI is high, if the lady is obese, you are likely to respond better than thin lean PCO.
Yes.
So obese patient is going to respond better than thin lean PCO. That's only one.
5 milligrams.
Yeah.
Five.
Correct.
Okay.
But then in a lean thin PCO, lean thin patient, you may start with 2.5 as well, right?
No, they will not respond. Thin lean PCO, they will not respond. So you will have to give standard dose and then do step up and staircase.
Subsequent cycles we can step up with it.
Perfect.
Okay, next.
Perfect. So there is a difference between thin lean and an obese women.
Yeah.
So the next question is PCOS, letrozole or CC. We have already discussed this. Next, we can take up the question. Let's yeah. Okay. So there are various.
These are various studies which showed that letrozole is better than CC in.
Now the question is
PCOS.
Yeah.
Okay.
Now the next question is when to add gonadotropins in OI.
And which gonadotropins?
Yeah. Choice of drug.
1 year ago, it was the sponsorship which was matters. Now it doesn't matter at all. Any drug you use is going to produce the same results. I do not believe that the LH contained in the HMG is going to affect in PCOS when her LH is so high. So it just doesn't matter. Use any drug you want to, but decide the dose which is correct. That is what is important.
So what is the criteria to deciding the dose? Which one you are going to decide and which day you should start?
On the second day of the cycle, when you do a scan, first of all, ask yourself, why are you doing ovulation induction for? So it's a ovulation induction for an ovulatory cycle. Your aim is to produce single and unexplained 2 to 3. Then you see the previous response. My neighbor has given 150 and she had hyperstimulation. So I should start with 75 or 100.
Yes.
Then I look at the antral follicle count. I look at the AMH.
Yes.
And then look at the affordability of the patient. If the patient is not very affording, I give letrozole 5 milligram, 1 day break, then start with HMG, 75 to start with, give for 5 days.
Every day, alternate day?
Every day, alternate day does not have importance at all.
Yes.
Even if you are giving, say, 50 milligram or, half the dose, you have reconstituted the injection. It has to be thrown in the dustbin.
Yes.
Next day, it has got no efficacy. You have to use fresh injection every day.
Indeed.
Nikhil is asking me to stop. So we'll just quickly go through the last couple of questions which I wanted to you to have on this thing. Okay. Roll of metformin, roll of myo-inositol. Metformin we have already discussed. We won't go into it. Myo-inositol. How many of you are using myo-inositol as an adjuvant in ovulation induction? In which patients you are using it? PCOS, all PCOS, PCOS obese, PCOS thin. Yes,
many months.
Bharati madam?
Yeah, I would use it in obese PCOS because myo-inositol helps in reducing the insulin resistance. It increases the sensitivity of insulin and it improves the glucose utilization. At the same time, you see that it increases the sex hormone binding globulin and therefore improves reproductive functioning of that particular insulin.
Dr. Kedar,
And the quality of the eggs definitely improves. So I believe in giving myo-inositol before starting gonadotropins at least 2 to 3 months. So that the milia interior of the ovary is normal.
All PCOS women.
Obese PCOS who have high insulin resistance.
Only documented insulin resistance patient, I give metformin.
Insulin resistance.
If metformin is intolerable, then only myo-inositol. Other group is adolescent PCOS, where giving metformin will cause convulsion in the family. Then I give myo-inositol. The only thing is, it's a water-soluble vitamin which is costing 28 and 30 rupees a tablet, which is not acceptable to me.
So next question is, what is the role of laparoscopic ovarian drilling in OI? And when should be done?
I want all of you to quickly tell in which patients.
And when we should do it? And how many? That whole second, that is also important.
Especially when the LH is very high, 10 international units, BMI is more than 30 kg, and AMH is high, 10, and then you would go for monopolar only for 4 mm with 4 watts and immediate cooling of the ovaries.
Yes, Kedar. He wants.
Only clomiphene resistant patient to be subjected.
Yes.
Patient who are good responders are high LH, shorter duration of marriage, high AMH, high testosterone. Punctures of only 4. Patients which are poor in responders are long-standing infertility, low LH, obese woman will not give good results. So you have to be very, very selective, and LOD is a procedure to be planned before you put the trocar in.
Yes.
Not on the table thinking that the ovaries look bulky, let me do some cauterization.
Perfect.
It's a completely wrong way of doing it.
Dr. Manasi, quickly, in thin PCOS women or in obese women?
In thin PCOS women.
PCOS.
Dr. Anjali, madam.
In thin, not very obese.
Yeah. Okay.
We discussed this.
Yeah.
We discussed this.
Now, so with respect to the time, the next module is
So
just take
last
2
question,
questions.
in a
Yes,
hypo
please.
case, what would you be doing? Dr. Asmita?
Hello.
Yeah, in hypo case, what would be the drug of choice for ovulation induction?
HMG, sir.
HMG or FSH?
HMG.
Why
If
not?
hypo, LH is low, of course we have to use HMG.
Why HMG and not why, and why not FSH?
Hello.
Yeah.
So she's a case of hypo.
So she needs both FSH and LH. So HMG is the drug of choice.
Why she needs LH?
She's a hypo, sir.
Okay, Kedar.
The first part of the ovulation induction, LH is required for induction of the receptors. So there is some amount of LH required, but I give them 2 to 3 cycles of oral contraceptive pills to make the uterus size normal, and then give the HMG. And the dose required is little higher. It's not going to be 75. It's going to be little higher. So you have to count than that. 150 is the drug I would normally start in hypo. Sometime. Yeah.
Adding LH is because if you add only FSH, there will be a follicular development which will be seen on ultrasound, but there won't be an endometrial development because the substrate which is needed for the estrogen production is not there, which is only seen if LH is acting on the ovary. That's the reason why we are adding LH to FSH and giving HMG instead of giving only FSH in hypo patients. Okay, we are running short of time.
We'll just speak to the
I have to cut
only one as we go with that ovulation induction. When is the time like OHS, ovarian hyperstimulation syndrome, and how do we prevent that, and what is to be monitored during ovulation induction? Those who have not with the IVF setups, those who are doing IEI or the routine practice, those gynecologists who are inducing the patients, what precautions they should be taking to prevent the OHSs, and what is the criteria, and when to stop, and how do you manage that? Yes, Kedar. Dr. Kedar.
Start with lowest possible dose. When the patient is not, means 75 or 150 or 100, whatever you've calculated. If the patient has not responded, don't step up the dose by double. Step up by 50%. If your radiologist is doing the scan, tell him to report each and every size of the follicle, because it is a cohort which is coming up, which is very important.
Indeed.
And if you still get a hyperstimulation, first thing is pick up a phone and call an IVF specialist. Because for them, for you is a PPH, for them it's a control over hyperstimulation everyday game. They will tell you, do not give SCG trigger. If at all you want to give a trigger, you can give agonist trigger. And to prevent.
Sorry to interrupt.
Okay.
Thank you.
Okay, thank you. Thank you.
Panelists, Dr. Kedar, Dr. Bharati, Dr. Manasi, Dr. Asmita, Dr. Daya, Dr. Mugdha. Thank you all of you
I'm sure
for joining today.
Yes.
Giving your inputs.
Thank you. As a valuable lot of inputs we have received from the experts, and ovulation induction to be a part of routine game. How you should deal with, we have learned from the experts. Thank you all the panelists.
Thank you so much.
Thank you so much.
Thank you, moderators. Thank you, moderators.
Next panel.
Thank you.
Thank you, my co-panelists.
Yes.
Thank you. Thank you.
But and immediately I would like to introduce our moderators for the panel. I request Neera from the AV team to mute all the others for now, so that we introduce the moderators. Dr. Sujata Dalvi is the moderator for our next panel. She is a consultant, OB-GYN consultant at Mumbai. She is the Honorable Clinical Associate as well from Naroji Wadia Maternity, Jagjeevan Ram Railway Hospital. And we also have Dr. Amay Purandre sir, who is a Joint Secretary, FOXI 2019, Chairperson, Food and Drugs Medical Surgical Equipment Committee, FOXI 2015 to 2017, Assistant Administrator, FOXI Manyata Project, and Quality Care of Self Childbirth. And he's also received many awards as well as Dr. A.E. Dastur Gold Medal and Dr. B.N. Purandre Gold Medal Awards, DGO, Prince of Wales Gold Medal, and Dr. C.G. Saraya Gold Medal Awards, and many more to name a few. Moving ahead, I would also like to take time to introduce our panelists. We have Dr. Akash Tube, who is a very well-known doctor from Pune. We've got Dr. Ami Date, who has got a total of 11 years of experience. We've also got Dr. Anil Bendre, who is the president of Ahmednagar OB-GYN Society. We've also got Dr. Bansi Shinde, who is a consultant gynecologist at the Shinde Hospital, and Ankur IVF from Ahmednagar is a past secretary AOGS. We've also got Dr. Jeevan Chaudhary. He's got many awards as well, and he's got 12 years of experience. We've got Dr. Krishma Dafle, who's one of the best IVF fertility specialists over here and has got over 10 years of experience. We've got Dr. Saili Kari. Saili Kari Bugam is amongst the best doctors specialized in OB and GY and has over 21 years of experience. And last but not the least, we have Dr. Mini Salanke ma'am, who is a prominent obstetric gynecologist right over here in Pune at Kalani Nagar. And I now hand it over to Dr. Amay Purandre. And yes, I am aware we are 9 minutes ahead of time, and I shall take a note of that. Over to Dr. Amay. Thank you.
So thank you for a nice introduction of the moderators as well as panelists. At an outset, on behalf of myself and Dr. Amay Purandre as the co-moderator, I would like to express my gratitude and thanks to Pune Obstetric Gynaecological Society and POGS President Dr. Harshad Parasnis and POGS Secretary Dr. Ashwini Kale for giving us an opportunity to have a panel discussion, be a moderator on adolescent endometriosis. There is some disturbance.
Dr. Ami, there is an echo coming from your end. Krishna Ami?
Just figure out where the disturbance is coming from.
Krishna Ami, can you hear us?
We had planned to have a physical meet, but probably because of so-called second wave of corona, that we decided to hold on, and we are on a digital platform. So before we start off with our panel discussion, I request my co-moderator, Dr. Amay Purandre, to introduce the topic. But there is still a disturbance somewhere. Please figure out, okay?
Thank you, POGS. Thank you, Dr. Harshad and Dr. Ashwini, for extending this invitation. It's indeed always a great pleasure, privilege to be a part of POGS activities. The pandemic has prevented us from reaching Pune today, but I'm sure that very soon we will be able to overcome, because Pune has given us the vaccine. I'm sure that Pune will also give us the victory over the pandemic. Hilary Mantel, one of the most popular best-selling authors, herself suffered from endometriosis ever since she was an adolescent. And she went on to say very realistically and stoically these following words. In my 20s, I was in constant pain from undiagnosed endometriosis. With no prospect of cure, I decided I needed a career like writing. Why? Because that could accommodate me being ill. And I think this is probably the plight of most of the young girls or young ladies having adolescent endometriosis. They learn to cope up with the pain and the difficulties. And we as obstetricians, gynecologists, and women healthcare providers should take the onus to ensure that we improve their quality of life and preserve their fertility. Discussing these issues this afternoon, we have eminent panelists from all over Maharashtra, and I'm happy that they will be giving very interactive and very important and vital take-home points. Over to Dr. Sujata Dalvi to proceed with the panel.
Thank you, Dr. Ameya. Now, little introduction about an endometriosis. Endometriosis is basically a disease of reproductive age group. It is not so uncommon in adolescent. It's not very common in an adolescent age group, but it's not very uncommon also. Today, we will be discussing on an adolescent endometriosis. Majority patients with an endometriosis, the symptoms do start in an adolescent group, but sometimes these symptoms are looked over and they are not being taken care of, or maybe they're just being treated symptomatically. And by the time the patients present to us, they are a little bit more in a reproductive age group, and that's when we start getting an endometriosis. I think young women with a pelvic pain or a dysmenorrhea, mind you, one of the differential diagnoses of endometriosis always has to be kept at the back of your mind, and you should try and investigate the patient accordingly. And this is basically to avoid any delay in the diagnosis, because mind you, endometriosis is a chronic disease, but it's a benign, but it's a chronic and it's a progressive disease. And as the disease progresses, it causes more of a morbidity over a period of time, and hence the main key is an early diagnosis and an optimal management. Dr. Meyer, next one. I would like to ask the panelists, what would be the incidence of endometriosis and how much of it is quite common in an adolescent group? Anybody can take it. Otherwise, I'll start with maybe Dr. Akash can take it. What would be the incidence of endometriosis? Dr. Akash, you can just unmute, yes. And what would be, how common is it in an adolescent age group? Dr. Akash?
5 to 38% of adolescent with, hello?
Yeah, we can hear you now.
Okay. Actually, in cases of chronic pelvic pain, 25 to 38% are suffering from endometriosis. And if
yes,
64% of those with chronic pelvic pain with that undergo laparoscopy.
So, yes, and any patient who has undergone a laparoscopy, almost for a chronic pelvic pain, you find incidence of endometriosis is almost about 64%. That is very high so far as a patient of a chronic pelvic pain is concerned. And what about the adolescent group, Dr. Akash?
Approximately 50 to 70% where pain is not controlled with ocipils and NSAIDs.
Yes, so any patient who is resistant to whatever treatment they have given, especially in the adolescent group, the possibility of endometriosis has to be kept in mind. Endometriosis originally was thought to be concerning women over with a 5 years of an ovulatory cycle, means whichever women, so it was not thought to be present in an adolescent group, but it was found to be even in a premenarchal group, but mainly it's a dysmenorrhea, which is a main symptom, or a chronic pelvic pain, which is a main symptom. I want to ask the next panelist, Dr. Ami, when will you suspect it will be a secondary dysmenorrhea? There is something known as a primary dysmenorrhea and a secondary dysmenorrhea. When would you presume that it's a secondary dysmenorrhea? Because most of the time, whenever there is pain in an adolescent age group, we always presume it to be a primary dysmenorrhea.
Yes, ma'am. Primary dysmenorrhea would mainly present in girls maybe 6 to 8 months after the onset of their menses. Whereas if an adolescent girl who has just started menstruating is not menstruating adequately and still complains of cyclical pelvic pain, which later on turns into an acyclic fashion and is not responding to the basic over-the-counter painkillers, or sometimes even a hormonal treatment is given by the family physicians just to combat the pain. If she is really not responding well, then we should keep endometriosis at the back of our mind. Because mostly it is seen that in primary dysmenorrhea, after the onset of ovulatory cycles, the pain factor starts. Whereas in these patients, they would present much earlier.
Yeah, that is true. Should not ignore in case the pain is not relieved. Possibility of an endometriosis should be kept in mind, even if the girl is in an adolescent age group. As we go to the first case,
18 years old unmarried girl. She presented with the progressive dysmenorrhea and she also complained of periodic bloating, diarrhea and constipation over last few years as such. Clinical examination, abdomen per abdomen was normal. Per vaginal examination could not be done. However, per rectal, she did allow a very gentle per rectal examination, though she was very uncomfortable, but it was also normal. Sonography showed pelvic structures and even the lower abdomen structures all normal. I would like to ask Dr. Anil Bendre, what would be your management approach? This girl has come to you with a mother. Mother complains that she complains of her dysmenorrhea, doesn't get that much of a relief. How would you go about, Dr. Anil Bendre?
Yes, yes. Can you hear me?
Yes,
Hello?
we can hear you, doctor.
Yeah. As you said that dysmenorrhea in this patient is progressive. She is more likely to have endometriosis, although endometriosis will be a diagnosis of exclusion after excluding other causes of pain in abdomen, including gastrointestinal tract abnormalities, urinary tract abnormalities, or concerns about those pathologies. After ruling out everything, we can say that the patient might have dysmenorrhea because it is cyclical. And moreover, sometimes the patient may not have only cyclical pain. She can have non-cyclical pain also in case of adolescent endometriosis. Okay. So the first line of treatment in such case will be giving NSAID. NSAID will relieve pain in most of the cases. If she doesn't respond to NSAID alone, then I will go ahead with a 3 months trial of OC pills. Cyclical OC pills which are having minimum possible estrogen and progesterone in those.
Okay. Apart from endometriosis, any other diagnosis that one could keep it in mind if patient has got pain, ruling out any GI or urinary symptoms? Dr. Bansi Shinde? Apart from endometriosis, anything else that you would still have it in mind?
Ma'am, since it is progressive, am I audible, ma'am?
Yes, you're audible, doctor.
Since it is progressive dysmenorrhea, it is less likely to be other causes. So first, my primary diagnosis will be possibility of endometriosis.
Endometriosis, yes.
And because USG has not shown any abnormalities, so again the endometriosis is the diagnosis as per exclusion criteria.
Okay. What are the other symptoms of endometriosis apart from pain, Dr. Jeevan? Yeah. What are the other symptoms or clinical features of a patient with an endometriosis apart from the pain? And what type of a pain? They've already described cyclical and acyclical. What could be the other symptoms of a patient with an endometriosis? Dr. Jeevan Chaudhary?
Good afternoon, madam. Good afternoon, everybody.
Yes.
As you have mentioned, there is progressive pain is the first feature. Along with that, it may be cyclical or acyclical. Secondly, in the last case, intestinal symptoms like bloating, pain in abdomen, and constipation can be there. Along with that, if deep endometriosis is there, the urinary symptoms can be there in the form of dysuria. Again, if that septum is involved, then dysphagia is there, which is very classical of deep endometriosis.
Deep endometriosis. Dysphagia is very classical of deep endometriosis. Anything else? Any strong family history that would point you towards that patient could be having endometriosis?
Yeah, if there is a family history, then we can suspect at least 5 to 7 times there is a greater chance of having that endometriosis in the particular patient. Along with that, if there is a history of fibrocystic disease also, it increases the risk of endometriosis.
Yeah, and in case the young girl is sexually active, then she may not give history of dyspareunia at an outset as such, but when you ask her confidently, she might just come out with that history of dyspareunia, which will also click in your mind that she could be having endometriosis.
Madam Amey, here one important point that I want to make is that the pain that is there, one needs to go deeply into that and assess its severity, and therefore maintenance of a pain diary would help in such a situation. She could tell you how much the pain is, when is it occurring, is it related to the periods or is it present at all times? And regarding the severity, is the pain so severe that even her daily activities like school, sports, recreation, all are affected? So I think you have to look at all points and have a thorough interview with the patient, maybe the girl as well as her mother.
Yeah. Anyone knows about the pain diary? I just wanted to ask, since Dr. Amaya has already cropped up. Yeah, has anyone told any patients to keep a pain diary? They have to keep it day-wise and they have to keep it hours-wise, at which time of the day they have a maximum pain. If they have maximum pain, they could put the points that way, and whether it restricts any activity, whatever they are doing it. So coming to the frequency of presenting symptoms in adolescent with endometriosis, both cyclic and acyclical pain could be almost about 60%. That 60%, that's quite a bit. Acyclic pain found to be in 28%. Cyclic pain was found to be in 9%. GI symptoms along with the pain was found to be 34%. Urinary symptoms little less as compared to GI symptoms at 13%. Irregular periods in 9%, and vaginal discharge in almost about 6% of the patient. Now coming to the adolescent endometriosis, I want to ask the next panelist, Dr. Karishma, what are the challenges that one faces while doing a clinical examination? These are young girls. You can't do a per vaginal examination. You want to find out what exactly is wrong with why they are coming. What are the challenges that one faces in that young adolescent girls?
Yes, ma'am, because they being young, chances of doing a per vaginal examination or doing a transvaginal sonography, which will help us in guiding the diagnosis of endometriosis, is difficult. So history taking main pointers like if she had early menarche, she has heavy bleeding, menstrual cycles. Again, the family history. If a mother or a sibling has it, there is a high chance that she might have it. Also, if her weight is low BMI, if her weight is low, and also some Mullerian anomalies, also they might lead to endometriosis. So
how will you figure
obviously,
out a Mullerian anomaly? Yeah. How would you figure out a Mullerian anomaly?
and
Yeah.
by doing an ultrasound,
Yeah,
3D
even
ultrasound.
without doing ultrasound, suppose if you have to just find out on clinical examination whether
Severe
she's having some, yes,
yeah, severe pain during menstruation, and very scanty menses or no menses.
yes, in case there is a possibility of any transverse vagina, imperforate hymen you'll be able to make out, but in case there is a possibility of any transverse vaginal septum or even a vaginal atresia, can you do it gently in these girls, young girls?
Gentle PV is always possible.
Gentle PV, but explaining everything to her. Otherwise, you can use a small uterine sound of a very small Q-tip sort of a thing to find out what is the length of the vagina, whether you meet with any resistance or no. That way you can find out that there could be a possibility of a transverse. This is only on the clinical examination as such. Then beyond that, what are the investigations that you would want to confirm whatever you found it on clinical examination? I would like to ask the next panelist, Dr. Saili. Dr. Saili? Okay, she's not there. Dr. Mini? Okay, fine. Dr. Ami, you can start off with this. What are the investigations that one would carry out to confirm your clinical diagnosis?
Yes, ma'am. The first and the foremost investigation which I would like to do is to do a transvaginal ultrasound. If there is a possibility of a 3D ultrasound, it would help me in getting closer to the diagnosis further. Now, if there is a clear-cut presence of an endometriotic cyst, or if we can see the presence of any other obstructive Mullerian anomaly, especially say a bicornuate uterus with one horn non-communicating, all these things, minor things, can definitely be picked up. But if we are looking in terms of the minor lesions or in terms of deep infiltrating endometriosis at the outset in these young girls, it would be really difficult to pick up on a transvaginal ultrasound, or rather a transrectal ultrasound in these girls.
Yeah,
not a perineal ultrasound, not a transvaginal ultrasound. I take back my words. So that would really be a difficult situation in these girls to actually come to a diagnosis if she's not having a clear-cut lesion. MRI pelvis also really is not very helpful. Yeah.
Yeah. That will come to it later. CA125 help you any as such. I just wanted to know. Before being even just CA125 as one of the tests, will it help you?
May or may not be elevated. It is elevated in grade 3, grade 4 or stage 3, stage 4 diseases. But right in the beginning of her adolescent career, if she has this kind of dysmenorrhea and endometriosis related problems, it may not be elevated. So
I want to ask Dr. Anil. Yeah, I have to ask Dr. Anil, what are the other aging sources that you have it to make a diagnosis like MRI, CT, or even 3D ultrasound? How far are they useful to make a diagnosis?
As far as mild to moderate endometriosis is am I audible? Hello?
Yeah, you're audible. Yes.
After doing a transabdominal sonography, and if you don't find anything, I don't think that MRI and CT scan is going to be of any help. MRI and CT scan only come into play only when you are suspecting a deep infiltrating endometriosis and endometriomas. And endometriomas also can very well be diagnosed by transabdominal sonography. So I think there is a very less role of MRI and CT scan in.
What about detection of Mullerian anomalies on MRI or this thing? Will it be helpful? Mullerian anomalies or obstructive anomalies?
Transabdominal sonography can also be very good in diagnosing, especially 3D ultrasound can be very useful in diagnosing this type of anomalies. But certainly MRI will help in boosting the diagnosis of Mullerian anomalies.
Yeah, so even these imaging technologies, they do have their own limitations. Deep infiltrating, if it is in the form of nodules, may be picked up on an MRI.
Yeah.
But otherwise, in an adolescent age group, you don't find such sort of an endometriosis this thing. You find only the initial stages of just vacuoles and maybe peritoneal defects, which is very difficult to be picked up on an imaging, whether you try 3D or whether you try MRI.
Even on MRI, yes.
Yes, it is very difficult to be picked up.
So the important points to summarize, even imaging has limitations in adolescent endometriosis.
Yes.
We all agree that it is less useful in the diagnosis because endometriomas occur rarely and superficial endometriosis, that is peritoneal lesions, cannot be picked up on sonography. Where sonography is really useful is helps to exclude all the other causes of pelvic pain, such as ovarian torsion, hemorrhage, tumors, genital abnormalities, and even non-gynecological causes like appendicitis.
Yes.
MRI, like Dr. Bendre said, will be helpful to better define an abnormality which is picked up on sonography, but it should not be used as the first line imaging test because of its cost effectivity, also the sensitivity to pick up peritoneal lesions or staging endometriosis. More useful in deep infiltrative when you have picked up something or you find that there is some rectovaginal nodule. As far as CT scan is concerned, it is an insensitive method in the diagnosis of endometriosis unless you see a frank endometrioma on sonography. So we must keep this in mind as clinicians and use them judiciously to gain more advantage and rather not confuse further management and also confuse and psych the patient or make her more anxious by ordering such extensive investigations.
Yes, very clear.
We go to the next one, that COG has given a guideline. Case of an adolescent age group patient comes to you with a dysmenorrhea, how would you go about it? Dr. Akash, would you like to take this up? ACOG's recommendations stepwise in case adolescent age group patient comes with a dysmenorrhea.
Supportive imaging for diagnosis, then first line of treatment will be NSAIDs and then cyclical OC pills.
Okay, so before you start up with the treatment, at least you need to go into the details of the history and the examination and then preliminary investigations and keep a pain diary, which has already been discussed, maybe on a sonography, and then you can start giving the treatment. I would like to ask Dr. Bansi, how would you go about if a patient gets relief of pain with NSAIDs or she doesn't get relief? How would you go about it? Dr. Bansi?
Ma'am, initially, if she gets relief with NSAIDs, we'll continue with NSAIDs and we will follow her up regularly. In such cases, if we suspect endometriosis, adolescent endometriosis, we need to counsel the patients and parents also that if endometriosis is the diagnosis, she will need a long-term follow-up and long-term treatment. As far as she's getting relief with NSAIDs, I will continue with NSAIDs. And if no relief, then we'll go to the cyclic OCs.
Yeah, so in case patient does not have relief with the NSAIDs, maybe even with cyclicosis, she may not get that much of relief. Then how do you go about it? Any other medication that you can give to confirm a diagnosis that this could be endometriosis?
Ma'am, it depends upon her age. If suppose she is more than 18 years, then we can try for GnRH analogs for 3 cycles. If she gets relief, then it is confirmed diagnosis of endometriosis.
Endometriosis, yes. Then how do you go about? If you have confirmed the diagnosis, then how do you go about?
Ma'am, during giving GnRH or progestins, we have to support with calcium support that she doesn't lose bone mineral density.
Yeah.
That is
and
one
how
support
long
I
can you give GnRH? How long can you give GnRH?
Ma'am, not more than 6 months, but trial 3 months, then at the most 6 months.
Okay,
and if
fine.
suppose on ultrasound she is having deep infiltrating endometriosis or endometriomas, laparoscopic treatment will be a choice, but not at first sight. It will be a later on.
See, deep infiltrating laparoscopy, they will agree. But in case she gets a relief with GnRH agonist, and then in case you want to ask her that, okay, let us confirm through a laparoscope, would they agree for a laparoscope? If at all you have put in a laparoscope, what do you find on a laparoscope as such? Because these are all adolescent age group patients where the endometriosis has just started. I would like to ask Dr. Karishma. Yeah, Dr. Karishma.
So if the patient has relief with medicines like GnRH analogs or progestins, so definitely I will not suggest laparoscopy immediately, but if after 6 months of giving her medical treatment and there is no relief, pain relief, then I would suggest a laparoscopy, ma'am.
That possibility of a laparoscopy, yes. What are the other findings that you find on a laparoscopy in a young adolescent age group?
Yeah. So, ma'am,
And what
there
do
are...
you do with that?
Yes, ma'am. So multiple spots on the uterine surface, like clear papules, vacuoles, red, white spots. So we usually suggest excision of the same.
How do you excise it, or you just cauterize it?
We can
Because
cauterize
it's
as
difficult
well
to
as
excise
excision.
all these
Yeah.
spots,
Yes.
you know, because these are just the beginning, and you get this peritoneal defects also. It's very difficult to excise a thing. So what do? You just surgically ablate, or you just cauterize it and place?
Yeah, ma'am. Surgical ablation can be done, but chance of recurrence is there. The whole disease cannot be removed entirely by ablation.
That
but
is true.
In advanced hands, in good hands, excision can be practiced.
Yeah, that is it. Yes. Dr. Amaya, the next. So this I've already said. In case you find that on a pelvic, on a laparoscopy, you don't find any endometriotic lesions, but patient still has pain. What would be your diagnosis as? What would you look out for? Dr. Jeevan? On a laparoscopy, you don't find any abnormality in the pelvis. You don't find any endometriotic vacuoles on it, but patient's pains are still there. What are the other investigations you would like to carry out? Dr. Jeevan?
Hello, madam. So laparoscopy is negative, and patient
symptoms are still there. Yes.
So there is very less chance that there is endometriosis, but still we need to look. We need to look into that pain as a. There is a probability not more than 1% that endometriosis is there, but other causes, it makes a case for to evaluate other causes of the abdominal pain.
Yeah, either a GI or maybe urinary symptoms. So you need to have a multidisciplinary approach, because patient pain should get relieved. Patient should have a symptomatic relief so far as the symptoms are concerned. This is an algorithm for the same. Yes.
For a case to label as a negative laparoscopy, the laparoscopist should have that expertise to look at, and we need to assure regarding the competence of that person also. Secondly, means there should be thorough evaluation starting from uterus, backside of the uterus, adnexa, uterine fold, bladder surface, along with that appendix and cecum. These are the sites we need to check and then label it as a negative laparoscopy.
Negative laparoscopy. Thank you so much. Yeah,
one important point I want to make is that in this algorithm, you will see that 2 important ages of the patient are put. If the patient is more than 18 years of age, the first line agent could be empiric GnRH agonist. But if the patient is less than 16 years of age, we must first offer her cyclical OCs
Hormone.
and not GnRH agonists. Only if she doesn't respond to to cyclic OCs, then you need to explain to her that we need to give GnRH agonists, but GnRH agonists can have an effect on her future growth and development. So you have to counsel her properly and also try to give it for a shorter duration and then de-escalate it back to once the pain is controlled back to a cyclic OC. So that's one important point in this algorithm.
Hello.
Yeah, doctor.
One little addition to that. First of all, we will rarely be doing a diagnostic laparoscopy on an adolescent patient for just a purpose of diagnosis. We rarely do it unless we see something conclusive that patient is having endometriosis, or rather it is visible endometriosis on ultrasonography. And if at all you are doing a diagnostic laparoscopy and if it comes negative on prima facie, means on laparoscopic view it is negative, one should always take a biopsy of posterior POD peritoneum to confirm the diagnosis, to rule out the diagnosis of endometriosis, which can be equally present over there, and that will in turn rule out the deep infiltrative endometriosis. The biopsy is must to completely say that the laparoscopy was negative, if it was done for diagnostic purpose.
It's a histopathological report is the confirmation of endometriosis, but most of us don't resort to an histopathological diagnosis of an endometriosis. We just look at the laparoscopy findings. That's how we arrive at a diagnosis.
If the laparoscopic finding is negative, then biopsy is must. Yeah.
That is true. Okay, fine. Dr. Ameya.
Yeah. So we move on to the next case now. 16-year-old girl having a sonographic diagnosis of a right-sided endometrioma of 5 centimeters. History of laparoscopic appendicectomy in the recent past. At present, she is asymptomatic. Dr. Bansi Shinde, how would you manage her? She is not symptomatic, but this cyst is worrying her because it has been done incidentally or found incidentally on a sonography.
Initially, I would like to reassure the parents and the patient, and I would like to wait and watch and reassess her by ultrasound after 1 or 2 months and then follow up.
Okay, so on follow-up, also the cyst persists. It is around 5 centimeters still. Is there a role of medical management because she is asymptomatic totally?
Since she is asymptomatic, I will continue to follow her up. And since she's 16 years, I will try to avoid to do progestins at present at least. And after, if a follow-up shows there is growth in the endometrium, then I can think of doing progestins.
Would you be tempted to put in a laparoscope in this patient?
Not so early, because I will try to be more conservative in such girls, because they can be a repetitive and recurrence rate is very high in such patients. And they will be the patients for recurrent laparoscopy and recurrent surgeries. So I will avoid that.
Okay. Now there is one school of thought that, like we said, that endometriosis is a progressive disease. My question is to Dr. Ami. Dr. Ami, will you give her cyclical OCs to arrest the progression of endometriosis? It is not a symptomatic endometriosis, but it is a sonographically diagnosed endometrioma.
In this case, yes, I would give her cyclical OC. If she's just 16 years of age, then I would just, as Sir rightly said, would just monitor her on ultrasound. But if I feel that the lesion is progressing and she becomes symptomatic in future, I would definitely consider putting her on cyclical oral contraceptive pills to prevent the future progression of the disease and also to keep her fertility safe. Because with the progression of the disease later on, these patients would present to us with infertility. So we have to think with that point as well and suppress disease.
Okay. Anil sir, question to you. This patient, after 6 months, as Dr. Ami and Dr. Bansi have said, we did a sonography again, and now it has come as 8 centimeter cyst. It is unilateral still. Would you advise her laparoscopy now?
Coming to a previous question, actually medical therapy does not arrest the progress of endometrioma. So if the patient was asymptomatic, there is no role of OC pills and even NSAID because she does not have any symptoms. We will just monitor the patient for the growth of endometrioma. If the endometrioma is increasing, then certainly there is a role of laparoscopy. There is no role of medical therapy or NSAID in this case. If the endometrioma grows to 8 centimeter size, then there is certainly a role of laparoscopy to arrest the growth of endometrium and to save that ovary.
Okay. Now, sir, you have counseled the patient regarding laparoscopy, but the family is very worried and they say we don't want laparoscopy at the present moment. What can we offer her? It's easy to say that we should do laparoscopy, but in a young girl who is asymptomatic, they are just not convinced. How would you convince them? And if they are not getting convinced, can we resort to some other treatment in the time being before they get convinced?
Actually, as I said, that any type of medical therapy does not arrest the progress of endometrioma. If at all she needs treatment, she has to be treated with laparoscopy. And having said that, I will always counsel them that the first laparoscopy will be the best laparoscopy and will be done in best hands. If I can handle it thoroughly, completely, then only I'll attempt laparoscopy. And laparoscopy is the only choice in this patient if the endometrioma grows to 8 centimeters, I think.
Okay. I move on to Dr. Karishma. Dr. Karishma, this patient starts developing pain. Now she has got only pain as her symptom and she is not willing for laparoscopy. What would be your approach to provide pain relief?
So, sir, basically endometriosis is a chronic inflammatory disease. So any anti-inflammatory drugs will give her good pain relief. So NSAIDs like ibuprofen, naproxen can be given. If no symptoms with that, no relief with that, then we can move on to contraceptive pills. But NSAIDs give a good pain relief, sir.
Yeah. So like you rightly said, NSAIDs can be safely given, but we need to run a checklist. Any other coexisting medical diseases or any other medications she is taking, which are likely to get interfered by this NSAID, which is going to be taken over a period of time, one needs to keep in mind. Also, patients who have got some existing renal insufficiency, we have to be careful in giving NSAIDs because some of the NSAIDs may be nephrotoxic. All this is because we are going to give them over a long period of time on a daily basis. My question to Dr. Bansi Shinde. Dr. Bansi Shinde, she is symptomatic. She is not willing for laparoscopy. Dr. Bendre has tried to convince her for laparoscopy. She is not ready to listen to Dr. Bendre. She comes to you now. Will you advise her she's ready to take any tablets. What will you advise?
I will try to put her on Dynogest 2 milligram daily with calcium support, and it will be a trial for 2 to 3 months.
Okay. So now Dr. Bansi says that we should give her Dynogest. Now this girl is a smart girl. She is of the Google generation. And she goes back again to Dr. Anil Bendre and she said, sir, I have been told to start Dynogest. And I find that Dynogest has got this black box warning. It should be used in caution with adolescents. Sir, what is her concern? What does Dynogest cause in adolescents?
So Dynogest, if it is taken for long time, then it can cause loss of bone mineral density. That is the only concern. I don't think there should be any other concern about Dynogest. Dynogest is a very safe drug otherwise.
Yes, so you are absolutely right. Dynogest is an extremely safe drug. It's an extremely effective drug in controlling endometriosis. But one must keep in mind, especially in the younger age group, like you said, bone mineral density issues could be there. So if she is frail, then in that case, you should monitor her BMD at least every 6 monthly or 9 monthly. Yes. We'll take a slightly different approach. And I'd like to ask Dr. Jeevan, any therapy in alternative medicine which can help her because she's not ready for surgery?
As literature suggests, there is a dietary modification benefit to the patient. So fenugreek and B12 supplements can improve the symptom score. Secondly, acupuncture can help her to relieve some amount of pain because of that therapy. So although data available at present, but dietary modification and these alternative therapy can help patient to some extent. It can act as a placebo, and to some extent the reasons which we are not aware of.
Okay. Dr. Karishma, what
Yes, sir.
is your opinion about the role of GnRH agonist in this patient?
Yes, we can give GnRH agonist. We can give the 11.25 dose for the at least 3 months and see how much pain relief she has. In fact, we have to add add back therapy because of the hypoestrogenism. Cause the symptoms like hot flushes, dryness in the vagina can occur, bone loss can occur. So we have to give her some low dose estrogen pills along with progesterone.
Yes, I think it's very important, and all these studies have shown that a steroid add-back therapy of estrogen progesterone definitely helps in minimizing the side effects and improving her quality of life. We move on to a next case. She is a 20-year-old. Family is coming to you since her childhood. In fact, you delivered her some years back, Dr. Bendre,
Yes.
the mother.
That do happen certainly many times.
We've got Dr. Ashwini also over here. She would also like to, and just wanted to also inform, we also have the next panelist in line. Just a sec.
Sorry, Amay, to interrupt you. I just wanted to thank you and Sujata madam for joining us from Mumbai. We actually missed having you here in Pune. Thank you.
I told you.
You miss.
Okay.
We are missing you, Ashwini.
Yeah. So, Dr. Old lady, well, she's just married and studying. She is very clear she does not want to have a child at present. She has been a known case of endometrioma. Her endometrioma last sonography shows 3 centimeters and her CA125 is 45. The rest of the clinical as well as other investigations are normal. She is not on any treatment. Will you treat her?
Am I supposed to answer this?
Yeah, Dr. Bendre.
The only concern is a little high, marginally high levels of CA125, which is 45, which can be raised in any other pathology, like including epithelial tumors of ovary, can also give rise to increase into CA125 level. So I'll suggest her, if she is not eager to getting pregnant, she's not having any symptoms as well. So I'll just monitor the endometrioma on sonography and monitor her CA125 levels as well. If there is a progressive increase in CA125 levels, then certainly there is the patient should be cautiously informed that the levels are increasing and the diagnosis could be something other than just endometrioma. So in that case, then she needs to be counseled for the surgery.
Yeah. So
otherwise, there is no treatment of no need of any active treatment.
Okay. So now a CA125 was repeated 6 months later, and they found that the CA125 now is 95. Dr. Bansi Shinde, would you put a scope in this patient?
Actually, CA125 increases in endometriosis and endometrioma. In such cases, I would like to do ultrasound color Doppler flows in such patients. And if they are reassuring and no flow pattern is seen, I will wait and watch further.
Okay. So when would you do a laparoscopy in this patient? She's 20 years old, known case of endometriosis, endometrioma seen, elevated, maybe thinking of future fertility. Would you put the scope and, see her pelvis?
I will put the scope when she has any more symptoms or pressure symptoms because of endometrioma, and then I will operate and remove the endometrioma, excise it.
So how does the endometrioma or the endometriotic patches look like in an adolescent? Are they very different from what you see in a reproductive age woman?
Yeah, they are different. We never see the powder burn like black patches in the adolescent group. We see red or white or the clear type patches in the adolescent age group.
Yeah, so the more red the patch, the more painful also it has been correlated as per this study in this thing. One important thing that we must keep in mind that laparoscopy also helps us to stage the endometriosis, which would be important in assessing her future fertility or our threshold for treating her more aggressively when she comes for infertility. Okay. Now, my question is...
Hello, sir. Can I add something?
Sure, sure.
Hello, sir.
Yeah.
Can I add something?
Dr. Jivan, bola.
Sir, the aim of laparoscopy is to get rid of the disease burden somehow. So to halt the progression. Second thing, for future fertility. And third thing, to relieve the symptoms. Here I can see the endometrioma size is not increasing. The means she is adolescent, so at present means the size is 3 centimeter, and that too it is unilateral one. So in unilateral cases I'm aggressive comparing to bilateral, where surgical damage is limited to one ovary. But here the symptoms are also not aggravated, so I will refrain from laparoscopy in this case.
Okay. I move on to Dr. Akash. Dr. Akash, suppose if we don't see endometriosis patches, is there any way by which we can, be able to see them? Because at times they may be difficult to visualize.
We can fill pelvis with normal saline and inspect underwater.
Yes, so this is what is called as the Lawford technique. Like you rightly said, we fill the pelvis with lots of normal saline and inspect underwater, which minimizes the reflection of light, and suddenly we start visualizing the endometriosis. And in Rees et al. Study, he in fact found by using this technique, almost 80% of undiagnosed endometriosis could be visualized in stage 1 and about 12% in stage 2. Obviously, lesser in stage 2 because it is more evident. You can see more marked this thing. Now, I want to ask Ami. Ami, Dr. Bendre said that the first attempt should be the best attempt when you're managing laparoscopic endometriosis. So how will you make it the best attempt? What precautions will you take? And what impact does it have on future course of the endometriosis?
First of all, I would like to evaluate whether she's got a unilateral or a bilateral endometrioma. If there is a unilateral endometrioma, in the first attempt itself, it has to be the entire excision of the capsule of the endometrioma rather than just ablating or draining the endometrioma. Because if we ablate or if we just drain the endometrioma, there would be a higher chance of recurrence. However, at the outset, I would also explain them that since we are going to remove probably some chunk of the ovary, there would be a slight decline in fertility. That is more so because it is a progressive disease. So later on, if she happens to develop an endometrioma in the other ovary and she gets operated, it would further hamper her fertility potential. Also, we would also like to do a complete laparoscopic check, as sir had already mentioned earlier, seeing the peritoneal, the underdiaphragmatic surfaces, the pouch of Douglas, the rectovaginal spaces, and the pararectal spaces, and ablate all those lesions which we see.
Okay.
Just a reminder, Dr. Amay, with due respect, we have run out of time. If you could sum it up, please.
Now, have we finished the timing or?
Yes,
we
we have finished.
How much time do we have?
Actually, we have finished the time, sir.
Okay, fine. May I just come to the conclusion that makes more sense?
Okay. So we'll skip the fourth case, which was a case of ruptured endometrioma. Obviously, this is an emergency and has to be managed as an acute abdomen with careful evaluation. Quick word, Karishma, about the role of oocyte freezing and ovarian cortex freezing. Which would be the patients?
In a case of a bilateral endometriomas, if you are dealing with that.
So bilateral endometriomas, I'll be better with oocyte freezing if she is above 16, menstruating well. I'll check her AMH prior to the surgery, repeat it after the surgery, and we can do oocyte freezing for such patients. It's truly beneficial for them.
Fine. And which cases you would go in for ovarian cortex freezing?
Very young girls.
Very young means how young?
14, 15, 14 to
16.
15.
Yeah. So these are very rare cases that you might have to do that. Yes.
Okay, Dr. Bendre, quick this thing. How will you follow up once you have done laparoscopy and cleared all the endometriosis? What will be your follow-up management? Any sandwich therapy? Any therapy?
I would like to put this patient on a long-term progestin therapy, preferably. I'll give her progestin for 6 to 12 months.
Okay, so it is important that the surgery is not the end of the management. Follow-up should be there. You look for recurrence. You keep giving her the suppressive therapy with medicines. Bansi, quick thought on thoracic endometriosis. Have you ever managed it? You are muted, Bansi.
Sorry, I haven't come across thoracic, but cyclical symptoms, cough and pain, that can be lead to diagnosis. High degree of suspicion is needed for such cases.
Yeah, I think more complex, we will require thoracic surgeons, etc., to help in symptomatic and severe endometriosis.
Or maybe a chest physician.
Yeah. So the future trends are, we are looking for better molecules. The loss of BMD, which is an issue in adolescent endometriosis, has to be kept in mind and has to be standardized. Add-back therapy is evolving day and night. Aromatase inhibitors, we are finding a role in reproductive or elderly women, but still adolescent endometriosis, we don't have conclusive studies. And anti-tumor necrosis factor therapy is being found to be useful in animals, not in humans. I request Dr. Sujata Dalvi to conclude this session.
Sorry, we had to wind up a little early because of shortage of time. But so far as adolescent endometriosis is concerned, endometriosis per se is a progressive disease. There are significant number of women with endometriosis. They do have symptoms, even adolescent age group, but we take them as a primary dysmenorrhea, and sometimes they are not being investigated properly to find out whether they have an endometriosis or no. Presentation starts with the patient of a chronic pelvic pain or maybe intractable dysmenorrhea. You start off with initiating with a medical therapy because they are all young and in young adolescent age group. In case they don't have any relief with whatever possible medical therapy, then as a last resort, they should be offered a laparoscopy, but laparoscopy should be such that you make a diagnosis and you also offer her a treatment at the same time. Appearance of lesion on a laparoscopy are different than what you see in an adolescent age group. You see red vacuoles as such, or maybe peritoneal defects as such, because these are the initial parts of an endometriosis. COCs, DMPA, or GnRH agonist, or even surgery. These are all practical treatment modalities so far as a patient of an endometriosis in an adolescent age group is concerned. And future research for an adolescent is needed so far as developing a safe, minimally invasive treatment options, but it should be a definitive option for a diagnosis as well as treatment, so that it doesn't hamper her symptoms as well as it doesn't hamper her fertility potential. Over to Dr. Amaya for Thanksgiving.
So the last words before Nikhil interrupts me is that the chill or the winter in Pune is over. I can see Kundan smiling and enjoying the bright sunlight. Spring is here. It is March month. March month is the month of endometriosis awareness. It is celebrated all over the world. And Patch Adams said that you need to treat the disease, and you treat the disease and you will win or you will lose. But if you treat the patient, I guarantee that you will always win. So let us look and bring back the spring in the life of the girl who has adolescent endometriosis. Let us make her feel bright and sunny like the sunshine and the spring month. Thank you all panelists for having us this afternoon. Thank you POGS for inviting us. It was always a pleasure to be here in any POGS.
And we were looking forward to seeing you all physically, but somehow it didn't happen. So thank you so much.
Thank you, madam. Thank you, Amay. Thank you.
We would now be moving to our next panel discussion. We've got our moderators on standby. We've got Dr. Prakash Patil with us. Dr. Prakash Patil is the founder president of ROGS. We've also he's also the member of managing committee of SR. He's also the member of managing committee of AMC. We've also got Dr. Kundan Ingle, a very well-known gynecologist in Pune, and he's also the director of Nirmit Clinic, and he is right with us. I request Dr. Kundan sir to please switch on his camera. We've also got Dr. Kedar Ganla with us. I request Dr. Kedar Ganla to also switch on his camera. We've got Dr. Anaga Pairaiturkar. She's an IVF consultant at Dina Medical Hospital. We've got Dr. Ravindra Dattatre Kulkarni, who is a gynecologist from Pimpri Chinchwad. We've got Dr. Vaishali Chaudhary, who is a consultant at Cloud9. We've also got Dr. Ravindra Kulkarni, Dr. Vaishali Chaudhary, Dr. Veena Todkar, and Dr. Ashish Jalak as well. Over to the moderators.
All right, good afternoon, everybody. I welcome for such an interesting and very practical panel discussion. And we have today with me Dr. Prakash Patil, who is my co-moderator for this session. We Today we thought of like let's discuss ovarian stimulation in a really practical way, so that I request all my panelists to give a very quick answers, short answers, and if you can justify your answer in 1 or 2 lines, it will be more easy. We want to discuss lot many things, so that our colleagues gynecologists, they can do ovarian stimulation and send the patient for oocyte retrieval to us. So we have to give them a very clear cut idea, and sharpen their skills for perfect ovarian stimulation, so that we get adequate number of oocytes. So friends,
Dr. Kundan, put it on a slideshow mode. Yes.
I'm done. So welcome panelists. I think Nikhil has already introduced all of them. They are the experts in this field, and many of them have excellent experience in practicing for many years in IVF. So friends, perfection means not perfect actions in a perfect world, but appropriate actions in an imperfect one. So IVF or in IRT field is such one that where we have so much variations, so much individualization, and so many different technologies and treatment options, and we have to be taking some appropriate decisions for our patients. So begin now to be what you will be hereafter. It is not in the stars to hold our destiny, but it is in ourselves. So we have to always get updated. We have to always learn. This is a continuous process to become excellent clinician. Dr. Prakash, you can start. Dr. Prakash? Are you there? Can you unmute yourself, Dr. Prakash?
Prakash, you need to unmute yourself.
Dr. Prakash, you have to unmute. Yeah.
Okay. Am I audible?
Yes, yes, you are now.
Good afternoon, everybody. And at the outset, I'm thankful to the President POGS, Dr. Parasnis, the Dynamic President, Dr. Ashwini Kale, Dr. Ganpule, and all the organizing team for giving us opportunity to share some of our views on IVF stimulation protocol. Dear friends, can I have the next slide?
Dr. Prakash?
Yeah.
Yeah, go ahead.
I want the previous slide. This is the next.
Sorry, Dr. Prakash.
Can I get the previous slide, please?
Sure. Okay.
Yeah. Dear friends, today we'll be talking if the controlled ovarian hyperstimulation in IVF. In IVF, certainly we want to have achieve some goal for getting good quality and quantity of sites. See, I just wanted to know from my panelists, esteemed panelists we are having today. I'd like to ask them that in regulatory supervision, by turning off the patient own hormones followed by stimulation, what is our aim and objective? I will put it to Dr. Ravindra Kulkarni. Can you answer, please?
Yeah, good afternoon, everybody. Actually, when one has studied the protocols and the ovum pickup and OCG complexes, it has been observed that when you get follicles anything between 8 to 15, the results are the best. So the aim of the gynecologist or the IVF specialist should be to get at least 8 to 15 OCCs or oocytes for a better outcome of the IVF cycle.
Yes.
So if that is the only question I am supposed to answer, then that's all. There are a few more questions to prevent premature LH, but I think other panelists can address those.
Yeah, but what are our goals? Other goals?
If I can add to this, the goals would be, besides having a good cohort of oocytes,
yes,
it should be safe to the patient. That
yes,
is, we should be able to prevent the OHSs, and it should lead to a healthy baby and to a healthy mother later on. whenever we do the transfer.
It will be have cost effective also.
And yes, and it has to be cost effective also.
Right. So my question to Dr. Ravindra, what are the important steps of ovarian stimulation in IVF? So what are those Broadway 3 categories or 3 important steps which you will individually using different drugs you will tackle? So what are those 3 important steps?
Actually, 3 important steps in the IVF stimulation protocol. That means one has to decide, depending upon the protocol has to be individualized. So one has to go through the entire history, what has happened earlier, whether she had previous cycles, what are the investigations, her age, weight, husband, male factor, everything one has to assess. And then one has to decide the protocol, one is going to stimulate her ovaries to retrieve the optimal follicles, like as I said, is 8 to 15. Then second phase will be trigger. So after development of the follicles, one has to decide which trigger one has to give. Usually trigger is decided also when one is deciding about the protocol. So that is already decided. When one is going to decide the protocol, one decides also the trigger. Only thing, the timing of the trigger one has to decide. The timing of the trigger will again depend upon the follicle size. And we are doing E2 levels on the day of trigger so as to definitely prevent the OHSS.
Sure, we'll come to that point, Dr. Ravindra, but for the delegates or the viewers, important 3 parts and 3 principles. We have to down-regulate pituitary, we have to stimulate ovary, and the third is a final oocyte maturation with ovulation trigger. So 3 important steps. And here, when we say ovarian stimulation, this physiology we have to understand every time when we start thinking about ovarian stimulation, and that is called FSH window concepts. So on the first on the second day, when the FSH is very low, then it starts rising. And once it crosses this threshold, and how long it remains up above this line, and for how much duration it is above this line, will decide how many follicles are going to be recruited. Like in natural cycle, once it crosses threshold, after 3 or 4 days, the FSH level starts falling down. Because of that sudden decrease in the FSH levels, you see certain follicles which are selected, but they go into atresia and only one dominant follicle remains. So we have to understand that when it comes to IVF and when it comes to ovarian stimulation, we have to keep this window broader, and we have to take the FSH levels more higher on the second, third, and most important 4th day, and because of which we get a multiple follicular grade.
So now our next question, it goes to Dr. Kedar. My dear friend Kedar, can you tell me what factors will you consider to decide starting dose of gonadotropins before ovarian stimulation? Kedar,
Yes, first is the age of the patient.
Yeah.
Second is the AMH, antral follicle count, weight of the patient, previous response, and is there any associated pathology like PID or endometriosis in the past? So on this basis, I will decide the dose of the starting stimulation.
So Dr. Vaishali, define those 3 categories of the patients for ovarian stimulation. Depending on these 3 categories, we do have a different protocols, what we call individualization. So can you define these 3 categories of the patients?
Yeah, we have 3 categories, that is the hypo patients, where the FSH and LH both and the estradiol both, all the 3 things are low. The second is the normogonadotrophic patients, where you have the FSH and LH and E2 in the normal range, which is the most common group that we have, which also includes the PCOD. And the third is the hypergonadotrophic, where you have the FSH is high and the E2 levels are low. These include the poor responders generally, which are having consistent high levels of FSH.
Kedar, anything you want to add 3 categories of the patients when you want to plan ovarian stimulation?
Can be a hyper responder, normo responder, or poor responder, or low responders.
Okay, Dr. Ravindra, can you define these 3 categories? How you can define this? Who is a low responder, and who is a normo responders, and who is a hyper responder?
Actually, to find out in which category the patient lies, one has to look for the investigation like AMH or day 2, day 3 FSH or AFC. So by these three things, one can find out whether, or if the previous history of stimulation, if she had,
Yes.
if she has undergone previously stimulation or IVF cycle earlier, then from that also one can find out.
So literature evidence says that poor responder is something who gives
is
us
less
less than 6
right.
oocytes. Normal responder is between 6 to 15 oocytes,
right.
and hyper responders who is predicted to give more than 15 oocytes.
Yeah, and
So we have
ovarian
to,
volume also one can add if
yeah.
one want to find out whether she is a hyper or even poor responders. When
Yeah.
the ovarian volume is less, then naturally she will be a poor responder, and when the ovarian volume is more than 10 cubic millimeter, then she will be hyper responder. So that's another thing one can consider while deciding whether she is a hyper or hyper responder.
Thank you. Dr. Prakash.
Goes to Dr. Parag Grote. Uh, Given a choice, which is the most reliable factor to decide and choose ovarian stimulation protocol? If you have decided what type of patient she is, so what stimulation protocol, what is the reliable factor? Dr. Parag. Dr. Parag, are you there? Dr. Parag Rote?
Is not there, I guess. So we can
Can Dr. Veena take this?
Veena?
Veena, are you there?
I don't see it. I think then Anaga, you can answer this
Sir,
question.
Dr. Veena is
So I think-
not able to join.
Yeah, no problem. Okay.
I think if you ask me only one factor, and probably the most reliable factor today is AMH, because ultimately success of ART depends on the oocyte number, of course, the quality, because the more are the number, it is going to take care of the inefficiencies in the human reproduction in the further stages, like the maturation, the fertilization, the implantation. So all these inefficiencies in the further steps will be taken care by the excess number of oocytes that I'm going to retrieve. So as Dr. Kulkarni said, because vitrification programs are running so good, we are aiming at the number at least between 10 to 15. So then AMH is the best guide because it is going to give you idea about the reserve. And along with that, if you ask me, the second would be AFC, because in AFC in the current cycle would tell me which how many oocytes are actually going to join the race and how many are most likely to come up in this particular cycle. So AMH and AFC could be the best if you have the ascending or the descending order.
Do we have Dr. Ajay with us? Has he joined?
Sir,
Dr.
Kundan,
Ashish, sorry, Dr. Ashish.
Kundan, about this AMH, actually this AMH is at times work very tricky, mainly in PCOS. She has got a good AMH, good ovarian volume, good follicle, but somehow we get stuck when we start the stimulation. That means maybe get stimulated up to 10 millimeter of follicle, and then beyond that it doesn't develop. So I agree with Anaga that, Anaga that is the main thing. But at times one should be aware that with PCOS, even the AMH and everything is good. Then even when one gets stuck while stimulating the ovary, and some of these ovaries do not respond, and we tried the maturation in vitro maturation also, but some ovaries have not worked.
So Vaishali, when will you like to do AMH assessment before ovarian stimulation? 3 months prior, 2 months prior, 1 month prior, or on the second day when you want to start ovarian stimulation?
See, first of all, let me tell you that I am a believer of AFC more than AMH.
Okay.
AMH does not vary much according to the cycle day.
Okay.
So you can do on any day of the cycle.
Fine.
I would prefer to do an AMH within a month before the start of the cycle. But as I said, always I give more importance to the AFC because that is what is going to be available.
All right. So as you rightly said, it is a kind of recent report is better and it doesn't vary as per the day of the menses. So fine. So how AMH levels will help you to plan ovarian stimulation, Kedar?
One more thing.
Suppose you have a AMH levels. 1 minute.
Kundan, one more thing. The AMH, what the literature said that AMH once done is valid for 6 months. So if it's done within 6 months, then one need not repeat the AMH.
Agreed. Okay. Kedar. So do you take a help of AMH for planning ovarian stimulation, or only for a diagnosis, or you decide some dose also according to AMH? Do you practice that?
only for diagnosis, not
Okay.
for deciding the dose. For deciding the dose, it is straightforward AFs, antral follicle count, age, weight of the patient, and previous response.
Great. So, friends, we know AMH is produced by granulosa cells of ovarian follicles and one of the very important parameters to assess the ovarian reserve. And with these levels, probably it is a supportive test which help us to categorize our 3 patients. So only for that purpose, it's more important. But yes, there are certain papers where according to the AMH and rest of the factors, what Kedar said, then you can actually, it helps to decide the dose, but it's not a very common practice in majority of the ART consultant. But when it comes to antral follicular count, I think that is something which all of us, we follow. On the second day, when we do this, we typically measure 3 to 7 millimeter follicle as antral follicles, and we scan from both ovaries and then calculate, and then we predict, looking at that antral follicular count in that stimulation cycle, that probably how many follicles are going to be recruited to your ovarian stimulation. And I think that is a cycle specific parameter. It differs in each cycle in same individual. So sometimes for that cycle, AMH may not help, but yes, the AFC is the one thing which is most reliable for all of us. So Dr. Prakash, you can take next question.
And then before that, before taking this question, I just wanted to add something
Sure.
before slide, because everybody has done day 2 FSH, day 2 E2, but does anybody do day 2 progesterone, day 2, day 3 progesterone, which will decide the further stimulation protocol? Anybody can
We do progesterone only in long protocol. We do progesterone and the day 2 after in the long protocol when she has received a antagonist, agonist, sorry, before that. And we know that if the progesterone is less than 1.5, LH less than 2.5,
yes,
E2 less than 50, then
my question is, if it is more than 1.5, what you do? Dr. Kedar?
I don't do progesterone on day 2 at all. I do an ultrasound. If there is a retention cyst or a corpus luteum cyst which suspects me that there can be a rise in the progesterone, okay, then and only then I will do it. And if the cyst or corpus luteum is there, then there's no question of starting the stimulation. So I will wait.
These latest evidences are there. If the progesterone is more than 1.5, you are supposed to give antagonist day 3 and day 4, and the stimulation we have to start from day 5. That is the latest.
So what is the source of progesterone? It has to be from corpus luteum. And what are you achieving? You are giving antagonist to suppress that particular progesterone. So in my ultrasound, if I don't see a corpus luteum at all, I find it very difficult that progesterone comes from somewhere else.
Kedar, but the appearance of corpus luteum is so much variable. It is better to do day 2 progesterone because sometimes
not at all. I don't agree with this. I don't agree with this at all.
Actually, what I think that when patient is on agonist protocol, then the agonists do not suppress the LH to that extent as they suppress the FSH. So LH activity is usually seen in long protocol or agonist protocol.
Fine.
So when the LH activity is there, naturally one expects some progesterone to be present in the circulation, which is not suppressed by the agonist. Okay. That's why one should do day 2 progesterone to find out whether there is an adequate suppression of the corpus.
No, but we have to be clear. We are talking about general principles of ovarian stimulation. These are special scenarios. I do agree with the points that rise in progesterone suggests to use an antagonist protocol. But in Farsi, we don't want to give a message that every second day you do progesterone. So you have a situation by transvaginal scans. Say you have a thick endometrium, patient doesn't have a proper withdrawal, or she has a corpus luteum, and sometimes you like to do this. But it's, as I say, on the second day, it's not compulsory to do a progesterone level. So that should be a clear-cut message. We can go to the next question, Dr. Prakash.
The next question, it is said many people they do. So I just put the question to all the panelists. See, next question is to Dr. Anaga. What is your cutoff for AFC and AMH to identify poor and high responders? Can you tell us the figure?
So that way, the definitions of poor responder is still not so clear. But vaguely, I would say AMH, by definition of Bologna criteria, is anything equal to or less than 1.1, we would consider it as a poor responder. And AFC, anything less than 5 to 7 would be considered as a poor responder. But of course,
what about high responder?
What is the cutoff for AFC and AMH in high responders? Kundan, can you show the next slide?
Yeah. Anaga, are you there?
Yeah.
Previous.
So I don't think so many such clear guidelines, but AMH anything more than 4.5 probably would be an indication for a high responder. And of course, AFC anything more than 15 would be a case for a high responder.
I think it's very clearly given there.
Yeah. And which protocol for Kedar? This question goes to you. Now we have decided according to the AMH, ovarian reserve or antral follicular count that I am dealing with probably a normal responders. Now I want to plan ovarian stimulation. So which protocol for down regulation? We understood 3 things: down regulation, ovarian stimulation, and trigger. So in normal responders, as a down regulation protocol, which one you prefer? GnRH agonist, that is day 21 protocol, or GnRH antagonist?
GnRH antagonist.
Okay, can you justify, I mean, what are those reasons why you want to give GnRH antagonist?
GnRH antagonist is a patient-friendly protocol.
Great.
It will allow the endogenous FSH and LH to act, so the drug requirement can be less. And it's a flexible protocol. And I may plan to do a freeze-all cycle if this response becomes a little excessive. So I can always give the GnRH agonist as a trigger.
So that is to prevent OHSS, right?
That's to prevent OHSS and achieve maturity.
Great. So this was the systematic review which Kedar has already cleared, that when you are dealing with normal responders, actually speaking, if you look at the pregnancy rate and look at the ongoing pregnancy rate and miscarriage rate, there is no difference in any of these protocol. You go for GnRH agonist, day 21 or antagonist. But it has been shown that if you are using GnRH antagonist, there is a significant lower duration of stimulation, gonadotropin doses, E2 levels are lower, number of oocytes are lower, number of embryos are, they obtain are lower, and incidence of ovarian hyperstimulation is significantly decreased. So, and these are the advantages because of which we are using antagonists rather than any pregnancy outcome. Next question.
Thanks. Next question is to Dr. Ravindra Kulkarni.
Yeah.
How will you use GnRH antagonist? How you what protocol you follow?
IVF, we are using fixed antagonist protocol. That is, we start antagonist from the day 6, and then we give antagonist daily.
Sir, day 6 of stimulation or day 6 of menstrual cycle?
Stimulation. Day 6 of stimulation.
Day 6 of stimulation.
He is telling that fixed protocol, fixed and flexible. He is following fixed.
Okay. Anybody who uses flexible protocol in panelists?
I use
only flexible. I never use the fixed protocol because so many of our patients require antagonist on day 8 of the stimulation, and then we don't want the down. The bad
you
effect
follow
of the antagonist.
blood levels, or you follow follicle size?
Follicle size by rule. And suppose the disadvantage of starting antagonist early in the cycle, that is the fixed day protocol, is that we are going to have the antagonist effect on the endometrium. So if you're planning to transfer the embryos in the same cycle, then starting an antagonist on the day 6, when the follicles are not yet 14 mm, 13 to 14 mm, that it will give you a disadvantage and your implantation rates might go down.
Okay, now this is the study where it has been used to compare these two protocols, and it has shown that flexible low dose protocol is as effective as conventional fixed dose GnRH antagonist protocol for most of the patient with a normal ovarian reserve. So it will not matter in terms of any outcomes. So both protocols are absolutely okay. If somebody is convenient with fixed day protocol and somebody is flexible, both are absolutely fine. It's your completely choice. So,
Kundan,
yes.
See, there are these patients who are polycystic ovarian.
No, this is normal responder, Kedar.
Okay.
Kedar, this is normal responder. So, next question to is Parag is not there, so I think Vinay is also not there. So maybe Vaishali, you can take this. What is your choice for ovulation trigger before oocyte retrieval in normal responders?
See, the choice of ovulation trigger will depend upon which protocol I am using.
Yes.
If I'm using an antagonist protocol, then obviously I'm going to use a, I would, and also depends upon the number of follicles that have been retrieved.
Yes.
If whenever I get a follicle count of more than 15, I go for freeze-all. So,
so what trigger you will see? Our viewers wants to practice this, so please give them a very clear answers.
Yeah, so I use decapeptyl.
Okay.
0.2 milligram. So it comes into 0.1 milligram. I use 2 of them.
Okay.
And retrieval is done about 36 hours. I do 36 hours after the.
That is if you're planning a frozen, freeze-all,
yes.
right? If it is a fresh transfer, then what you will give? Because it's normal responder. Sometimes you will plan that also.
Yeah, so I prefer a recombinant HCG, Ovitril,
yes,
250 micrograms. That is given as the ovulation trigger.
Okay. Now, this is what another evidence which I want to get it in front of all of you, that there is recent papers which are suggesting using a dual trigger, which is a combination of agonist as well as SCG, and they have shown that there is a significant increase in the implantation rate, clinical pregnancy rate, and live birth rate when it is dual trigger was given, and it was compared with only SCG. So somehow, if you look at the normal responders, especially normal responders, you have a choice, because there is a if there is a less likely that she's going to be in a severe ovarian hyperstimulation, you can go ahead and give dual trigger. But be careful, dual trigger, if it is a expected any anticipated ovarian hyperstimulation, then you can safely, as Dr. Vaishali has said. Dr. Prakash.
This again, the question goes to Vaishali. Dr. Vaishali, in the era of cryopreservation advancement, what is your opinion for normal responders? It is whether you will go for fresh ET or frozen embryo transfer.
See, nowadays there are many indications for which we are going for freeze-all. In normal responders, as I said, if I have more than 15 follicles, then I generally go for a freeze-all. But there are some other indications also that I might come across a small polyp during the stimulation I come across, or sometimes whatever, if there is PGS, or if I find the endometrium is not up to the mark, if I don't get, or if the progesterone is high. So there are so many indications which are.
Yeah, I want to stop you here. You're doing very good. But I just wanted to know that you have started your ovulation stimulation for fresh ET. But when you will convert it to frozen cycle, what are the conditions in which you will cancel the fresh ET and you will go for frozen embryo transfer?
So that's what I was saying. More than 15 follicles. If the progesterone levels are more than 1.5, if I find the endometrium compromised in whatever condition, either because of a polyp or it's thin or it's not, the flow is not good, then I will go for freeze-all.
Okay. Any other conditions like detection of polyp?
Yes, that I have already said, detection of polyp. Or
mention those conditions.
Vaishali, talk a little loudly. Vaishali, ask for a cup of coffee and get up. डॉक्टर पाटलांना कॉफी द्यायला पाहिजे डॉक्टर वैशालीला दोघे सेम इंडिकेशन बोलतायत.
Can I add a few more things? Ultimately, even though one gets 15 follicles or 14, whatever number, what is the number embryos, good quality embryos? So that will also decide. If you have got 1 or 2 embryos developing, then there is no point in going for the freeze. One has to go for the transfer.
No, but your decision has to be on the day of SCG, because you have to decide your trigger.
But if one may have to change the decision on day 2 or day 3 also.
But that's fine, sir, because that's a situational variation. So
right.
We are talking about general plan for normal responders. This study says that there is no difference in live birth rate in normal responders, whether you do fresh embryo transfer or you do an elective frozen embryo transfer. So I think there is no change. You can go ahead with, and I think Vaishali has pointed out right reasons that in those scenarios, you will convert from fresh transfer to frozen embryo transfer. So, Dr. Veena is not there anyway. So, Dr. Ravindra, you can take this. What do you feel about which type of gonadotropins is best one for PCOS? Now, we have finished discussion of non-responders. We are with the polycystic ovarian syndrome hyper responders. So, what gonadotropins? Only pure FSH or HMG?
Actually, we were long time believing that PCOS has got high LH. So we should use the gonadotropins which doesn't have LH. That means mainly the recombinant FSH. We should use those.
Right.
But sometimes you get stuck with the recombinant FSH also. And what has been come up is that the LH which is present in these PCOS is not effective. So even if one use the HMG for stimulation of PCOS, you are not going to end with the hyperstimulation, or you are not going to end with the less follicles or high progesterone. Is not going to happen. So even
Kedar,
for PCOS now one can
which
use.
gonadotropins you will use in PCOS, Kedar?
I use a combination in the first 4 days. I use a combination of
Kedar, can you please tell us in detail, like combination means what? Please tell the viewers properly.
Recombinant FSH.
Yeah.
If I'm going to use a dose of 300, then 225 recombinant, HMG 75.
And that is you start from second day.
Second day for 4 to 5 days. The day I start the antagonist, I stop the recombinant and switch over to HMG.
Okay, Vaishali, do you have any variations in your practice?
I also use a combination. Only thing is I don't go completely to the HMG after 4 days. I continue with more or less the same days I change to complete HMG on the day 7 of the stimulation. That is the only difference.
Okay, so friends, what evidence says. So as a viewer, we want to know that what should I start in PCO patients. So this is the evidence, especially Megaset HR trial, the largest multicentric trial has been done on 620 patients. It very clearly says that ovarian hyperstimulation rate is, if you look at even moderate to severe, it is significantly higher with recombinant FSH. As Dr. Ravindra mentioned, that it is lower with HMG. So HMG has got there some advantage. And if you look at the ongoing pregnancy rate, there is no difference between this. Or if you look at the early pregnancy loss, if you look at the chart also, there is a slightly higher miscarriage rate with recombinant FSH. So this study concluded that highly purified HMG, because of these two advantages, it is showing a better results and lesser OHSS rate. So it's probable they propose that appropriate treatment option for patients who are predicted to be higher responders. Dr. Prakash, next question you can take.
Suppose Ashish is not there.
Yeah.
Anaga, when IVF is indicated in PCO, can you answer? Start.
Yeah, so IVF is indicated if a PCOS situation, if there are associated factors, obviously male factor, tubal factor, endometriosis. But per se, PCOS alone can be an indication if everything else has not given her any success. I mean, the ovulation induction has not worked for her, and IUI have 2 or 3 IUI cycles have not worked for her, then probably we would take her up for IVF.
As a third line of treatment.
Pardon, sir?
As a third line of treatment. First, second, and
yes.
And second fails, you go for IVF in PCOS as a third. Okay. Which downregulation protocol is used in hyper responders? Dr. Kedar, please.
In my practice, I use oral contraceptive pill.
How long?
21 days. And most likely it's a hyper responder. So I have already decided it's a freeze-all cycle. So I give 1 or 2 days break and I start the stimulation. So it's not necessary that the patient should get a withdrawal period. And then I do my stimulation, and the trigger which I give, if there are facilities available after giving GnRH analog trigger, after 12 hours to do an LH, then only I'll give a GnRH analog as a trigger. Otherwise, okay, I will give very low dose of SCG, say 2000 with Lupride or GnRH analog as a dual trigger, even if it's a hyper responder.
Do anybody differ from these OCs?
Yeah, actually, what I think that it has been found that the downregulation is okay. So I would like to add that down regulation with OC is more suppression than only progesterone. So one can give 10 days progesterone. Second half, if she is having irregular cycles, then one can do a mid cycle scan, find out whether it's growing follicle. One can give 10 days of progesterone for the withdrawal and down regulation. And then when she gets the period, then you start the stimulation instead of putting her on OCs.
And this is very important. This is very important because if you down-regulate too much, you have to give a agonist trigger. And if you have to give the agonist trigger, sometimes it may not work because the endogenous FSH-LH is not available because of the down-regulation. Because I have seen this happening to one of my donors who was on OC pills prior to the cycle, and we gave the trigger and we didn't get any mature.
So that's very important, Vaishali, madam. You have brought up the point. See, if the patient is on for a long duration on oral contraceptive pills, this is the scenario which we might come across, that there won't be any release of LH due to GnRH agonist. But for giving one cycle of oral contraceptive pills, probably it will not affect that particular situation. It will not create majority-wise this situation that we don't have any LH surge because of agonist.
I want to say something.
Please.
If estrogen suppresses FSH, progesterone we are giving for withdrawal will suppress the LH. So anyway, the LH is getting suppressed in hypothalamo-pituitary axis.
It's the number of days. It's the number of days.
21 days of oral contraceptive pill.
Kedar, if you give it longer time,
I said 21 days. I said 21 days.
21 days they are not recommending. They say that it is given up to 10 to 12 days maximum, so that this physiological this is not suppressed, FSH and LH. So you get the follicles, but you don't get the oocytes. That's what, or you get immature oocytes. That's what it says.
So Dr. Ravindra, will you plan fresh embryo transfer or freeze all strategy in hyperresponders? Can you quickly?
My strategy is freeze all for all hyperresponders. All PCOS, freeze all.
Great. Kedar, you do freeze all for all hyperresponders?
Freeze all.
Great. Vaishali?
Yes.
Yes. So we are very clear on this ground that when we are dealing with hyperresponders, it is elective freeze all strategy for all the patients. So that is very, very clear, this thing. Now we go to the poor responder group, which is a third category. We have just 10 minutes left. So Dr. Prakash, you can take quickly.
Now, in poor responders, do you give any pre-treatment before IVF ovarian stimulation to get better yield, good quality and quantity of the oocytes? Dr. Vaishali.
There are two things I use. The commonest thing that I use is the 5 days prior to the starting of, like from day 24, 25, I start them on estradiol valerate for 5 days, and patients get their withdrawal. So I start the stimulation on the day of. This is just to get a equal cohort of follicles. That is one thing that I use. And if I have the liberty of 2 months time with me, then I give them ORS, that is DHEA, for 2 months prior to.
Do you give testosterone in these patients?
Sir, yes, I did use androtas gel, but recently I'm not using it because I had many patients, directly it mentions testosterone, and I had a lot of patients complaining that why are you giving testosterone? So I prefer using.
No, let's talk about science, not by patients. But no, forget about patient. But scientifically, what evidence says? Does it work?
And how long? When do you start and when do you stop?
It is believed to work only if you give it 60 days prior to the ovarian stimulation.
Okay. When do you stop?
Dr. Patil, if you are giving DHEA, okay, 75 for 3 months prior, 3 months prior.
I am not giving DHA.
No, I understand. So I am telling you DHEA can be given.
Yeah.
The most important is growth hormone. One should add growth hormone 2 units or 4 in the international units, either from day 21 of the cycle of the previous cycle or day 2 of the stimulation. And I put on estrogen the patients from day 21 of the cycle or post ovulation 7 days, and I continue till the time they get period, and I stop ovaries that day and then start the stimulation.
That is very important point, Kedar.
That slide is coming up, Kedar. That slide is coming up regarding the growth hormone. but we were talking about testosterone. Anybody is giving or not?
No, I use testosterone, but I am not very confident whether it is going to work or not. Because, but they are poor responders. So I have tried testosterone in the same patient, and if she has not responded, very few follicles got not good quality of embryos developed.
This trial is shown there on the slide.
Yeah,
There
I
are
know.
two groups. They have received testosterone gel. First group and second group, they have received placebo gel. And the pregnancy rate, clinical pregnancy rate was good in testosterone gel group. So it is proved that if you give testosterone gel from day 2 of previous cycle till the day 2 of the next stimulation day, the results are better and promising.
Sir, the study showed only 25 patients in each
Yeah,
arm.
but that is the one comment at the base. That it is a
25
very
patients.
small, yeah, only small group.
Agreed. Agreed, but it's a single blinded randomized control trial. I understand we cannot take this evidence as a compulsory, but there is a evidence which says that in testosterone gel patients compared to placebo, here we're not comparing DHA or testosterone, but with placebo, these patients have done well. And this poor responder group is selected by a Bologna criteria.
I
So
have a
think-
question for Prakash Patil. How do you use testosterone
Kedar, you
gel?
are not
when-
allowed to take
No, we are also allowed.
No,
Sir,
no.
सब लोग मेरे पीछे आओ.
So, Anaga, what protocol you will like to offer for ovarian stimulation in poor responders? Quickly, we have a really short of time.
See, evidence does not support any one stimulation over the other, but my personal choice is antagonist because you retain the
Yeah. So you use GnRH antagonist for all poor responders. Agree?
Yes. Yes.
Okay. Any panelists differ or you accept all these things?
No, I agree.
Okay.
Antagonist for the poor
patients of-
responders.
In some patients,
It is most of the times, but only the endometriosis, severe endometriosis,
Okay.
and less poor responders, less number. I had used long protocol.
Long protocol. I agree. That's because of endometriosis you are saying, right?
Yeah.
Again, what will be your starting dose of gonadotropins in these poor responders? Kedar, again, I am asking you.
My standard dose is 450 IU.
Of
Poor
this
responder,
gonadotropin.
HMG.
Good.
450
And
IU.
And if it is recombinant FSH, then?
No, I don't use recombinant for poor responders.
Okay, who uses recombinant FSH here for those patients? Nobody?
So we are using HMG.
HMG.
For this session, the sponsor is HMG.
Kedar, come on.
Sorry.
Okay, coming to Dr. Ravindra, growth hormone in poor responders. Will you use in all poor responders? And if yes, how do you use it? So all poor responders.
I'm
Should
not
we use
using
it or
all
not?
poor responders, but I have used in some cases, and usually I'm using 4 international units per day for a period of about 15 days. That before she gets the periods, it's from the -1 cycle, one can start in the mid cycle and continue for 15 days till she gets the withdrawal. But I have got difference of responses. I have tried the same, that means this growth hormone in the same patient, and again the testosterone in the same patient, and I got a different response. Initially she didn't respond to growth hormone, so afterwards I gave her testosterone, and then I got a good response. So I'm not very confident whether the growth hormone is going to really help or not.
Okay, Anaga.
Yeah, may I say something? There is enough evidence to support growth hormone use. Not that I have used it very widely, but in some of my patients I have, and the theory behind it is probably it stimulates the ovaries, and secondly, it achieves a better synchronization of cytoplasmic and nuclear growth in the oocyte, which is probably a problem in poor responders where they have poor quality as well as poor numbers. So I think growth hormone we should do our own study and find out, because
Yes. So what is the current evidence from growth hormone is that yes, if you use growth hormone, there is likely that you will get little more extra eggs because of use of growth hormone. But this study, which is a randomized trial in 2019, they wanted to study whether it is improving the reproductive outcome, which is not. So, we have to take, still we are not very clear evidence whether it is very 100% useful. and we should use it for all the responses. That's the answer. Yes.
Dr. Veena is not there. Dr. Anaga.
Yes, sir.
What is your choice, fresh ET or freeze-all strategy in poor responders, not in high responders, but in poor responders? Do you go for fresh ET or freeze-all?
So in poor responders, it is always a challenge to achieve 3 good quality grade 1 embryos in one cycle. So many times I counsel my patients that probably you should be ready for 2 stimulations, 2 pickups, and then probably we'll get more chance of getting a blastocyst or at least good quality grade 1 day 3 embryos. So generally we would counsel the patient for 2 stimulation and hence freeze-all in the first cycle. But if it depends on the situation and case to case.
Can I add something?
Yes.
Kind request, sir. We are about to finish. We've got the valedictory here and everybody's ready. So if you could sum it up in the next 30.
Nikhil, how many minutes we have?
Sir, actually we have finished our time, sir, to be very honest. And now we are 2 minutes delayed.
Okay, can you give us 1 minute to summarize?
Yes, sir.
Thank you, Nikhil. Thank you so much. So just to brush up, I think we have to move on quickly, Dr. Prakash. So I think, so just to brush up, I don't want to ask questions to panelists, but whether can we use recombinant LH in ovarian stimulation? So I think there is no significant difference in terms of number of oocytes, implantation rate, miscarriage rate, and clinical pregnancy rate. So slightly, this is again a randomized control trial for a patient who are more than 35 years. So recombinant role in poor responders is little still evidence is not supporting. Which drugs are to be used for final oocyte maturation? We have all 4 options, but 3 are the most common use. You use urinary and recombinant. It doesn't make any difference. Yes, dual trigger is something which is giving us a better clinical pregnancy rate and ongoing pregnancy rate. So another question was, what is your opinion about dual stimulation? In which clinical scenario will you use? So friends, it is meant for fertility preservation where we have a very short time. But a recent study says that there is a scope of using dual stimulation in even poor responder. So we have already discussed these points. That was just a summary of it. So take home message is, so Dr. Prakash, you can say some take home message to the viewers.
Is locked off.
Okay, so ovarian stimulation is an art to be developed over the time period, learning from our own cases, understanding how each patient responds in a different way to your stimulation protocols. So aim of ovarian stimulation is to get good quality oocytes and sufficient number without much complication. So we have to remember the complications. And you take a use of ovarian reserve predictors, identify your category of the patients and use optimized ovarian stimulation protocol, which we discussed. So one size do not fit to everybody. We have to individualize the stimulation protocol for optimum results. So it takes only a moment to say thank you, but your thoughtfulness will be remembered a long time. To my panelists, I really thank you for giving a very focused, kind of messages. Though we could not finish in time, but I know we have covered this vast topic in a really 45 to 50 minutes. Thank you very much, panelists, and thank you, Dr. Harshit Parasnis and Dr. Ashwini Kale, for giving us a chance to moderate and participate as a panelist. Thank you very much.
Thank you so much. I would again like to thank the moderators and the panelists for being there and giving us a valuable time. Immediately, I would now like to move to the valedictory session. And I request the MOC, Dr. Ashwini Kale ma'am, to take the proceedings further.
Good afternoon, everybody. As we come to the end of the conference, I would like to invite on stage Dr. Harshit Parasnis, President POGS, and Dr. Chaitanya Ganpule, Clinical Secretary, Dr. Prakash Kothare, Treasurer, to preside over the valedictory. So we have had a fun-filled, academically packed 3 days of this conference, where on Friday we started with 4 workshops running simultaneously. And we received a stupendous response of 2,500 registrations for the conference. So I think this deserves a round of applause. Delegates joined out of India from over 30 countries. So it was a unique conference in itself, our POGS annual conference, Re-Edify 2021. the first of any of the OBGY society to have a hybrid conference. We started our first day with 4 workshops, and then on Saturday we had plenary session wherein we had 4 talks, and the entire conference was all about panel discussions, which was enjoyed by all. The inauguration was done by the hands of a chief guest, Dr. Alpesh Gandhi, President Foxy, and the guest of honor was Dr. Nozer Sheriar, who is the past Secretary General of Foxy. Then we had wonderful panel discussions running simultaneously, 6 panel discussions, and then 6 debates, which were equally interesting. We began our Sunday by the plenary MSR oration by Dr. Anuja Dokras, who joined us from US. And then we had plenary oration by Dr. Anjanelu oration by Dr. Amarnath Bhide, who joined us from UK and spoke on prenatal diagnosis. Past president oration was given by Dr. Dilip Vaike. And then we ended up with equally interesting panel discussions. I think I should take this opportunity to thank our team, President POJ's Dr. Harshad Parasne sir, who gave us complete independence to decide about the program, the faculty, everything. And an equal thank you to Chaitanya and Prakash sir, who've always stood by me. I now invite Chaitanya to give the vote of thanks. I'm so sorry. I request Dr. Harshad Parasne sir to say a few words.
Yeah, thank you. Nirav, can you change this total registration thing? Stop that. Yeah, thank you. Yeah. Thank you. Thank you very much to all the delegates, faculty actually for attending this conference. Most important, actually, what the thoughts which come to my mind are that this was supposed to be a physical conference, and at the last moment we had to actually make it hybrid because of the COVID situation, which again has started rising. And even then, there is always a silver lining to any dark cloud, and that was that because it was a virtual conference, we could actually go and show it this conference could reach out to delegates, nearly 2,500 delegates, which actually registered, and that itself was an achievement for us. Secondly, this is the first time any Foxy society is doing a hybrid conference. We complete the hat trick of doing 3 first in our year. The first virtual conference, the first conference, international conference by any Foxy society, wherein we had more than 5 halls running at the same time. And the third is the first hybrid society conference by any society, Gynaec society of Foxy. So I think that itself is an achievement, and that deserves a round of applause. I know I can't be hearing those. Yeah. And again, as far as this conference is concerned, I must appreciate that even at odd hours, Dr. Anuja Dokras from United States and Dr. Amar Bhide at odd hours actually were ready to give their orations and did a wonderful job. Thank you once again, everybody, for participating and making this conference successful. I now hand over back to Ashwini.
Thank you, sir. We must indeed thank the delegates and the faculty who've logged in with us for 3 days. I now invite Chaitanya to give the vote of thanks.
Thank you, Ashwini. We have come to the end of this academic extravaganza, and I have been given the task of proposing the vote of thanks. I would like to start by thanking our chief guest, Dr. Alpesh Gandhi, our guest of honor, Dr. Nozer Sheriar, I would also like to thank Dr. Anuja Dokras and Dr. Amarnath Bide for giving the Anjanelu oration and the MSR oration. I would also like to thank ICUG Chairperson Dr. Mandakini Megh and ICUG Secretary Dr. Parag Binniwale for giving us the credit points. I would like to thank all the faculties who were there throughout the conference for their inputs. I would also like to thank all the delegates who had logged in for this conference. We had more than 2,000 delegates which were registered for this conference. I would like to take this opportunity to thank the pharma for their academic support. I would like to thank GSK. I would like to thank Abbott, Lilac Insights, Sun Pharma, Imcure, and Zydus for all their supports. Thank you so much. I would also like to thank Ali for giving us the audio visual support for this conference. I would also like to thank Mice Ideas for giving us the support, technical support. I would like to thank Nikhil for being the master of ceremony for this conference. And lastly, I would like to thank Renuka ji because she has been working relentlessly for this conference for the last almost 15-20 days. And I would like to thank the management of Hotel Grand Sheraton for making the venue available and for the hospitality they have shown. At the last, I would also like to thank Harshad sir for giving myself the opportunity to being the clinical secretary for this year, and Ashwini and Prakash for being my buddies. Thank you so much. Thank you and have a wonderful weekend.
Nirav, you can stop the recording and end the meeting.